بسم الله والصلاة والسلام على رسول الله وعلى أهل بيته الطيبين وأصحابه ومن والاه. I would like to welcome you all in this 2021 hematopathology overview, which is a hybrid meeting so far, very successful in the last one day, and hopefully it will be successful today too. I would like to welcome everybody, virtual attendees and speakers and moderators and physical attendees in this conference. Today's or this year hematopathology overview is brought to you with different flavors. This year hematopathology overview has total of four sessions divided into malignant and benign hematology, transfusion, and a flavor of COVID impact into our practice. This impact will stay with us for some time, I believe. So we have this year almost 13 presentations presented to you by the finest practitioners and hematopathologists across the country, from coast to coast, south to north. And these will share with you their practice, valuable, I believe, and I hope you enjoy it and benefit from it. And feel free to drop your questions into the Q&A part in the virtual screens. Without further ado, I would like to welcome the first moderators to present the first session of this presentation of this conference, Dr. Ayman Mashi and Dr. Al-Garni. Thank you very much.
Thank you very much, Dr. Ammar. Assalamu alaikum wa rahmatullah. In the beginning, I would like to thank the SPMT for giving me this great opportunity and for the excellent organization for this conference. We will start now with our first session. We're going to have in this session 3 talks going to be presented by 3 distinguished speakers. Each talk is about 30 minutes, divided to 25-minute talks and 5 minutes for the Q&A. We will start now with the first presentation, going to be presented by Dr. Mansour Al-Jabri. Dr. Mansour is a well-known consultant and associate professor of hematopathology and transfusion laboratory, and as well as the chairman of pathology and laboratory medicine at the College of Medicine and King Khalid University Hospital. He has been active in a number of research and peer-reviewed journals. Dr. Mansour is going to deliver a talk about diagnostic approach of acute myeloid leukemia. Without further ado, welcome Dr. Mansour. Mic is yours.
Assalamu alaikum. First of all, I'd like to thank the organizing committee for this kind of invitation, and I hope my lecture will meet their expectation. So in the next 30 minutes, inshallah, I will talk about diagnostic approach of acute myeloid leukemia. I try to summarize it as much as I can, because, you know, this is a very long topic. You know, acute myeloid leukemia, as a definition, is an aggressive clonal hematopoietic disorder derived from either hematopoietic stem cells or lineage-specific progenitor cells, which manifest as accumulation of abnormal myeloid blasts in the bone marrow, in peripheral blood, and sometimes in extramedullary hematopoiesis. It manifests as bone marrow failure, anemia, neutropenia, thrombocytopenia, and it might manifest also as organ infiltration, hepatosplenomegaly, and lymphadenopathy in some rare occasions, which will interfere with the normal function of those organs. As you know, acute myeloid leukemia is a hematopoietic stem cell disorder, and hematopoietic stem cell disorder is the mother of the cells that has self-renewal capability and differentiation capability. And if the mutation occurred in the common progenitor, it might give us to mixed lineage or acute leukemia of ambiguous lineage. However, if it is occurred in lymphoid progenitor, it might give rise to acute lymphoblastic leukemia, and sometimes if the mutation leads to accumulation of lymphoid cells, it will give rise to lymphoma, but it is beyond the scope of the lecture. What we are talking about actually in this square, if the mutation occurred in the myeloid progenitor, which will give rise to different type and different subtypes of acute myeloid leukemia, and myeloproliferative neoplasm, if the mutation leads to accumulation of more mature cells like eosinophils, neutrophils, and so on. So quick insight about the pathogenesis of AML, and leukemia and cancer in general is truly multifactorial disorder in which no factor is sufficient to cause, no single factor is sufficient to cause leukomogenesis. However, it will accumulation of those multiple factors will lead to genetic alteration in the mature precursors, manifested as translocation, sometimes inversion, or sometimes genetic mutations, which will lead to the phenotype that we know, that we see in the peripheral blood and see in the bone marrow, and it will manifest it as the clinical feature of acute myeloid leukemia or cancer in general. So by one of the three mechanisms, sometimes by the three mechanisms together, it will lead to accumulation of the blast in the bone marrow and the peripheral blood. Those mechanisms, it's either block of differentiation through some oncogenes like FLT3, c-KIT mutation, RAS, KRAS, which will lead to block of differentiation, so accumulation of the blast and prevention of the differentiation process. Again, it might lead to decrease of apoptosis and epigenetic modification through mutation in IDH1, IDH2, which will lead to recruitment of histone deacetylases. Enhanced proliferation, and the best example here is some balanced translocation like BMR-RARA and A221. So it will lead to the morphology and the clinical feature that we are seeing and dealing with in acute myeloid leukemia. The classification of acute myeloid leukemia in general, according to the WHO, it has been subcategorized to maybe 6 categories based on several diagnostic tools that has to be applied strictly for consensus between hematopathologists and also consensus between the center. The first category is AML with recurrent genetic abnormality, which include any recurrent genetic abnormality that has a unique clinical pathological signature in prognosis and diagnosis, and also in monitoring of the disease, like translocation 1517 and 821 and so on. And recently, WHO has recognized nucleophosmin as CABP and RONOX1 as entity, and some of them are provisional entity. Second is AML with MDS-related changes, which include any case of acute myeloid leukemia when the blast exceeds 20%, and the patient has significant dysplastic changes, or if he's from background of MDS, or if the genetic study shows that he has some MDS-related genetic abnormality. Therapy-related AML, which is a very poor prognostic type of AML, if the patient have history of previous chemotherapy or radiotherapy. Myeloid leukemia associated with Down syndrome, which is associated with Down syndrome, and it has 2 categories, and we will talk in details later about it. AML not otherwise specified, which is the previous FAB, as you know, when you cannot fit any one of I mean, it does not fit to any one of the recurrent genetic abnormality or the previous category. Myeloid sarcoma, when there is extramedullary blast of myeloid origin. Now, actually, WHO relies on, relies on some important diagnostic tool that has to be applied strictly. It includes clinical features, morphology, chromosomal karyotype, molecular study, and immunophenotyping by flow cytometry or immunohistochemical stain. The role of clinical features actually is limited to three types of then three subtypes of acute myeloid leukemia, which is the presence of Down syndrome, which will qualify the disease to be myeloid proliferation of Down syndrome. And if the patient has history of MDS, it will automatically place him in the category of AML with MDS-related changes. Or if he has history of cytotoxic therapy or radiotherapy, he will be classified under category of therapy-related AML after applying the diagnostic algorithm. The morphology is a powerful tool, and it is the primary tool actually for identification and diagnosis of acute myeloid leukemia. And it has, we have to obtain proper sample, and it has to be fresh sample, and it has to be obtained from the patient without any previous therapy. Whether we obtain the sample from peripheral blood, or we obtain it from bone marrow or a liquid biopsy. Again, so the morphology is the primary. It is the gate actually in the classification and diagnosis of acute myeloid leukemia. It will help us in enumeration and identification of blast count, and it will help us in early recognition of aggressive subtypes like M3, in which we should give the patient ATRA, and we should treat him to prevent the complication like DIC. Identification of myeloid blast feature like our roads, which will help us to guide the immunophenotype and sometimes the molecular panel. Differentiation of blasts and blast equivalent from mature cells, which is clearly apparent in monocytic lineages, in which we need to differentiate between the monoblast versus promonocyte and abnormal monocytes. And it helps us to properly ordering of ancillary tests like flow cytometry, immunophenotype, which panel we should use, and also genetic study, which panel we should use. And it helps us also in identification of non-blast features like multilineage dysplasia and eosinophilia. Cytochemistry actually has no role in the diagnosis of AML. However, it is still useful in case of iron study, because when we need to determine if the patient has some dysplastic changes by presence of ring sideroblast. Now, in the era of immunophenotyping by flow cytometry and immunohistochemical stain, it has no role actually in the diagnosis and classification of acute myeloid leukemia. Flow cytometry is one of the most powerful tool and essential tool in classification and diagnosis and monitoring of disease, and also prediction of prognosis and the target presence of target therapy, such as anti-CD20 or anti-CD38 in multiple myeloma. We can enumerate the blast. We could identify the blast. And when we enumerate of the blast, we have to know that it has some advantage over the manual count. However, it has its own drawback and disadvantage of during, if you use, the count of a blast by flow cytometry. Subclassification of acute myeloid leukemia, specifically the NOS or non-otherwise specified, and detection of antigen associated with prognosis like CD56 and some other markers, assessment of minimal residual disease. So now, what are the things, in which condition you could rely on flow cytometry, and what are the conditions in which we have like false and negative or false positive in calculation and enumeration of the blast using flow cytometry? Because still we know that the manual count as the gold standard for counting of blast. So flow cytometry count might be less than manual count if you have dilution of flow cytometry samples, specifically if you send the second sample for the flow cytometry and the first sample for manual count. Lack of expression of immature markers, if you if you start calculating the blast using CD34 or TDT or sometimes 99 and T-cell ALL, and some blasts, we know that some blasts are not expressing CD34, like some monoblast, some megakaryoblast. It might lead to false reduction of blast by flow cytometry compared with manual count. Some blast equivalent are not included in the blast count, like pro-monocytes, sometimes pro-myelocytes. The manual count might include some normal immature precursors, like hematogones or sometimes regenerating myeloblasts. And so what are the conditions in which flow cytometry has higher than the manual count and blast enumeration? The lysis step for RBC might remove some erythroid precursors. Some technicians who have like rigorous lysing for the RBC, he might remove erythroid precursors. So falsely, it will lead to elevate of number of blast. And sometimes by manual count, the blast might be difficult to be recognized, especially in case of dysplasia or post-chemotherapy. And the last condition, which apply mainly actually with acute myeloid leukemia with multi-lineage dysplasia, in which hypogranular mature myeloid cells might fall in the blast region. So if you just use the blast region to calculate the blast by flow cytometry, it might lead to falsely elevation of the number of blast. Blast identification is the key feature in diagnosis of acute myeloid leukemia. So I will give quick insight about the most common type of blast, like myeloblast. You can see 2 hour roads, thin hour roads, which is usually associated with translocation 821. Myeloblast is large nucleus with fine chromatin, prominent nucleoli, and variable number of cytoplasmic granules, plus minus hour roads. And the classical immunophenotype for myeloblast is positivity of CD13, 33, MBO along with CD34. Promyelocyte, which is equivalent to blast only in acute promyelocytic leukemia, as large cells with irregular eccentric nucleus, slightly condensed chromatin, abundant cytoplasm, and it might contain multiple hour roads, which is the phagot cells. And the classical immunophenotype for it is bright positive for MBO and negativity of CD34 and HLA-DR. Monoblast is the largest cell maybe in the bone marrow among the blast, excluding the megakaryoblast. It is large cells with round and oval nucleus with prominent nucleoli, and usually the cytoplasm is slightly basophilic and it might contain occasional vacuoles. And the classical immunophenotype for it is positivity of CD13, 33 plus minus CD64 and CD4. Sometimes we have to differentiate between monoblast, pro-monocyte, and abnormal monocytes. In pro-monocyte, CD64 is brighter than monoblast, and CD14 again is brighter compared with monoblast, but CD34 is usually negative. This is pro-erythroblast, which is positive for E-cadherin and positive for hemoglobin A. And it is blast equivalent only in case of acute erythroid leukemia. Megakaryoblast with distinct plebs, and it is positive for CD61 and CD41. So now I will go to the main topic here, which is the diagnostic algorithm, how to assign any case to its subtype. Now, when we do the morphological assessment plus immunophenotyping using flow cytometry or immunohistochemical stain, we have to evaluate the case. If there is no myeloid immunophenotype, it is not AML, and we have to behave according to the immunophenotype. And if the immunophenotype is a blast, myeloid immunophenotype, we have to do the proper counting for blast count. If the blast is more than 20%, this is acute myeloid leukemia for sure. And if it is less than 20%, we have to double check the cytogenetic, specifically the recurrent cytogenetic abnormality, in which we could label the patients as acute myeloid leukemia, regardless the number of the blast count, which is A21, aversion 16, or BMR rara. And again, we have to double check the history of the patient. If he received cytotoxic therapy, he will be qualified as therapy-related AML, whatever the conditions that he has. Sometimes if he has translocation A21 and he has history of cytotoxic therapy, he will be qualified as therapy-related AML with notes that he has translocation A21, because usually the prognosis is very poor, whatever cytogenetic that he has. Now we need to go to the history, and we need to double check it. And this is why we are emphasizing that we cannot diagnose any patient without proper history. So we need to double check the cytogenetic. If he has any one of the recurrent cytogenetic abnormality, he will be labeled as AML with recurrent cytogenetic abnormality, whatever morphological features he has. If he has Down syndrome, we need to double check the morphology, and also we need to do the GATA1 mutation just to label him as Down syndrome related myeloid neoplasm. AML with multilineage dysplasia or MDS related changes, if he has pure MDS or MDS/MBN, or he has MDS related abnormalities like significant dysplastic changes involving more than 50% of the lineage, he will be considered as acute myeloid leukemia. Now, the mutational analysis and the genetic analysis, if the patient has like normal karyotype, we have to do the mutational analysis just to double check the CAPPA, RONOX1, and nucleophosmin. And if he has any one of those genetic abnormality, he will be labeled accordingly. And we have, again, to pay attention to MDS-related changes, MDS recurrent genetic abnormality. And if he has any one of MDS recurrent genetic abnormality, you need to go back and to diagnose him as AML with multilineage dysplasia. And mutation analysis for prognosis will be done for him. Now, quick slides about the therapy-related AML. Therapy-related AML is any AML that occur after cytotoxic or radiation therapy for malignant or non-neoplastic conditions. It has been divided according to the latency period of AML post chemotherapy to short latency therapy-related AML. And usually it is associated with topoisomerase 2 inhibitor like etoposide, in which the disease occurs usually after 2 to 3 years, and it's often associated with monoblast or myelomonocytic leukemia with MLL mutation. Long latency therapy-related AML usually occur after alkylating agent, and it is usually associated with multilineage dysplasia and complex karyotype. Prognosis is very poor as a result of drug-resistant and limited tolerance to chemotherapy. And if you see this case, this is one of our cases. He's 4 weeks old infant presented with fever and jaundice, and he has mild hepatosplenomegaly and no lymphadenopathy. And he has mild leukocytosis and mild anemia and thrombocytopenia. And if you see his peripheral smear, he has around 33% immature looking blast. And if you see the morphology, if you see cytoplasmic clipping on the cytoplasm, so we have to think that we are dealing with megakaryoblast. We did the bone marrow and we discovered that he has multiple large blasts with distinct bleb, as you can see here by arrow, along with significant dysplastic changes in the megakaryocyte. If you see the white arrow, it is pointing toward this plastic megakaryoblast. So he has 60% blast with significant dysplasia involving only the megakaryoblast, while erythropoiesis and granulopoiesis is normal. By flow cytometry, he has 53% blast, which are positive for CD45, CD7, CD33, 41, and 61. So when we do the karyotype, we discover that he has trisomy 21, and he has also GATA1 mutation. So he has been labeled as transient abnormal myelopoiesis. So what is the... Sorry? Okay. Excuse me. Okay. So my voice is clear now?
Yeah, it's clear. Go ahead.
Yeah. So, are there any way to differentiate between transient abnormal myelopoiesis and myeloid leukemia associated with Down syndrome? Usually blast by morphologies are indistinguishable, in fact, but in transient abnormal myelopoiesis, it is usually associated with isolated GATA1 mutation. And you should not see any complex karyotype or any translocation, recurrent translocation associated with AML, like translocation 122. If you see any complex karyotype, this is myeloid leukemia associated with Down syndrome, and it is not transient abnormal myelopoiesis. By morphology, usually transient abnormal myelopoiesis is associated with dysplasia in megakaryocytes only. It is not associated with multilineage dysplasia. AML with recurrent genetic abnormality, and it is well known, so I don't think that I will add too much to you by talking about those very famous recurrent cytogenic abnormality. However, if you see AML with translocation A21, and if you see it resulted RONOX and RONOX1 mutation and presence of A21.
Dr. Mansour, 3
yes?
minutes. 3 minutes remaining.
3 minutes. Okay, I will go to the inversion 16. You can see inversion 16 is associated with myelomonocytic blast, and usually it leads to high DAC and recruitment of histone deacetylation and the block of differentiation. AML, and I will not talk about this one. I will show you just a very interesting case here. If you can see here this flow cytometry histogram, you can see here by site scatter CD45, you can see two population of blast, the red blast and also the green one. And if you, when we actually test them with flow cytometry immunophenotype, we discovered that we are dealing with myeloblasts, which are positive for CD34 and positive for 117 and positive for CD33, and we are dealing with basophils, in fact. If you see, it is positive for 123 and negative for CD34, and we discovered that we are dealing with AML with translocation 6-9, which is commonly associated with basophilia, and it is usually associated with poor prognosis. You can see this is the morphology of this immunophenotype. AML with genetic abnormality like mutated nucleophosmin, you can see the cup-like nuclear inclusions. AML with biallelic mutation CAPPA, it is usually associated with myelomonocytic leukemias, and it is of good prognosis. So I don't have time to talk about it, and I will go to the pure erythroid leukemia because they keep changing the definition of pure erythroid leukemia. And if you can see those blasts, those deeply basophilic blasts, and the bone marrow biopsy is totally infiltrated by those poorly undifferentiated pro-erythroblasts. CD34 is more is commonly negative. E-cadrine is the strong positive in early precursors. And if you see glycophorin and CD71 are both positive. So this algorithm, it will help you to identify any erythroid leukemia, or sometimes whether you are dealing with MDS or therapy-related AML, or you are dealing with pure erythroid leukemia. If you have erythroid hyperplasia and more than 50% and dysplasia, you have to exclude the non-neoplastic conditions, especially erythropoietin therapy, sometimes folate and B12. If you have exclude the reactive causes, you have to do the recurrent cytogenic abnormality. If any one of the recurrent cytogenic abnormality, the diagnosis should be changed accordingly. History is very important. MDS-related changes has to be excluded also. We do not need now to calculate the blast out of non-erythroid cells, because if the blast is less than 20%, this is MDS with excess blast. Pure erythroid leukemia will be labeled only if you have more than 80% erythroid precursors and with more than 30% pro-erythroblast. Okay, acute megakaryoblast leukemia is commonly presenting with large megakaryoblast and severe thrombocytopenia, and CD41 and CD61. This is one of my cases, actually. If you see the morphology here, as poorly differentiated blast with microvacuoles in the cytoplasm, and the flow cytometry was positive for CD4 and 56, and CD4 is bright positive with the HLA-LDR, so it was plastic plasmacytoid dendritic cells, which is the last one. So just to sum up and to summarize, the application of diagnostic tools for acute myeloid leukemia. For morphology, the material used here is bone marrow aspirate biopsy, peripheral smear, or bone marrow aspirate sometimes. So morphological assessment is quite useful in AML diagnosis and AML subtyping, but it is not of benefit in predicting the prognosis or identifying the treatment therapy. Cytochemistry can help in AML diagnosis, especially if you are an under-resourced lab. Immunophenotyping for flow cytometry or immunohistochemical stain is quite useful in AML diagnosis and AML subtyping also, and it is quite helpful in identification of target therapy. Chromosomal analysis is quite useful almost in all stages of the diseases, starting from diagnosis until identifying the treatment target, and also in MRD assessment. Mutational analysis using next generation sequencing, it is not useful usually in diagnosis, but it's quite useful in subtyping and predicting of prognosis and target therapy. Laboratory tests, usually they are quite helpful in predicting of prognosis. So just to conclude, the diagnosis of AML, it involves multimodality approach involving integration of history, clinical presentation, and new lab results for better characterization and classification. And the classification in turn provides valuable information regarding the prognosis and identification of treatment target. So sometimes it's quite difficult to summarize everything and to summarize almost half of your daily work on 30 minutes. So I hope that I do my best to summarize all the aspects of acute myeloid leukemia, and thank you.
Thank you very much, Dr. Mansour, for this excellent presentation. I cannot see any question in the Q&A, so we may proceed for the second talk. Thank you again, Dr. Mansour. Next, it's my pleasure to introduce Dr. Haytham Khougir. Dr. Haytham, he did a training and postdoctoral fellowship in hematopathology and leukemia, lymphoma, and molecular genetics at MD Anderson Cancer Center. He is a consultant hematopathologist at King Faisal Specialist Hospital and the former hepatopathology training director. Dr. Haytham is going to present a topic about titled with molecular pathological finding in neoplastic hematology. Welcome, Dr. Haytham. Mic is yours.
Assalamu alaikum. Thank you for this invite. Thank you for this invitation. So this is my disclosure. So what I thought I would do today is starting broad and then get into some specific vignettes using disease that I think a lot about in my daily practice, and also to continue what Dr. Mansour he start with, which is acute myeloid leukemia, as a specific example of some of the things that we have learned in the past few years, and which was the first step for discovering a target therapy. So we'll start with the classification, genomic landscape, what are the age difference in mutational landscape, mutation evolution, clonal hematopoiesis of indeterminate potential, which is very important topic. And at the end, I will end my talk with some take-home messages for my colleague and fellow and resident. So in line with the new era of medicine and medical technologies, all of us believe on the precision medicine as an ideal clinical practice, where we really need to match a patient with a specific therapies based on specific alteration in their health and disease status. I think we reach to this belief because of the significant advances that have been achieved on the pathophysiological and genetic knowledge of numerous diseases because of the innovative genomic applications. So this figure summarizes the timeline of various milestones in the evolution of the genomic classification of AML. As you know, AML was classified initially by FAB in 1976 based on the cell lineage of the leukemic cells and their differentiation status derived from the cell morphology as well as cytochemical staining of the bone marrow cells. Then the discovery of the recurrent cytogenetic abnormality led to a novel classification system by the WHO at 2001. 2008 classification reflects the significance of new molecular insight that have become available since 2001 and opened the door to include genetic abnormality as a criteria for classification at that time and also in the future. So the current classification 2016 acknowledged that the genetic abnormalities can be used as an objective criteria for defining of some entities and as a target for some approved chemotherapy. So this is AML based on the classification based on WHO 2016, but I want to mention the diagnostic karyotype remains the most powerful prognostic indicator in AML and form the basis of the current diagnosis and prognostic score. To give an example quickly of the key rules of cytogenetic that play important role in the diagnosis of AML, so the WHO classification has established that patient with the translocation 821 in version 16, 1616, and translocation 1517 should be considered to have AML regardless of the blast percentage. Moreover, by dividing patients into 3 risk groups, favorable, intermediate, and adverse, cytogenetic has been widely adopted to provide the framework for the risk-adopted treatment approaches. In certain situations, also cytogenetic allow for prediction of effective therapy, such as patients with BMR-RARA who can have a benefit from the ATRA. This is one of the famous picture in the genomic landscape of AML. The data shown on this slide from German-Austrian AML study group. It includes data from over 1,500 patients between the ages of 18 and 84, treated with the 3 different clinical trials with intensive chemotherapy. 111 different genes were sequenced, and among these genes, 5,234 mutations were identified among 76 genes. 96% had at least one driver mutation, and 86% had more than two, or had two or more than two driver mutation. So the molecular analysis demonstrated that there were several mutations that were either prognostic or predicted, and they are also targetable. For example, FLT3 abnormality occurred in 1/3 of the patient, and these we can target it with the FLT3 inhibitors. NPM1 mutation occur in 30% of the patient with diploid karyotype, and these patients have very favorable prognosis with intensive chemotherapy, provided that the mutation is not associated with the other adverse mutation. We also know that about 20% of patients have either IDH1, IDH2 mutation, and we can target them with the inazatinib or ivosidenib. But what does this all mean for the classification? Briefly, with the ability to sequence the gene involved in the leukemia genesis in multiple patient samples using advanced genomic techniques, we were able to refine the risk stratification and even the classification of the AML. So the author pointed out that nearly half of the patients in this cohort would not fall under the WHO molecular classification criteria, despite having disease driver mutation. So beyond the existing WHO subgroup, the author suggested an alternative classification method based on specific statistical analysis for their own result, and they proposed a 5 new molecular subgroup in addition to the recurrent cytogenetic abnormalities. So there is a distinction between system for classifying patients with the AML for diagnostic purposes and a system for predicting the outcome of the AML. So for prognostic purposes, the system should be stable and durable based on the fixed biologic properties of the disease. So the focus will be on the causative driver mutation. For prognosis purposes, the system should be flexible and adaptable, evolving to reflect the advances in the treatment and often being influenced by changes in the disease severity. Let's take an example. Although the WHO lists FLT3 ITD as a molecular genetic alteration significantly affecting the clinical outcome in patients with the AML in a specific cytogenetic subgroup, it doesn't group FLT3 mutation into a single category because it occurs across multiple AML subtypes. Therefore, they rather divided them into many risk groups. So this slide summarizes the new ELAINE classification, and this already adopted in the 2017, and it might evolve in the future with some recent discovery. So what you see among favorable profiles, some mutation that consider favorable beside the core binding factor leukemia and ABL, for example, patient with the NPM1 without FLT3 abnormality or with low allelic burden of FLT3 abnormality less than 0.5%, are considered favorable. Also CEPA biallelic, even though it is uncommon, is also considered quite favorable. But when you see at the adverse group, patient with the FLT3 ITD and with the high allelic frequency, more than 0.5%, are considered adverse, but this is before the introduction of the FLT3 inhibitor. The prognosis of these patients is changing very quickly. At the bottom, you see TP53, which probably consider worst of the worst mutation. And now there are some ongoing effort by different scientist group to have target therapy, such as ABR246 and CD47 antibody for such mutation or for its critical pathway. These data show interesting findings regarding the age-related differences in the mutational and the structural alterations in the AML. So in the top, childhood AML, like adult AML, both has a low somatic mutation burden, less than 1 somatic changes in the protein coding region. In the bottom, childhood AML is more frequently impacted by common cytogenetic alteration than adult AML. However, the landscape of somatic variant in pediatric AML was markedly different from that reported in the adults. Alteration in the RAS genes, KIT and FLT3 were more common in the children. For genes such as CPL, GATA2, Wilms tumor make both the frequency and the site of the mutation often differed between the children, or different between the children and the adults. Another striking difference between adult and the pediatric AML involved a high frequency of mutation in the DNA methylation related gene are more common in the adult AML compared to the pediatric, like DNMT3A, IDH1, IDH2, and TET2. Mutational complexity of the AML. So this circus plot depicts the relative frequency and pairwise co-occurrence of the common molecular mutation in the AML. So basically, it connects the notion that if you have one abnormality, you are going to have a large proportion of the another abnormality. So let's take an example. So patient with the NPM1 very frequently have a FLT3 abnormality and DMT3A as well. And also FLT3, patient with the FLT3 ITD are common to have an NPM1 also. So all these can be mixed up together. One common feature of neoplastic progression is clonal expansion or evolution with a genetic or epigenetic alteration. In the other word, there is a clonal architecture of AML, and this can differ at the diagnosis and at the relapse time, where in this slide shown here, each color represents a different genetic profile or different clone. So when the patient are treated and then relapse, they can relapse with the different clone, major or minor or treatment related. For example, this example, no change with in the relapse clone. It's similar as a diagnosis. Here there is differential clone expansion. In this example, we see gain of novel subclone, here complex clone. And now I'm going to talk a little bit about clonal hematopoiesis and how it translates into difficulties for us in interpreting the result, especially measurable residual disease following the therapy. So the definition of the CHEP is basically the presence of the clonal mutation in hematopoietic stem cells and progenitor cells in the absence of hematological disease. In other words, the presence of clonal blood cells population associated with the leukemia driver mutation at a variant allelic frequency of 2% or greater, but in the absence of cytopenia or the WHO-defined disorder. So we know very well that the incidence increase with the age, and most commonly one or few mutation in the gene recognized as early event in the myeloid neoplasm include epigenetic modifier like DMT3A, TET2, splicing factor such as SF3B1, SRSF2, and also TB53 and JAK2. These are considered the recurrent mutation in the clonal hematopoiesis of indeterminate potential. Its incidence increased in patients with the solid tumor, which also be as a result of its association with increasing age, and it does have also potential association with the higher exposure to oncologic therapy or chemotherapy. This paper was published in the 2014 and demonstrate that mutation that discovered by West whole exome sequencing were very rare in the person younger than 40 years of age, but rose up in frequency with each decade of life thereafter. Then the author searched for mutation in genes implicated in hematological malignancy, and the most commonly genes or the mutated genes were DMT3A, TIT2, SXL1, TP53, JAK2, as most of the paper they mentioned. Another important observation was about 693 of the 746 persons with detectable mutation had only one mutation in the set of the gene that were examined. These findings consistent with the hypothesis that these persons had clones harboring only in the initiating lesions. Okay, so we know that clonal hematopoiesis can precede AML development. But what happens after you treat a patient with the AML? And what is the fate of the clonal hematopoiesis? And what happens to the clonal size? And what are the long-term effects of the patient who had a residual clonal hematopoiesis following induction therapy? So in this study, the author looked at the series of the patient with the AML who achieved complete remission. And then they analyzed the dynamic of persistent clonal hematopoiesis and investigated its clinical implication after they sequenced them by using targeted panel of 295 genes by NGS. So variant with the greater than 2.5% allelic frequency at complete remission were defined post CRCH, post complete remission clonal hematopoiesis. Two subtypes were defined, persistent CH, the variant were detected in the original AML sample and persisted after complete remission. And emerging CH, the variant, were not detected in the original AML sample, but emerged after attaining CR. So following induction chemotherapy, 48% had a post-CRCH, among which 40% had persistent pre-leukemic CH alone, and 1% has emerging CH alone, and around 7% have had both. So let's look at an example to explain more. So this is one patient that was treated with the chemotherapy. As you can see that at the diagnosis, these variant allelic frequency of the various mutation, and on the other side, on the right side of the of this graph, you have the blast count. So when they treat a patient, the blast count goes down. Also, the mutation of NPM1 and NRAS goes down. But you can see DMT3 and TET2 actually persist. However,
3 minutes, Dr. Haytham.
Okay. However, they also found that allostem cell transplant, as we'd expect, is able to eradicate the mutation, right? So here the patient has a DMT3 that persisting, but once they are transplanted, the DMT3 disappear. So in summary, post-treatment clonal hematopoiesis may be associated with phenotypic abnormality, but it's not necessarily residual AML. Consolidation and maintenance therapy have minimal effect on the post-remission clonal hematopoiesis, but allogenic stem cell transplant may be curative. The take-home messages for my colleague and fellow and the resident regarding the testing, the utility of the genetic testing depends on who are you testing. It really depends on what is your test probability and how you will interpret the result of that test. And think about what you are testing, single gene or multiple gene, whole gene or hotspot. Also think about the test sensitivity. So there are some diseases where small clone matter particularly if you are thinking about prognosis. So if you find a small clone of adverse mutation, that might be something to know, that might be something that really changed the outcome for this individual one. And if you are doing less sensitive testing, so you might not identify this. Finally, think about when you are testing and why. So there are certain stages during the disease, of course, that can be amenable to genetic testing, where you can learn different things. Are you doing this at the diagnosis? Are you doing this at the doing it primarily for prognosis or at relapse? So this may determine what kind of panel you are interested in looking at, and again, how you interpret those genetic mutations. So in order to prevent poor utilization of the molecular testing, both either over or underutilization that may lead to increased cost associating with unnecessarily molecular tests, and also to prevent misinterpretation or misapplication of the molecular result, and also in order to provide or to give the best clinical integrated report to clinician in order to provide the optimum treatment management plan, I think this can be done by applying a special approach that we can call it diagnostic management approach, which mainly driven by hematopathologists with the collaboration with the clinician and the scientists or laboratorians. So the goal of hematopathologists is to create guidelines and algorithm to ensure that molecular tests or the other ancillary tests are ordered on the right sample at the right time for the right patient to meet the clinical need of each patient, and create integrated narrative report that really is the result interpretation for the clinician. And again, of course, we have to not forget the other collaboration team, clinician and scientists and laboratorians, where they have great input either in the result interpretation, in the technical management, test validation, test development, and also in the management, treatment, or result interpretation. And I think this is my last slide. Allahumma anfa'ni bima 'allamtani wa 'allimni ma yanfa'ni wa zidni 'ilma. Thank you very much.
Thank you very much, Dr. Haytham, for this excellent comprehensive presentation. We have two questions here. First question, do you have any classification of AML based on protein and metabolites profiling? Because the fact that not all gene translated to protein or molecular function.
Actually, till now, the new or adopted molecular classification that adopted before, the one that I showed you, the recent, but maybe in the future, maybe we'll have this classification. True.
Okay. Another question, do you think, is this the time that we have to screen for CHIP in a specific medical condition?
See, CHIP, as I told you, the molecular test should be requested at the right time. For example, if you have a patient who's not suffering from anything, no cytopenia, everything, so why we should screen this particular patient? But if the patient has, and as I told you, CHIP can be common with the other solid tumor, and he will involve in the, for example, he will be a donor for his son or for his daughter, or and I think at this time maybe it's a good idea to screen them. But the important thing, how are you going to interpret this mutation, because the clonal hematopoiesis, it doesn't mean the patient has a cancer, but it can be the first signal in the future for this patient to may transform or develop AML in the future, not at that time.
Okay. I cannot see any more question. Thank you again, Dr. Haytham. And I will handle the mics now to my colleague, Dr. Ayman. Thank you very much.
Thank you, Dr. Mania. Thank you, Dr. Mansour, Dr. Haytham, for interesting topics. Good afternoon for all attendees everywhere, which are exceeding now as 800 persons. It's my great pleasure to introduce our next speaker, Dr. Abdullah Al-Harbi. Is obtained his bachelor's degree of medical science from the Al-Qura University and graduated with MBBS from King Saud bin Abdul Aziz University for Health Science, Riyadh. Then he went to finish his fellowship in pathology, hematopathology, and blood transfusion from King Saud University. Dr. Harbi is currently the Director of Medical Laboratory, Medical Service Center Imam University, as well as an Assistant Professor of Hematopathology and Transfusion Medicine, Pathology Department, College of Medicine, Imam Muhammad bin Abdul Saud Islamic University. Dr. Harbi will talk in the coming 25 minutes about MRD assessment tool in acute leukemia. Without further details, Dr. Harbi, mic is you.
Thank you, Dr. for this nice introduction. It's my pleasure, and I want to thank the organizing committee, SSBMT, for this invitation. So my topic is regarding the MRD assessment tool in the acute leukemia. The measurable residual disease describes that a disease detected only by laboratory technique with a more sensitive than morphological tool, like flow cytometry for detected the immunological MRD, and PCR for molecular MRD. As it is found in the absence of the clinical signs and symptom, is termed as a minimum. Prognosis is a variable for patient with the acute myeloid leukemia for pre-treatment characteristic like age, karyotype, mutation profile, response to treatment, chemosensitivity, achievement of complete remission. In a patient with less than 60 years, show the achieve of CR cure rate in 50%. Morphological assessment of response is not sufficient to predict the outcome. Risk of relapse inform a treatment strategy for consolidation or stem cell transplantation. The European Leukemia Net in 2017, they proposed the prognostic stratification to the favorable, intermediate, and adverse. With the favorable, if it is have a specific translocation or mutation in MBM1 without FLT-ITD, or with FLT-ITD with a low allelic burden, or biallelic mutation of CBBA. In adverse prognostic, if it is complex karyotype, monosomal karyotype with MBM1 wild type and FLT-ITD with the high allelic version, and if there is a cytogenetic abnormality not classified as a favorable and adverse, it will be intermediate. So what is the role of the MRD assessment? MRD is a highly prognostic in AML, and sometimes it supersedes a pre-treatment characteristic. It is not standardized across the field. So which optimal MRD assess we can use? What is the appropriate time? And should be MRD guided the treatment, and how we gonna report. Clinical implication of AML MRD, the European Leukemia Net indicate the complete remission without MRD as an official AML response criteria. Lack of standardization evidence-based recommendation in the US. Flow cytometry and NGS are complementary, and they use the apparent surface protein expression and leukemia-associated mutation. Method for MRD detection in the AML, we have the multi-parameter flow cytometry for leukemia-associated immunophenotype, or different from normal approach. The sensitivity is high. It is up to 10 to the power 5 sensitivity for detection of the leukemic cells. The advantage for this method is widely applicable. It's up to 90% of the acute myeloid leukemia can be detected by this modality. Relatively quick, the result can be ended by the day, and the single result interpretable, high specific with the using defined leukemia immuno-associated phenotype. Can detect cell leukemic stem cell phenotype, can distinguish between live and dead cell, and provide the information about the whole sample cellularity. What is the cons for this modality? It's a little bit challenging, and somewhat interpretation require expert pathologist. Sensitivity depend on the antibody panel use, limited, harmonized, and standardized across laboratory. Leukemia phenotype not necessarily stable over time. For example, the initial leukemia-associated immunophenotype may not identify a subclone leading to relapse. RT-PCR, the quantitative method, is also sensitive, which is reached to up to 10 to the power -5. It is widely applicable and run of any certificated laboratory with this capacity. The sensitivity is high and might be more than the flow cytometry. Well standardized, and the disadvantage for this method is result may take multiple days, expensive and time consuming, require high level of experts, and require setting of threshold limits. Interpretation often require a trend of result, and different mutation have a different biological consequence in AML. Molecular target applicable only in 50% of all AML cases. Next generation sequence also good sensitivity for detection of MRD. It has a relatively easy to perform, sensitive, and applicable to specific subgroup, while there is some limitation in standardization. Error rate lead to a low sensitivity of mutated subsequence. Mutated gene can be detected in healthy people without hematological abnormality. Persistence of some genetic abnormality in a patient in long-term remission, and there is a risk for contamination. FISH modality also has a little bit sensitivity up to 10 to the power 2. It's superior to the PCR-based assay for detection of a numerical cytogenetic abnormality, for example, in gain or loss of a whole chromosome, deletion, or duplication. But considerably less sensitive than PCR and the flow cytometry, not useful for the patient with the normal karyotype. Quality assurance probe are expensive. Technique is need a labor intense. A chromosome or a conventional karyotype, has a sensitivity of 5%, and more common in routine clinical practice, evaluated the dividing proportion of the cell, but is also costly and time consuming. The sensitivity is less than the FISH and not useful for the patient with the normal karyotype. Detection threshold of various MRD modality compared to the traditional clinical complete remission We have as a morphology, fish chimerism, and BCR and NGS with this sensitivity of detection of residual leukemic cell. However, the next generation center, there is a clonal heterogeneity and evolution, and should be taken in consideration. So what is the approach of AML MRD by flow cytometry? It is unlike the B lymphoblastic leukemia MRD. It is not standardized approach. So we look for the leukemia-associated immunophenotype approach and different from a normal approach. In leukemia-associated immunophenotype, look for apparent antigen expression, asynchronous antigen expression, variation in the intensity of antigen expression. The different from normal approach is usually used in the case of referred patient without no knowledge of original AML phenotype. And it is difficult to interpret. Sometimes the atypical antigen expression in regeneration must be considered. This is a panel for MRD assessment designed in National Guard, and they used the 8-color approach with the 4-tube, and they used a lot of antibody with the myelomonocytic marker and early stem cell marker to detect more appearance for when they deal for MRD. The strategy for the MRD study, after we take the bone marrow and the screening of antibody by multiple assay at presentation of the bone marrow sample with identify of lineage and lineage association marker to be identified as acute myeloid leukemia or acute lymphoblastic leukemia. Then there is a secondary balance to identify leukemic-associated phenotype or different from a normal approach using 8-color of staining with the CD45 gating strategy. So if there's a negative in this patient, it says this not suitable to track MRD. But if we clearly specify the leukemia-associated antigen with the percentage of these blast and the percentage of all the marker at the diagnosis, this can be used as during the follow-up and the tracking of MRD. And then you establish the MRD after every cycle of a treatment, correlate the percentage of MRD with the relapse and the refractory-free survivor and overall survival. In this case, you can see the gating strategy after they use the forward and high side scatter to tracking the blast, and with the positivity of CD45 and the CD33, and you can see after the cycles of chemotherapy, the decrease of the leukemic blast at the detected level of MRD is 0.03, and after 5 months of cycle, they again do an MRD and they detect less than 0.01%, but after 12 months after consolidation, you can see the minimal residual disease, it was positive, and that's case with the percentage 0.1%, and in the relapse after 17 months, the MRD with the same immunophenotypic has a 1.7%. So the prognostic impact of the acute myeloid leukemia MRD by flow cytometry and the remission post-induction, in this study, they identified that cases positive MRD more than 0.1 by flow cytometry, and they have stated the important prognostic marker that can help guide for treatment and decision and you can see in the overall survival and disease-free survival difference between the negativity and positivity of MRD. Also, the other study, they see the relapse and refractory AML, also the MRD that's help for the treatment decision of two type of case, and also the relapse and refractory percentage of the MRD. There is some practical challenging in AML MRD detected by flow cytometry for the pathogenesis of AML due to the clonal complex neoplasm that drive the immunophenotypes, pre-leukemic cells, like in case of MDS, it might persist after a therapy, and there is some antigenic shift following the therapy. Also, for bone marrow regeneration can elicit the phenotype changing, particularly if there is a growth factor therapy. Sample adequacy can be a limited factor in case of ablation or suppression following therapy. There is some potential limitation for MRD detection using the immunophenotypic due to the heterogeneity of this marker, and you can see here in this diagram the aberrancy distinct from the diagnosis and the clonal identical or clonal evolution that arise from the diagnostic cell. Some common immunophenotypic aberrancy in the leukemic myeloid blasts. For example, we look for the increase and overexpression of some marker, decrease or loss of the other marker, or decrease and increase of the side scatter and 45. If there is an apparent lymphoid antigen present in the myeloid leukemic cell, like CD2, 5, CD7, CD19, and 56, asynchronous expression of mature myelomonocytic antigen like CD4 and 15 and 64. Some pitfall that is when you deal with the MRD by flow cytometry, you have to distinguish the early normal myeloid progenitor, and that is which is usually DIM34, DIM38, BRIGHT 34, and when they get about the CD45, usually it is TIM to BRIGHT. Also, there is a DIM33 and 13, BRIGHT of 117, and HLDR BRIGHT, and 123, it is DIM. There is also, you have to take in consideration, there is some normal expression of lymphoid antigen by myeloid progenitor, like CD20 is my expression in myeloid blast up to 1.8%, like in MDS case, and also CD7 expression in about 9% of MDS. The reporting of MRD in acute myeloid leukemia as a consensus document from the European Leukemia Network, Leukemia Net working group. They recommended that if it is below there is immunophenotypic detection of MRD with the true leukemia-associated anti-immunophenotype, but it's less than 0.1%. You have to look to the background, a prognosis. It might be there is a consistency with the residual leukemia. Also, you have to assess the viability of the cells and the quality of the sample that we provided to the lab. The percentage of the leukemia immunophenotype, it also should be mentioned, and The approach for AML MRD next generation sequence, you have to look for persistent and new mutation, clonal evolution, ML and clonal heterogeneity, mutation landscape often change post-therapy. Persistence of a mutation do not equal residual AML. For example, like Dr. Haytham mentioned, in clonal hematopoietic, if that mutation, DMT3A and TIT2 and XXL1, often persistent, drive a mutation severe. Suitability for MRD detection marker, if you can see here in the leukemic, the drive mutation, for example, BML RARA, RONX1, CBB MYH11, it is sensitive and specific for tracking the MRD by molecular. While the some of the pre-leukemic marker have like DMT3 and TIT2, IDH1 and SF3B1. This is it can be detected post-therapy, so it is non-specific and not recommended to be used as an MRD marker. Also, post-onset driver mutation like FLT3-ITD and RAS, BTVN11 and KIT, this is might be changed after the therapy, so also is not suitable to tracking for the MRD. In this study, you can see the that mutation, which is about 50% of the patient that detected by the NGS at the diagnosis and after the induction of therapy. So this is it is not suitable for tracking of MRD. Relapse among those patients with the persistent DAT mutation has the study in this shown that is not DAT mutation had a high prognostic value with respect to the relapse, and there is no significant associated with the relapse rate than the not detected DAT mutation. But there is no significant correlation of a persistent DAT mutation with increased relapse risk. The RT-PCR for the NPM1 mutation, it is a good marker for detection and the give a probability for relapse and overall survival when they compare the after induction of therapy and after the completion of therapy. And you can see the difference between the MRD negative and MRD positive. So the monitoring during and after therapy of the NPM1 mutation allow to discrimination of the patient with the high and low risk of relapse. The PCR for the NPM1 mutation in the peripheral blood, it's better than bone marrow. And this study has shown that is the, despite the bone marrow testing of NPM1 mutation, does appear as more sensitive than testing via peripheral blood. However, the presence of the MRD in peripheral blood was highly informative among a patient in morphological complete remission. The use of and comparison in this study between the NGS and flow cytometry, it's can give the prediction percentage of the relapse rate if you have a result from both modalities. So there's some recommendation by the European Leukemia Net for MRD testing. If you use flow cytometry, you have to use a full panel with these markers and monocytic tube. It can be added to increase the and explore all the appearance. The target classical of a lab approach and different from normal approach in all apparency, and apply this is both in diagnosis and follow-up. Estimated the contamination from peripheral blood, especially if you use as a first pool from the bone marrow. Use the up to 1 million cells has to be acquired to as a good assessment for MRD. And for the molecular biology, there is analysis is different for you can use any anticoagulant. The mutation of the DANT mutation as well as the FLT-ITD, this is marker is not useful in the to assess and tracking of MRD. However, it may be useful when used in combination with the second marker. For BLL, this is a panel used with the 8 color and the 3 tube. And the pitfall for the BLL, it says it might be there is a highly percentage of the hematogone, which is mimic ALL. So this is hematogone. It is immature B cell found in infant and decrease with age, increase and observed in the patient with the lymphoma, marrow regenerating state, and the immune cytopenia, acquired and loss of antigen resulting in the maturation speed, spread, hematogone panel that use like CD10, 19, 20, 34. There's some overexpression of the CD49 or underexpression of CD81, asynchronous of 123 with the 34 in ALL.
5 minutes.
Okay. And this is, you can see the hematogone, especially in the three type, the 3 stages have a decrease or increase the expression of the CD20 with the maturation and loss of the CD10. So in the hematogone, you have to see the approach of the hematogone. It is a low side scatter, and when you get about the 45 and 19, you can see also the type of and dim of the 38. This also percentage of all stages can be done, and you can see this different stage with the maturation, especially if CD19 with the CD10, and also you can use the different stage of maturation when you combine the CD10 with this one CD20 and give you like a question mark sign. Also, they have a TDT and the decrease the expression of the 34 and the increased expression of the CD20 with all increased maturation. Hematogone can be seen in the peripheral blood, especially the stage 1 and 2 can be detected in peripheral blood. Both pediatric and adult patients can have a circulating stage 1 and stage 2 of hematogone. When present in peripheral blood, early stage of hematogone are associated with the late stage hematogone, potentially helping to discriminate those early precursor from B lymphoblastic leukemia. My conclusion is, despite this substantial heterogeneity, MRD negativity has been reliable, shown to predict the risk of relapse and long-term outcome. And MRD detection has a strong clinical relevance in AML, and the new technological advance have increased in sensitivity and specificity. The ultimate goal of assessing MRD is to use this information to the appropriately guide decision regarding post-remission therapy. The development of a more sensitive MRD assay, including NGS, may all allow for even better risk stratification. Thank you.
Thank you, Dr. Abdullah, for this nice and comprehensive and more informative presentation. There is no question, but I have one question for you. We think how can assess MRD for malignant patients and treated patients in the minimal or limited resources in some area?
Yes, as we mentioned, that is in the diagnosis, you have to detect and assess the leukemia associated immunophenotype. In case of, and this is what it will help a lot for tracking the MRD by flow cytometry. The most important thing that is you have to use the same panel that we use in the diagnosis, and it has to be followed in the MRD. However, if you don't have the immunophenotypic marker at the diagnosis, so you can use the new strategy different from normal by the assessing the new appearance and also the pattern of the maturation and expression by flow cytometry.
Thank you, Dr. Abdullah. Thank you for all presenter and Dr. Mansour, Dr. Abdullah, Dr. Haytham for this informative presentation. In this session, I would like to thank also Dr. Ammar and organization committee for this informative events. We hope is will be done annually, and inshallah we'll stop for a break for Al-Asr prayer. We'll be back at 3:55 for second session. Thank you for all.
Mm, mhm. Bismillah. Okay. Can we start now the session? Hello.
السلام عليكم ورحمة الله. شكلهم لسه في البريك.
But it's already 55. That's from your time يا دكتورة.
لا أنا مالي. أنتوا تأخرتوا الوقت. يلا إن شاء الله خير. إن شاء الله خير.
I think somebody is talking to me. السلام عليكم. السلام عليكم ورحمة الله وبركاته. Can we start the session now, دكتور عمار?
دكتورة تفضلي الله يعافيك.
Okay. طيب. بسم الله الرحمن الرحيم. Good afternoon, everyone. I'm Dr. Rabab Al-Attas, and it's my pleasure to share to co-chair, in fact, this session with my colleague, Dr. Noor Al-Muzayyin. We will have a very exciting session with very distinct speakers. The first speaker, which I'm going to introduce her, is Dr. Salwa Al-Hindawi. Dr. Salwa is a professor in hematology and transfusion medicine at King Abdulaziz University. Dr. Salwa is certified both in hematology and transfusion medicine by MRC Path and FRC Path. She is also a member, in fact, of many prestigious societies, and she's actually president of some of them, including some, not all, is the WHO, ECPS, the Expert Committee to Biological Standardization, the Saudi Thalassemia, Sickle Cell Anemia, the Saudi Society of Transfusion Medicine, and she's the AABB as well. Dr. Salwa is an editor and a board member of many journals, national as well as the international, like the Indian Society of Blood Transfusion and Immunotherapy. Dr. Salwa is gonna talk to us about the impact of the COVID infection on the transfusion medicine. Dr. Salwa, please go ahead.
Thank you, Dr. Rabab. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. I just like to start with thanks to the organizing committee for inviting me today. And my talk today, as Dr. Rabab said, on the impact of COVID-19 on blood supply. This presentation is supported by Bristol Myers Company. Just get me to the slides. Okay, I'll start with introduction, some challenges, local experience and strategies for management, then conclusion. Blood supply, we, through the WHO, the reporting on 2018 worldwide that there are 118.5 million blood donation collected globally. 40% of this blood donation is in the high-income countries, and this in high-income countries are the home for 16% only of the world population. The world blood donation rate is an indicator for the general availability of blood in any country. The median blood donation rate in high-income countries is 31.5 donation per 1,000 people. Upper middle income is 15.9 donation per 1,000 people. For low middle income countries and low income countries, it is below average and it's 6.8 and 5. And this is not, the supply is not equal to the demand. There, the demand is superior to the supply in these countries. In general, we know that transmission of SARS-CoV-2 via transfusion has not been reported up till now. And it's currently considered highly unlikely. As we know, the transmission mode is by direct contact and respiratory and other modes, but not yet any report by blood transfusion. Coronavirus disease pandemic had a significant impact on the blood supply around the world, especially at the beginning of the pandemic. There are reports by American Red Cross as example that they have dropped by fewer blood donation 200,000 and 6,000 blood drives canceled. The blood supply chain, we know that it is having part of it as for the product itself and part of it for the patient. This means part for the supply, part for the demand. And products, content of products part is the recruitment and collection of blood donation, testing and processing and storage. For the patient is ordering the delivery of correct blood to the patient, administering blood to the patient, and this all affected during the pandemic. In this figure or graphs, we can see the report of WHO organization on September 30, 2021, about the total cases reported globally, and it is arrived around 235 million, and this is around 5 million globally. And there are many waves happening and occurring since the beginning of COVID-19 pandemic in 2020 around the world, and more than 100 variants discovered around the world. In Saudi Arabia, situation is a little bit better now, and we had a total of 547 confirmed cases and around 8,727 deaths by 30th of September. And we can see from the graph that we have dropping of the cases and improved situation in our country. And this luckily because of the control of the authorities and Ministry of Health. There are many challenges around the world facing us usually for the blood supply, but also the COVID-19 increases challenges. Donor supply is reducing and challenging for donor supply, that we have to maintain constant supply of donor, and we have to ensure that all blood groups, including rare types, are represented. And donor health is important, and we need to have a policy that protects donor health. And one option for that we can try to increase supply by interdonation, reduce interdonation interval. One study showed that it is not a good choice on the long term, as it's not long-term solution. It can affect donor health. Other challenges which all of us we know and we pass through it in blood transfusion centers, related to donor challenges like social distancing and travel restriction, illness, self-isolation, need to care for family members, and fear of acquiring COVID-19 during donation. Cancellation of blood donation campaign also affecting remote areas in certain countries owing to travel restriction, and reduced capacity at donor centers due to COVID-19 precaution, staff being sick or on sick leave, self-quarantine, and application of social distancing to donor also affect that. Also, there is in certain centers, there are collection of the plasma from recovered COVID-19 patient, and this led to diversion of blood and staff to service related to that. This is affecting the usual collection. Blood processing and supply chain disruption due to restriction of travel and the transportation, affecting the supply of critical materials and machines needed and lead to shortage. Supply doesn't always meet demand. There are chronic worldwide blood shortage, and the World Health Organization estimates that resources limited country to be improved in their supply, they have to have more than 10 donors per 1,000 inhabitants to be collected annually. Many low-income countries don't reach this target. In this graph, you can see that most of the donation is in the high-income countries and low-middle-income countries, as I stated before. The impact of transfusion on chronic disease also affecting demand and supply. Transfusion-dependent patients have experienced blood supply shortage, and the patient may have postponed their own transfusion clinic because they are having the fear of COVID-19, acquiring COVID-19 from the hospital. And also the capacity of some transfusion service has been reduced owing to COVID-19 safety precaution and staff shortage, and this results in postponed of transfusion appointment in some cases, or I can say in many cases. Blood service organization face pressure in maintaining sufficient blood to meet demand. And the treatment of chronic anemias in general places a considerable additional strain to the blood supply. As example, in Greece, 20 to 30% of their annual blood supply is used to transfuse around 3,000 patients with thalassemia and sickle cell anemia annually. I will just state some example of local experience and about a few studies, because if we can just look around, there's a lot of studies happening worldwide on supply and demand and the impact of COVID-19. And this is happening everywhere in US, UK, Europe in general, all regions of the world, and locally at Saudi Arabia. If I can start with Saudi Arabia with one study done by Yahya Ammar, who is, or Ammar Yahya, and published in Transfusion Science in 2020. It's about management of blood supply and demand during the COVID-19 pandemic in King Abdullah Hospital, Bisha. A retrospective study from this hospital in Bisha revealed a decrease in blood flow or supply in blood banks by 39.5% during the pandemic, in contrast to the demand, which was decreased during the same period by 21.7%. And this likely secondary to cancellation of many surgeries due to occupation of the hospital with COVID-19 patients. But even though this shows that the supply is decreased more than the demand in that period. Another study from African region by Andrew Loa, which is from the Regional Office of Africa. It's published in Vox Sanguinis. Also the impact of COVID-19 pandemic on blood supply and demand. A survey questionnaires was sent to all 47 countries in WHO African region to collect information on blood supply and demand for the first 5 months of 2019 and 2020, respectively, and on COVID-19 convalescent plasma therapy in September 2020. In conclusion, this study showed that the pandemic had led to a reduction of blood-related activities in the region in most of the country, including the supply and demand. Countries' preparedness plan for health emergency need more emphasis to maintain blood stock. Another study by our group at King Abdulaziz University Hospital by Saud Al-Malki and colleagues. It's about awareness about coronavirus and challenges for blood service among potential blood donors. The aim of the study to assess knowledge and awareness of blood donor about COVID-19, and the method was by survey, including 27 questions. A total number of 3,841 persons responded. 58 of them were between age of 31 and 50. More than 60% of participants donated blood previously. In conclusion, the fear of contracting COVID-19, secondary to concern about contact with other blood donors and staff, was the main limiting factor to blood donation. Now I'll just go to some of the important strategies for management, and starting with saying that during an emerging pandemic, any pandemic, it's too late to think about the implementation of new strategies or technique. And we have to be prepared, and we have to have a plan for this future pandemic. Strategies, there are here 6 strategies which we may think about more than this, but this is important strategies for blood supply specifically and demand. And it's starting from donor recruitment, eligibility, protection of staff, and inventory management, production modification, and patient blood management. First strategy about donor recruitment, we have to encourage donation. During pandemic, we can do invitation to donate, call donors from our database, the usual donors we know, we can just allow transportation for donor to facilitate their arriving to our centers. We have to depend on media for awareness and education, and just to allow donors knowing what is situation and how they can participate from the society. Extension of working hours will help, and change age demographic of donors may help also. Awareness campaign has to be encouraged. Donor eligibility, we have to have a donor selection criteria relaxation. We may just relax the criteria, and it's done already in many countries. And also we did it locally in few of the criteria which will not affect safety of the donor. Deferral period should be applied for confirmed or suspected cases, for travel in countries region at high risk, and for exposure to confirmed cases of COVID-19. Eligibility criteria for COVID-19 has to consider that persons with possible direct contact with COVID-19 patients are temporarily deferred. Positive COVID-19 donors are deferred for 14 days after their last negative result or complete recovery. Donor with pending COVID-19 test result has been deferred until the results are completed and just discover if it is negative or positive. And also for the vaccination, which a lot of people asking the vaccines, donor who had vaccination, which is based on RNA vaccination, it is okay to donate at any time, but patients who get a live attenuated vaccine, they should be deferred for 4 weeks. Protection of staff and donors, as we know, the social distancing helping a lot for protection with the using of masks, as we know, and also washing hands, encourage donation by appointment, and environmental decontamination, sanitation of all materials used before and after donation, all will help in the protection of donor and staff. Inventory management is an important strategy at any time, and especially during pandemic or disaster. We have to have a regular update of inventory. We have to plan for emergency and disaster. We have to increase the efficiency at donation center, and the product availability. We have to plan for inventory level, timing of deliveries, and order review. Product integrity is important also to minimize wastage. And we can just see the references. There is an important reference from Australia on managing blood and blood product inventory. If you can go back to it, you can learn a lot from it. And you can use some of their methods to help you and discover. This is an example of one method, just to know your inventory by today, how it will help you and how many days it will cover. And it's easy to calculate it through this equation, just for anyone who wants to look at it, and you can go to the reference path. Product safety, also strategy to modify production, specification, and storage of blood component to help prevent blood shortage is very important. Modifying of production of the red blood cell platelets and plasma. You may use the whole blood in certain indications. You may just use the platelets and increase shelf life from 5 to 7 days. You can just reduce the dose of platelets in prophylaxis situation. All this can help if you modify the specification. Storage of plasma, you may use the liquid plasma in certain indication. Also, all of this will help in products. Donor selection and hemovigilance remain important tool to protect patients receiving donor blood, and also to protect donors and staff. Pathogen inactivation methods help a lot in just get rid of or reduce non-pathogen and also COVID-19 or SARS-CoV-2. Here I'm showing you 2 of our studies which we did for SARS-CoV-2 inactivation at our center. We had we used amoxicillin and ultraviolet A light treatment, and we use it for both plasma and platelets. And these two publications, it's already done the study and it was successfully. And the conclusion of the study is that the SARS-CoV-2 was efficiently inactivated in platelets concentrates by amoxicillin and UV light treatment. And the results are in line with previous inactivation data for SARS-CoV-2 in plasma, as well as MERS, as well as SARS-CoV-1 in platelets and plasma, demonstrating efficient inactivation in human coronavirus. And if you can see here, you can see that the negative control is equal to post-inactivation. And this just demonstrates it is efficient. And if any possibility of transmission, this can get rid of it. Last strategy I will talk about it today is the patient blood management. I will not just give details on patient blood management, but I will highlight on it. Patient blood management primarily aims to improve patient outcome, and it can significantly reduce the use of blood products and save health costs. By implementing patient blood management, we can find that it is a key to rethinking blood use and should substantially reduce blood demands, and we may reach the demand equivalent to supply. By using alternative to blood transfusion and approach to improve patient outcome and optimize transfusion, this will help a lot. And alternative to blood, such as synthetic oxygen carrier genetic gene therapy for inherited disease, and using of novel techniques and management, like application of artificial intelligence through data modeling to improve supply-demand chain. We have a few studies which succeed in just getting this model, and they have used the artificial intelligence to improve the supply and demand. And there is still studies going on about this to help and increase and improve the supply of blood. Evidence-based approved treatment options to manage anemia and reduce transfusion dependency is needed. And I will give you one example of this study and this medication who can help. We can say that the luspatercept is a first-in-class erythroid maturation agent that overcome ineffective erythropoiesis in beta thalassemia. And the mode of action of this drug is that it is it is an recombinant fusion protein consisting of modified form of the extracellular domain of the human activin receptor type 2B. And mode of action is that it binds to select transforming growth factor beta superfamily ligand, leading to enhancing late-stage erythropoiesis. In two studies which called the BELIEVE study, they showed that during week 13 to 24 as a primary endpoint, that it is having 33% reduction from baseline, and during any 12 or 24-week interval as an endpoint, it showed that it is effective to reduce the burden of transfusion by 33% up till 50%. And it is generally safe and well tolerated. In summary, this luspatercept significantly reduced red blood cell transfusion burden in patients with beta thalassemia, and also it can be used in MDS. Luspatercept reduced marker of iron overload and in generally safe and well tolerated. This published by Caplini and group and by Herman and his group in 2020 and 2018. We can say now it is registered by Saudi FDA and it should be available. In conclusion, building and maintaining trust between donor and collection center is essential to maintain an adequate and safe blood supply. Establishment of national blood system with well-organized and coordinated blood transfusion services that can provide sufficient and timely supply of safe blood and blood products to meet the transfusion needed of all patients is very important. And workers in blood collection centers must receive continuous education and up-to-date accurate information about the status of the pandemic. Collaboration is very important among collection centers, and sharing experience and learned lessons from each other, even nationally or internationally, from this pandemic is expected to help plan and manage current and future crises affecting the blood supply. Lesson learned, or the final thoughts, there is a need to continue supporting countries through strengthening capacity of national blood transfusion system through collaboration between WHO, country official, and other stakeholders. Enhancing risk mitigation is important. The use of novel techniques and therapies are encouraged. Blood services must be prepared to move quickly in response to changes in future pandemic situation. Thank you.
Thank you very much, Professor Salwa. And we have, and thank you for ending exactly on time. If there is any question, now we have full 5 minutes for any questions. Okay, may I ask a question then? Dr. Salwa, you mentioned that the most important impact of COVID on blood transfusion is the decrease the supplies, basically because of the pandemic itself and the shortage of donors. Now, in your studies, you have inactivated some of these viruses in the blood products. Was it because this has been, these patients had been, or this collection of blood was drawn without testing the patients, or before the pandemic was obvious? And do you recommend this way of inactivation as a routine now?
Yes, it's a good question. Thank you. No, this, till today, as I said, there is no evidence that COVID or SARS-CoV-2 is transmitted by transfusion, but just as a precaution. We know that pathogen inactivation is helped in reduction and inactivate many of pathogens around the world. And we prove that, and others also internationally prove that it is effective against reducing the pathogen in blood supply. But for this COVID-19 or SARS-CoV-2, we inoculate the virus itself in the products, and we inactivate it just to make sure that it can activate it if it will be in the blood. We know that in general, there is some studies show that the SARS-CoV-2 is present in the blood and even in platelets of some of the donors. And that's let us just a little bit worry. And just to get worry out, I recommend that if it is possible, you can use the pathogen inactivation to just get rid of this virus or other viruses after testing. For SARS-CoV-2, we know that there is no testing for routine donors, and we can't test every donor for SARS-CoV-2 if it is there or not. We need to just do pathogen inactivation in case if it will be transmitted in any case. And this will help all, even we know that pathogen activation will help bacterial also reduction and just inactivate bacteria in platelets. And we are using it actually in certain centers routinely for platelets. This encourages us to use it for also plasma, and we can use it for plasma to inactivate COVID or SARS-CoV coronavirus 2 or others viruses. And I recommended yes, but if it's possible and because of the cost, if it is nationally had what for every center, this will be much better, and this will reduce the cost on any hospital or any center. Thank you.
Dr. Rabab.
Okay, thank you very much. Thank you very much, Dr. Salwa, and we'll move to the next speaker. Our next speaker is Dr. Muhammad Al-Shif. Dr. Muhammad is a consultant internist with a subspecialty in thrombosis and vascular medicine.
دكتورة رباب.
Yes.
بس بعثت لي السكرتيرة إنه next speaker حتكون دكتورة سميرة. دكتور محمد حول حيكون اللي بعده. Okay. Sorry for the introduction.
Then is Dr. Noor, my colleague in this session, is she available here?
That's me.
Okay, would you please introduce him?
Okay. So our next speaker is Dr. Samira. Dr. Samira has brought her degree from King Faisal University in Dammam, and she is hematopathology and transfusion medicine consultant and King Faisal University at Dammam. She's the head of the transfusion services, and she's going to take us through the pregnancy-related hemostatic complications. You have 25 minutes of 5 minutes questions at the end.
Thank you so much, Dr. Noor. Thanks for the organizing committee for inviting me, particularly Dr. Ammar Al-Saghir. So let's get started. Okay. Am I audible? Can anybody give me a hint? Am I audible or not?
Yes, Doctor.
Can I? Okay, thank you very much. So my topic will be about pregnancy-related hemostatic complication, and that's my pleasure to introduce and explore such topic. Here is the outline of my talk. I'll be talking about the hemostatic changes in a pregnancy, hemostatic testing, pregnancy-related hemostatic complication, which will be one of these: thrombocytopenia, abnormal hemorrhage, or thrombosis. As you know, in a pregnancy, in fact, all the three factors of Virchow's triad will be affected: the endothelial injury, the hypercoagulability, as well as the venous stasis. And this is related to hormonal changes, the estrogen and progesterone that produce in the pregnant lady. And why that happen? What is the purpose of such hemostatic changes? In fact, it is needed to maintain the circulation from the mother to the fetus, which is very important for the health of the fetus, and also prepare the lady for a very big challenge during delivery. The stoppage of this this amount of blood that flow to the fetus has to be stopped, and this is the purpose of change in the hemostasis. As you know, in a very simple way, the hemostasis, it's just a balance between the procoagulant and anticoagulant factor. But in fact, it is a very complex network of positive and negative feedback loops that integrate the blood vessel, platelet, coagulation inhibitor, as well as fibrinolysis. And this is just one shows you the very complex, it's simplified, but it's still complex, the coagulation system, where you can find the positive and negative loops interact with each other. You can see in a pregnancy, those in red color, these are the factors that will be upregulated, increased, and those in gray will be the one decreased during pregnancy. With the black color, they remain unchanged. Let's summarize these changes that occur during pregnancy, starting with the count of the CBC blood count. The plasma volume will be markedly increased, started in the first trimester, then complete in the second and third trimester. At the same time, the RBC will be increased, RBC mass, but to a lesser extent as compared to the plasma volume. And this is why we have a physiological anemia in a pregnancy. Neutrophil count also will be increased during pregnancy, and the platelet will be decreased to a lesser extent, but still within the normal range. Coming to the coagulation factor, as you can see, most of the coagulation factor will be upregulated during a pregnancy, with the exception of factor 11, which will be reduced, about 20 to 30% reduction. Coming to the adhesive molecule, like the von Willebrand factor, will be upregulated, as well as microparticles would be upregulated. the anticoagulant, the natural anticoagulant, the protein C, the activated protein C resistance will be increased during the pregnancy, as well as the level and the activity of protein S, with the level of protein C remain unchanged. In the fibrinolytic system, you have the tissue plasminogen activator will be reduced, but at the same time, the plasminogen activator inhibitor type 1, which is derived from the endothelial cell, and the plasminogen activator type 2, derived from the placenta, will be markedly increased, and ultimately the fibrinolytic system will be increased. Although the tissue factor, the soluble tissue factor, remain unchanged during pregnancy, but the monocyte-derived tissue factor will be increased. This just shows you the summarization of the changes that occur during the pregnancy. And it has, as you can see, there is a procoagulant tilt in pregnancy. The interleukin 10 will inhibit the monocyte tissue expression. And the level has been found that the level of interleukin 10 are increased throughout the normal, healthy pregnancy. The lower level, in contrast, found in preeclampsia. Homocysteine as well has been found to induce the monocyte tissue expression at physiological level, and it is reduced during normal pregnancy. The activation marker seen in pregnancy, there will be an increase in thrombin activity, soluble fibrin level, increased thrombin antithrombin complex, as well as increase in the D-dimer, which is a sign of fibrinolysis. In one study, it has been shown that the coagulation and the fibrinolytic indices in healthy third trimester pregnant women were similar to or higher than those found in patients following DVT or pulmonary embolization. And yet none of these women develop any clinical symptom of venous thromboembolization. And this is just lead to the conclusion that the changes, the hemostatic changes during pregnancy is just as a physiological rather than a pathological process. On the same study, the fibrin peptide A to the ratio of fibrin peptide A to the D-dimer remained the same, constant throughout the pregnancy, suggestive of constant coagulation to fibrinolysis balance. In contrast to the high ratio seen in women with preeclampsia, which suggestive of hypofibrinolysis. So the balance in coagulation between the coagulation and fibrinolysis in pregnancy, the increase in the coagulation will be counteracted by the increase in fibrinolysis, and this lead to hemostatic balance during pregnancy. And any disturbance in this hemostasis will lead to the pregnant lady will be subjected to the risk of venous thromboembolization, and there will be inadequate maternal fetal circulation with all the complication associated with it, such as placental abruptio, fetal growth restriction, or preeclampsia. How the changes, the laboratory changes during pregnancy, during normal pregnancy, there will be endogenous, the increase in endogenous thrombin generation. Acquired activated protein C resistant normally increase in normal pregnancy, slightly decreased activated partial thromboplastin time, and increased the prothrombin time with INR less than 0.9. The platelet count usually within normal, except if there is gestational thrombocytopenia, as we're gonna see in a while. The platelet turnover is usually normal, and the bleeding time is normal. So these are the changes, the laboratory changes during normal pregnancy. Now, the complication during pregnancy could be, it has to be one of these three complications. It could be thrombocytopenia, bleeding, or thrombocytosis. And if the lady comes with thrombocytopenia, it has to be one of the four differential diagnoses. It could be gestational thrombocytopenia, immune thrombocytopenia, thrombotic microangiopathy, or acute fatty liver of pregnancy. And if there is bleeding, it could be primary or secondary postpartum hemorrhage, and in thrombosis, congenital or acquired thrombophilia. So coming to the thrombocytopenia, if the lady come with only isolated thrombocytopenia without any other symptoms, then the two differential diagnoses we have, either gestational thrombocytopenia or ITP. Sometimes it's difficult to differentiate between the two conditions, but these are factors that could help differentiating both of them. The commonest cause of thrombocytopenia in pregnancy is gestational, with high incidence, 70 to 80%, as compared to the second cause of thrombocytopenia, which is ITP, 3% only. The explanation in gestational thrombocytopenia, it's believed that it's due to dilutional effect because of the expansion of plasma volume. Whereas in ITP, it is antibody against the platelet. Whether there is a prior history of thrombocytopenia or not could help in gestational thrombocytopenia. In ITP, sometimes the ITP onset could be prior to pregnancy. This will be helpful to determine the cause, but sometimes the onset during the pregnancy, and you wouldn't know. Now, the platelet count usually is very mild in gestational thrombocytopenia, with the count between 130 and 150, whereas in ITP, usually it's less than 100. The onset of gestational in the second or third trimester as compared to any time in ITP. Spontaneous resolution after delivery usually is the case in gestational thrombocytopenia, but not always with ITP. With the gestational thrombocytopenia, the fetus will not be affected, but in the ITP, the antibodies will cross the placenta and cause neonatal autoimmune thrombocytopenia. The management will be observation in case of gestational thrombocytopenia, and ITP, it's almost the same as a non-pregnant lady, with the exception of NTD, and azathioprine will be avoided because of the safety issues for the fetus. Now, if the thrombocytopenia are combined by microangiopathy, hemolytic anemia, then the differential diagnosis will be one of the three differential diagnoses. Could be HELP, TTP, or atypical HUS. With the incidence more with the HELP syndrome. You know, HELP syndrome is a very severe form of preeclampsia, which is defined as a new onset of hypertension plus proteinuria after the age of 20 weeks. And the etiology of HELP believed to be the poor placentation of in the placenta, and both of the three cases will be presented with thrombocytopenia and have the elevated liver enzyme and low platelet. And the management for HELP syndrome, management of the pressure, and as soon as possible to take the lady for delivery, as the pathophysiology or the pathology in the fetus in the placenta. The TTP, the treatment with plasma exchange, and HUS with eculizumab. The TTP السلام عليكم. انقطع الاتصال.
We can hear you now.
I can hear you.
Okay. Just carry on.
Okay, I don't know what happened. Is it lost connection? Did you hear me? Because I'm in the middle of my presentation, actually.
Yeah, just
can
for
I
a few
just
seconds.
continue, or
yeah, please continue. You were just disconnected for a few minutes, for a few seconds. You can just
okay.
carry on.
So just continue. Okay, thank you very much. So with the HUS, the causative agent here is the congenital defect in the alternative pathway.
Can you share your
complement.
slides? Can you share your slides again?
Oh yeah, sure. Now you can see it, right?
Yes, yes.
Okay. So the causative agent here, or the abnormality here in the congenital, the alternative pathway of the complement in acquire atypical HUS. Okay. The last differential diagnosis of thrombocytopenia in pregnant lady is the very rare and life-threatening condition, which is acute fatty liver of pregnancy. The incidence is not well defined and it's variable through the literature. It is triggered by the microvasculature and fatty infiltration of the maternal hepatocyte, which lead to acute liver failure and result in the death of the mother and the fetus. The initial presentation is non-specific, GI symptoms. With the disease progression, they will be characterized by significant liver enzyme elevation and sign of hepatic dysfunction, such as encephalopathy, coagulopathy, and hypoglycemia. The diagnosis is based on clinical and laboratory signs, and the liver biopsy is the last resort. Now the bleeding in 30% of death in the mother accounts for the postpartum hemorrhage, and it is defined as a loss of about a liter of blood. According to the onset of this bleeding, within 24 hours, it is called primary, and if it's between 24 and 6 weeks, it is defined as a secondary postpartum hemorrhage. The primary cause, usually it is related to the uterine atony, retained placenta, and genital tract. The most important primary hemostasis to stop the blood after delivery is the uterine contraction. And if there is abnormality, this will lead to primary postpartum hemorrhage. The treatment with oxytocin and uterotonic agent and recent randomized controlled trial found that tranexamic acid use after delivery will significantly reduce the risk of postpartum hemorrhage. The secondary cause of bleeding, it could be one of these conditions, either von Willebrand disease, hemophilia, or the other rare bleeding disorder. I tried to summarize all the causes. So we'll talk about the von Willebrand disease, which is the most common. About 1% of the population affected by von Willebrand disease. It has 3 types: quantitative type 1 and 3, and qualitative type 2. In pregnancy, represent a challenge for the diagnosis of von Willebrand disease, as you saw that the von Willebrand factor will be upregulated during pregnancy. And in type 1, as it is partial deficiency of von Willebrand factor, it can reach to normal levels. So it is very difficult to diagnose a lady during pregnancy for von Willebrand disease, and it's better to start the investigation after 21 days post-delivery, as the von Willebrand factor will be returned to normal. The treatment using the von Willebrand factor concentrate is the preferred choice, as desmopressin is controversial. Some try to avoid it as it causes placental insufficiency or hyponatremia in the mother, and other reported that they are using in routinely with no complication. In hemophilia, you know that it is X-linked. It's either deficiency of factor 8, hemophilia A, or factor 9, hemophilia B. And the female, usually they are a carrier. Because of the wide range of the level of the factor in carrier state, it's preferred to check at least once and repeat it close to delivery to check the activity of the factor. If it's less than 40, then consider the replacement with factor. And it's very important to determine the gender of the fetus, as 50% of the male for the affected carrier will be affected by the hemophilia. And it is important to decide the intrapartum management or to avoid some, for example, the scalp, the forceps or venous extraction. The other rare bleeding disorder could be one of these deficiencies, and the treatment with either fresh frozen plasma or factor concentrate. It's very important to recognize the deficiency on factor 1 fibrinogen or hypofibrinogenemia or dysfunction fibrinogen, as the fibrin is very important in implantation of the placenta. Now, the third complication, which is the thrombosis, acute venous thrombosis could be pulmonary embolism or deep venous thrombosis. The pulmonary embolism in developed country remained the leading cause of maternal death, with an estimate 1 to 3 maternal deaths per 100,000 live births. The incidence of venous thromboembolism estimated to be between 0.5 to 2.2 per 1,000 patients, which is 5 times higher than the non-pregnant population. The diagnosis of acute venous thromboembolism is challenging because D-dimer is no more can be used as it's normally upregulated. So for diagnosis of DVT, use the compression ultrasound, and for pulmonary embolism, use the CT, pulmonary angiography, or ventilation perfusion scan. And the treatment, the therapeutic low dose, dose of low molecular weight heparin is a preferred choice during pregnancy, and has to be stopped about 24 hours prior to vaginal or cesarean section to allow for regional anesthesia, and resumed back 4 to 6 hours after normal vaginal delivery, 6 to 12 hours after cesarean section. The thrombophilia, which is the increased coagulation, increase the procoagulation or the tendency to thrombosis, it could be congenital or acquired. The congenital cause of thrombophilia, it include but not limited to these: factor V Leiden, prothrombin G, deficiency in the natural anticoagulant protein S, C, and antithrombin 3. And it has been found that the inherited thrombophilia present in 50% of the venous thrombotic event that occur during pregnancy and postpartum. And the presence of thrombophilia does not always lead to the thrombotic event. Now, the acquired thrombophilia, unlike the congenital thrombophilia, which we can say it is relevant or it is equivalent to antiphospholipid syndrome, shows a poor pregnancy outcome, the association with a poor pregnancy outcome between the antiphospholipid syndrome and the poor pregnancy. It is defined, the antiphospholipid syndrome defined as autoimmune disorder characterized clinically by one of these: venous or arterial thrombosis, recurrent first trimester miscarriages, fetal death in the second or third trimester, or preterm birth due to severe preeclampsia or placental insufficiency, plus the laboratory finding, which is one of these antibodies, either lupus anticoagulant, anticardiolipin, or anti-beta-2 microglobulin. And it has to be measured twice, about 12 weeks apart. Now, for congenital and acquired, there is a difference in terms of antepartum and postpartum prophylaxis, the use of anticoagulant. For congenital thrombophilia, an attempt to quantify the relative risk, you have to quantify the relative risk of VTE, which considered to be the highest among those patients with homozygous factor V Leiden, prothrombin G, or combined heterozygous factor V Leiden and prothrombin gene plus the antithrombin 3 deficiency. And according to the relative risk, whether to use or not to use the prophylactic anticoagulation. Whereas in acquired hemophilia, the use of heparin, either unfractionated or low molecular weight heparin plus the aspirin, show a significant reduction in the fetal loss or the miscarriages. The use of postpartum thrombophilaxis in patients with persistent antiphospholipid.
2 minutes left.
Yeah, sure. Okay, I'm in my last slide actually. The use of postpartum thromboprophylaxis with antiphospholipid syndrome is not clear yet. And there is a consideration to use postpartum prophylaxis with low molecular weight heparin for at least 6 weeks postpartum. Finally, I'll just talk about the screening in complicated pregnancy. For the congenital thrombophilia, it hasn't been shown, the guideline is not to screen for congenital thrombophilia, as a recent clinical trial showed that there is no significant effect with the use of antiprophylaxis to reduce the risk of VTE or the pregnancy loss. Whereas in acquired thrombophilia, it is recommended to screen with a history of complicated pregnancy. I'm ending with my presentation, and thank you very much.
Dr. Samira Safwan, thanks a lot for the very brilliant summary about the obstetric homeostatic complications. We have one question for you. And the question says, what platelets count would you allow for delivery, and does it matter which condition and what mode of delivery for the count?
Okay, thank you very much for this question. The level for platelet, the safe level of platelet count is 30,000 for normal vaginal delivery. And if the lady going for cesarean section, it has to be 50,000. If epidural to be used, as you know that there will be involvement of CNS, then you have to go higher, about 100,000 per microliter. Then the next part, which condition and what mode of delivery, it doesn't matter as long as you have a safe level of platelet count. It depends on the condition of the mother rather than the platelet.
Perfect. I think that's all. That's all for you, Dr. Samira. Thanks a lot. And let's move. Oh, we have another question that just popped up. Is it useful to use the cryo to reduce treatment?
Well, the question is unclear.
Yeah,
what does it mean? I think maybe something missing.
Yeah, it's from Fahd al-Sharif. If you can please clarify. We still have time. I think he could be in the postpartum bleeding to raise the fibrinogen, if I'm not mistaken. Cryo for the treatment.
For the treatment of which condition?
Yeah, it's not clear.
To use FFB for what? Just to specify which condition you are talking about.
Yeah. We're still waiting. Okay, another question. Is there any rule for prophylactic low molecular weight heparin in patients with recurrent miscarriages without evidence of thrombophilia? What do you think?
Okay, is there any rule for prophylactic in the use of miscarriage without evidence of thrombophilia? Well, I cannot answer this question actually. There is no evidence of thrombophilia, then they use just for blindly. I cannot answer that question, actually. Maybe this is gynecologists need to answer you. I believe that some gynecologists can use it. I have seen some cases they use it, even if they don't have just the last resort. But I don't know.
I don't think this practice, even giving low molecular weight heparin or aspirin blindly for miscarriages.
In fact, this is not practice, but I've seen it in some cases.
Yeah, we see it a lot, but I don't think it's the correct thing to do. Okay. Dr. Samira, what do you think in the terms of postpartum hemorrhage? What do you think is the minimum amount of fibrinogen would be, and is cryoprecipitate, does it have a vital role? Do you recommend fibrinogen concentrate transfusion to those
fibrinogen for the use of postpartum hemorrhage? I haven't come across the use of fibrinogen. I don't know, actually. I cannot answer this question, but the transexamic acid, which shows the significant reduction of the risk of bleeding postpartum. But the fibrinogen in the without hypofibrinogenemia, you mean the lady doesn't suffer from deficiency, or she doesn't have dysfunctional fibrinogen? What is the use of fibrinogen then? I don't think so.
Okay. Yes, maybe it's good to highlight the latest NEJM study, which has used the prophylactic tranexamic acid to prevent postpartum bleeding for ladies who underwent cesarean section. Okay, we have Prof. Fahd al-Sharif. He sent again. If the patient needs to transfuse or diagnose with ITP, which one is good to use for the transfusion of platelet or cryo, reduced plasma or platelet in order to prevent bleeding? Yeah, in the transfusion for patients in the setting of ITP, what's your recommendation?
Yeah, and the setting of ITP, you mean a pregnant lady, if he's talking about a pregnant lady, I think, right?
Yes, yes.
Well, the treatment in pregnant lady with the steroid, low dose steroid and IV immunoglobulin, and the platelet transfusion only if there is bleeding. Because it's ITB, you don't give just blood transfusion, platelet transfusion, and there is autoantibody which will be destroyed. If you don't treat the cause of thrombocytopenia, which is the antibody, you have to use the steroid. The critical issue here, or the significant treatment, is with the use of steroid and the IV immunoglobulin, not only the platelet transfusion. Platelet transfusion only if there is bleeding. The patient is symptomatic and she has a bleeding. And with the use, of course, of steroid and immunoglobulin. And if there is refractory, it's refractory, then they can go for splenectomy and other more advanced treatments with the ITP.
Yeah.
I hope that answered.
Okay, Doctora, we have to
let's move to the next speaker.
Yes.
With you, Dr. Rabab.
Yeah. Okay, we'll move to the third speaker because of the time. We are already 3 minutes late. Our third speaker is Dr. Muhammad Ashif. Dr. Muhammad is a consultant internist with subspecialty in thrombosis and vascular medicine in King Fahd Specialist Hospital. And in King Fahd Medical City since 2010. Dr. Sharif is a research advocate in thrombosis and pregnancy with long-standing experience in this field. And he is a certified enhanced physician communication skill facilitator from Mayo Clinic. Dr. Schiff is gonna also talk about impact of COVID infection on hematology and transfusion medicine, both the infection as well as the vaccine. Dr. Muhammad, please go ahead. Dr. Muhammad, can you hear us?
Yes. Assalamu alaikum wa rahmatullahi wa barakatuh. Do you see my slide?
Yes.
Yes. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, ladies and gentlemen. I would like to start by thanking the organizing committee for such wonderful conference and giving me the opportunity to share my experience in the topic of COVID-19 coagulopathy and VIT vaccine-induced immune thrombotic thrombocytopenia. So first of all, so this is I'm going to present about the hematological complications of COVID-19 infection and VIT or COVID-19 vaccine. First, I would like to start by highlighting my objectives. After attending this presentation, you will be able to review the cross-link between thrombosis and inflammation, discuss the common coagulopathic abnormalities in COVID-19, provide practical guidance for the prevention of thrombosis and management of coagulopathy in COVID-19. And also, last will be vaccine-induced thrombocytopenia, epidemiology, pathophysiology, diagnosis, and management. So, you know, the COVID-19 data, there is a tsunami of data. Physicians are really drowning in COVID-19 papers. And also lately is the vaccine immune thrombotic thrombocytopenia. So very difficult to catch up of all, you know, literature about COVID-19 thrombosis and VIT. However, I will try my best to cover the landmark study and the most important, you know, and burning issues in this field. So these are, you know, my outlines of my presentation. So I will change the pointer to laser. See, these are the outlines of my presentation. I'm gonna take you through some case scenarios, the COVID epidemiology, COVID-19 epidemiology, the VTE in COVID-19, the cross-link between thrombosis and inflammation, because this is the key part of the presentation. What's, you know, D-dimer clinical applications, what's the anticoagulant therapy for COVID-19, and the updated guidelines of thromboprophylaxis of COVID-19 and VIT, and then summary and key points. Starting by first case scenario, we have this patient who is a 45-year-old female with no chronic illness, so previously healthy. She was brought to the hospital after a transient loss of consciousness at home, following a 2 weeks history of dry cough, shortness of breath, and a 3-day history of palpitation. So she was found to have severe stroke, right-sided weakness, severe based on an IHSS score, and she was desatting in the meantime and hypotensive. So she was diagnosed with a massive PE, an acute stroke, splenic and renal infarction, and COVID screen came back positive, unfortunately, after the patient died. It was a stormy course. So this is the pulmonary embolism. It's a typical saddle pulmonary embolism. It is occluding the bilateral left and main arteries. So there is here subpleural ground glass opacity. So this is suggestive of COVID. There is another patient who presented to us. He's a 50-year-old male with no chronic illness. He was diagnosed with unprovoked massive DVT with limb venous threatening gangrene, what we call it phlegmasia cirrhola dolens. Maybe this is, you don't see it frequently these days, probably maybe 10 years ago. Now with the advancement and early diagnosis of VTE, you don't see such late clinical presentation. However, these cases I presented was during the, the early, phase of the pandemic. During that time, we have quarantine, not quarantine, we have curfew. So this patient, he presented with, severe clinical presentation, and it was the COVID screen was positive, and he have also chest changes suggestive for COVID-19 bilateral ground glass opacity. So this patient also found to have very interesting. This patient, we are writing up this case, found to have antiphospholipid antibodies was very high, anti-cardiolipin and anti-beta-2. However, this patient was managed successfully with catheter-directed thrombolysis, and we used the technology which is pharmacomechanical angiojet. So this is completely occluded. This is it was opened up, and there was a stent, mesh stent was placed. This patient see the leg compared to the initial presentation. So there is a remarkable improvement in the color of the leg. So this is the normal leg. We repeated the antiphospholipid antibodies after 6 months, came back negative. So this is just, there are some literature I'm going to talk about. You have transient positivity of antiphospholipid antibodies. Then we have this is the case of VIT. VIT, it's more recent, compared to their case. We start to see these cases from April, and onward. Yes, it is quite, rare disease, but however, it is associated with substantial morbidity and mortality and devastating disease. So this is a 35-year-old female on combined oral contraceptive pills who developed severe cerebral vein thrombosis 7 days post-COVID, vaccine, AstraZeneca vaccine. And this patient described her experience. This is the worst headache ever in her life. So this patient was managed, successfully with non-heparin anticoagulant drug, and she just came to clinic last week doing fine. So now moving to the epidemiology. So, the epidemiology, I will not, I'm not going to dwell for a long time on this topic. Now, alhamdulillah, COVID pandemic is under control. So this is the latest, epidemiology we have today. We have 48 cases only, and the total cases we have about more than 500,000. The etiology, we know it's the SARS coronavirus 2, which is RNA virus that belongs to the beta coronavirus genus. The pathogenesis, why, like the first case scenario I presented to you, why we have such a stormy clinical presentation, we think, that this is a response, exaggerated immunological response to the virus, to the viral antigen, that we have what we call, cytokine storm syndrome, that our immune cells release pro-inflammatory cytokines and chemokines that result in uncontrolled systemic inflammatory response, which look like macrophage activation syndrome or HLH. So this is we think this is the reason, that why we have all what we call, where do we stand right now? I think this is the vaccine. This is what really changed the equation. Now the number of cases, as you see, under control globally and locally in Saudi Arabia. We have all these, open buffet approach, but gonna focus about the anticoagulation, which is my topic here. Just this is for important point to address. COVID-19 is currently recognized as hypercoagulable state. It is polyvascular disease. It does not cause only venous thrombosis. Yes, yet it is the most common venous thrombosis. It can cause VTE, DVT, and BE. It can also, cause arterial stroke and coronary artery disease. I'm sure people covering, COVID-19, floor, you'll see these cases. Also can cause what we call microvascular disease, like you have leukocytoclastic vasculitis or microvascular presentation. This is like the video reticularis you can have in these patients. So this is really a puzzling disease. It's not only a simple virus like H influenza that cause only infection. So this is very, it's a virus that causes induce hypercoagulable state. We think that it can induce DIC. Some people, there are two, theories. It's local pulmonary DIC, pulmonary vascular thrombosis with subsequent activation of fibrinolysis, like they have vascular microthrombosis. This is the thing that the cause of ARDS in these patient with, COVID-19. They have vascular microthrombosis in addition to the infection. And also development of DIC is due to also systemic activation of cytokine producing monocytes such as interleukin-6, tumor necrosis factor, which in turn induce activation of the endothelial cells and tissue factor that triggers the blood coagulation cascade. So the activation of blood coagulation is essential. Usually this is a physiological protective phenomenon. So the activation coagulation cascade is essential in counteracting viral infection, along with the immune system, trapping, to trap viruses by forming fibrin network, thus limiting their dissemination. However, we have what we call this the cytokine storm syndrome, is massive inflammatory and coagulative response, against the virus that, trap the virus, with the, fibrin network. In addition, can cause widespread thrombosis. So pulmonary we call it pulmonary immunothrombosis. So you have this is the post-mortem finding indicate indicate microvascular thrombosis and hemorrhages in the lung. So we can have the cytokine storm syndrome that lead to endothelium activation. We call it also new term endotheliitis. They have endotheliitis, these cases that lead to increase the tissue factor that activate the coagulation cascade leading to thrombosis. This is the main mechanism. So it can be local in the lung and can be systemic as well. So this is the pulmonary post mortem changes in a series of COVID-19 cases from northern Italy, and they saw this is fibrin deposition or microvascular thrombosis or fibrin necrosis. So what's the cross link between thrombosis and inflammation? So remember that we consider the COVID-19 virus as a procoagulant, like infection, like any other infection. It will, activate coagulation cascade that will lead to activate conversion of fibrinogen to fibrin, and then clot. Then we'll have clot formation that will undergo clot lysis or fibrinolysis. That's why we have to, abort this, process, by, administering the VTE prophylaxis or thromboprophylaxis to prevent the formation of blood clot, in this virus. So this is, you have thrombosis and inflammation that go hand in hand. And so this is the, COVID-19 virus. So it will activate endothelium or vascular endothelium, also activate the mononuclear cells, both that will, secrete the tissue factor, that will lead to tissue factor mediated, coagulation activation. These activate through, pro-inflammatory cytokines, IL-6 and the tumor necrosis factor that lead to thrombin generation and fibrin formation. So severe COVID-19 generates an increase in pro-inflammatory cytokines and activates endothelial cells. So this is the mechanism that have neutrophils, mononuclear cells, and platelet, leading to the tissue factor mediated activation of the coagulation. This is the inflammatory response to COVID-19 result in the activation of the coagulation that itself may modulate further inflammatory activity. So this is the way that you have, why we have, because we have, activation of coagulation is quite substantial, that leading to high, D dimer compared to other, viral, infection. So if you have more activation coagulation, you'll have more, fibrin degradation products and high D dimer. So this is, as I told you, it could be systemic or could be, this is what we call local DIC in the lung, because the lung tissue is rich in fibrin. So you'll have enhanced turnover, fibrin turnover in the lung due to severe lung inflammation. So what's the clinical application of D-dimer? It's a marker of coagulation and fibrinolysis activation. And also D-dimer, now this is just, we have never heard about that D-dimer is used as inflammatory biomarker before, I mean, COVID-19 pandemic. So we used to request D-dimer only to roll out DVT because it has excellent negative predictive value. But nowadays, it's been used as inflammatory biomarker in COVID to assess the severity of COVID-19 infection. Also used in diagnostic, in diagnosis of VIT. So D-dimer, a biomarker of disease severity and mortality in COVID-19 patient. It's a pro-inflammatory marker. So D-dimer, it's also we call directed decisions in many established risk situation. Also, we use it to for to determine the duration of anticoagulation as well, okay, for patients who have unprovoked or idiopathic venous thromboembolism. So D-dimer is not specific, as we know, of VTE because it's elevated in many or variety of conditions: pregnancy, inflammation, old age, surgery, bed rest, COVID-19 infection, and also VIT, cardio, also cerebrovascular disorder, also in stroke and acute coronary syndrome, cancer, and DIC. Always, that's inpatient hospitalization, patient with usually medical patient, they are confined to bed or bedridden, and they have multiple comorbidity and old age. So it's always will be high among hospitalized medical patients. So it's not, should not be used, to roll out DVT for this patient. So that's why the reason why D-dimer is not used to confirm the presence of a disease, but used as exclusionary parameter to rule out VT. The patient will never care how much you know until they know how much you care. So VT in COVID-19 patient. So there seems to be a high incidence of venous thromboembolism in COVID-19 patient. And there is increasing, reports and case studies showing a high incidence of VTE and COVID-19 infection. Some you find it about you have a wide spectrum up. You have 15 15% up to 35%, and it is variable whether the patient is inpatient medical floor or a critical care setting. And it is also variable from country to another. And it's unclear whether this is more than usual in a critically ill patient, but really I think it's more in the critical ill patient. And undiagnosed pulmonary embolism could contribute to sudden and unexplained, respiratory deterioration in this patient and sudden death. As we know, VT is the leading, PE is the leading preventable cause of death among hospitalized patient. And usually prevalence of VTE among, patient with COVID, they found, most of these patients, about 25%, I told you it's a variable, like this is 25%, and most of them, they have high D-dimer. Patients who have VTE, they have high D-dimer 5.2 and no VTE 0.8. So the cutoff D-dimer, most the studies they use one, more than one. This is really, indicate patient might have VTE in COVID-19 patient. And also these, the randomized controlled trials, more than one, they are, this is one the inclusion criteria to start to upgrade VTE prophylaxis from standard dose to use half therapeutic, anticoagulation or therapeutic anticoagulation. That we're going to talk about it in the subsequent. So this is higher incidence of thrombotic complication and COVID-19 compared to influenza. And you can see here that this is a COVID-19 patient. After 30 days, you have 3.8% in general ward patient. However, all patients, including ICU, you'll have 18.7. Like in the ICU, only 15%. And compared to influenza virus, about 1.04%. So there is really significance, it's more hypercoagulable than other common respiratory viruses like influenza. So this indicating that, incidence of also for arterial thromboembolism, it is, they did not compare with the influenza, but it is also, it's high, 1.5% in ward patient compared to all patient 3.4%. So conclusion, the incidence of thrombotic complication in hospitalized COVID-19 patient was substantial and considerably higher than that in hospitalized influenza patients, suggesting a possible, specific effect. And further studies are needed to substantiate these, findings and to explore explanation for the large difference. Also, the D-dimers. So this is another study interesting that, COVID-19, about 450 patients almost compared to non-COVID-19 like bacterial pneumonia. And they found that, D-dimer is not only elevated in COVID-19, but also, COVID and pneumonia also elevated in other, bacterial pneumonia. And this is even, it is higher, but I think this is, I have critique for this study. This is smaller numbers. And so here we have here 104 patients compared to, this is for 50 cases. I think in our clinical practice, and all of you, my colleague who covered the world hospitalized COVID-19 patient will see very, high or sky high elevation of D-dimer compared to other infections. So just the message that D-dimer is not only elevated in COVID-19, infection, it's also elevated in other, bacterial infection, but to less extent compared to, COVID-19. So this is incidence of thrombotic complications among, critical care patients with COVID-19. This is one of the important study. They look for the incidence of, arterial venous thrombosis among critical care patients in Netherlands or Dutch, population, and they found the about 31% incidence of thrombotic complication is remarkably higher, in spite these, patient on standard dose prophylaxis, what they are using there in country nadrobarine, which we don't have it here. It was adjusted even also for weight. In spite of that, these patients, have higher. I think this study set the stage that we are using, intensifying thromboprophylaxis for these patients. We are using therapeutic anticoagulation and using, half therapeutic anticoagulation. Also, so D-dimer here, just to show you that more than one, really that they found non-survival. They have, most of them, they have 81%, they have D-dimer more than one. And for versus survival, they have, only 24% they have D-dimer more than one. That's why D-dimer 1 is the cutoff used, help clinician to identify patient with poor prognosis at an early stage, or to, intensify thromboprophylaxis for this patient. And very important point that we should not be, this is one of the important study, we should not only rely on single study. This is a dynamic, disease. Usually upon, presentation, the D-dimer, you might be low. You have to follow, the trend for this patient and markedly increasing D-dimer levels 3 to 4 fold over time associated with high mortality. So this is important. That's why we have to request usually serial, D-dimer for this patient, because they found that markedly elevated dimer and fibrin degradation product are common in deaths with, COVID-19 pneumonia. They have signs of coagulation activation mimicking DIC, this patient, but slightly different from usual sepsis induced because they have less prominent thrombocytopenia and they less consumption of coagulation parameter. Most of these cases, I covered the floor, covered the floor, probably 10, cycles or 10 rotations. We don't see commonly thrombocytopenia patient, and we do see these patients thrombocytopenia if they have concomitant, heparin-induced thrombocytopenia, or this patient at late stage in the critical care where they have, full-blown, DIC, and they are, dying, this patient. So abnormal coagulation results are associated with poor prognosis. If you have this, you mean patient, this is a late stage, and existence DIC is common in deaths with COVID-19 pneumonia at later stage. But early stage, most of them, we have very sky D-dimer, sky high D-dimer. However, the platelet is normal and PT, ABTT are normal. So this is the evolution of coagulopathy in COVID-19. So we have the COVID infection. You can have first high D-dimer and 5
You have 3
radical
minutes
product.
more, Dr. Shif.
How many?
3 minutes more.
Oh, okay. I'm not managing my time well. So I will try to move to highlight the most important. So just I mentioned before, just give me 5 minutes. I will appreciate it, not more. So COVID
Sure.
also associated with transient positive, you know, antiphospholipid antibodies like low-dose anticoagulant that usually, you know, normalize after recovery from infection. Also that we have found that this is one of the publication in New England Journal of Medicine. They have 3 stroke patients who have antiphospholipid antibodies positive. You know, what's the indication for extended thromboprophylaxis after discharge of COVID? So this study does not really support this, you know, hypothesis because there is a very low incidence of VTE after discharge. In our clinical practice, we are really case by case basis. Some of cases who have high VTE risk factor, immobile patient, previous VTE, we do extend the prophylaxis up to 2 weeks. Remember, heparin, it's not only you know, anticoagulant, also it has anti-inflammatory effect. That's why this is the rationale in the clinical trial. You know, we have one of them, it was published as a preprint. We participate in this study from Saudi Arabia. It was published preprint in British Medical Journal, and we are waiting for final publication. This is a study that showed really heparin for moderately ill patient. We did not include ICU or critical care patient. This patient, we really found that it does decrease mortality if patient early within like 48 hours up to 72 hours, and we D-dimer more than 1. And they are not yet, you know, requiring intensive, invasive, you know, ventilation or non-invasive ventilation, or in the ICU, if we use therapeutic anticoagulation, you can decrease the odds of death at 28 days. Also, this is the same as publication New England Journal of Medicine, and they found this is non-critical ill patient was associated with decreased mortality. But in critically ill patient, so this is sorry, the critically ill patient, they found that it has no, you know, impact on reduction of mortality if the patient already presented late to ICU if they were started on anticoagulation. So this is I will move on, skip the guidelines. The guidelines, this is published before the publication of, you know, 3 randomized controlled trials, just I mentioned in New England Journal of Medicine and British Medical Journal. Just the VET, you know, started the first case of the VET in April because the vaccination starts on March, you know, and we started to have rare, you know, cerebral vein thrombosis, and this thrombosis with thrombocytopenia syndrome is VET. It is, you have to meet all 5 criteria. COVID vaccine 4 to 40 days prior to symptom onset, any venous or arterial thrombosis, thrombocytopenia platelet count less than 150, positive platelet factor for HIT, heparin-induced thrombocytopenia, or markedly elevated D-dimer more than 4 times upper limit of normal. Incidence is luckily is extremely rare, about 1 in 250,000, or about 4 cases per million. And you know, you need to have urgent, you know, medical evaluation for VET cases. If the patient is like post-vaccine within the time frame 4 to 42 days, severe headache, visual changes, abdominal pain, because these cases, they usually have unusual site thrombosis, different from the usual VTE, DVT, and BE. So this is thrombotic thrombocytopenia. This is one of the case publication, April 9, by Ted Warkenton and Andreas Granster. They are the godfather of HIT. So these are series of publication we have about, remember, it is more common with adenoviral vector vaccine, which is, you know, Johnson and Johnson and AstraZeneca. However, it can occur in, you know, messenger RNA vaccine like Pfizer and Moderna. So these cases, typically they are young and more female, young, like about, from, you can see 22 up to 49. And this is unusual site thrombosis, usually cerebral vein thrombosis and abdominal vein thrombosis, and usually treatment, it's similar to, the VET is similar to heparin-induced thrombocytopenia. exactly the pathophysiology, the management. We have to avoid heparin and use non-heparin anticoagulant like fondaparinux, IVIG, IV immunoglobulin also used. Avoid blood
Dr.
transfusion.
Schiff, can we close now? Please, conclusion remark.
Yes, I'm concluding my presentation. The most common pattern of coagulopathy observed in patients hospitalized with COVID-19 is characterized by elevation in fibrinogen and D-dimer. This correlates with parallel rise in markers of inflammation like CRP, ferritin, LDH, and IL-6. Unlike the pattern seen in classic DIC from bacterial sepsis or trauma, the thrombocytopenia is mild, elevated D-dimer at admission, and markedly increased D-dimer level over time associated with high mortality. And the efficacy of intermediate or full therapeutic anticoagulation for critically ill COVID-19 patient without documented VTE, it's not, it was negative study. However, it was positive in patient with moderately ill COVID-19. Prophylactic dose, heparin or fondaparinux. Still the guideline, they recommend the prophylactic dose to use of standard dose prophylaxis. Also, mechanism of development of prothrombotic state and relationship to vaccine, which is VIT, is unknown, but similar to what we call autoimmune HIT or de novo HIT, and patient-specific factors to VIT are not clear, but some of them like OCP and postpartum or have family or person history of VTE, they seem to be patients who develop VIT. With this, I will conclude my presentation by a few words of gratitude for all healthcare provider working at the front line treating COVID-19 patients. You are indeed the superheroes. Thank you very much for your attention.
Thank you very much, Dr. Muhammad. And the door now is open for question and answer. Because of the time, you might have only two questions.
I'm sorry for being late. Okay.
Okay, Dr. Noor, you have a question?
No, thank you. Carry on.
Yes, Dr. Muhammad, can you see the one of this question? The one question is, do you recommend thrombobox after discharge of COVID treatment patient in ICU, and how long? We can't hear you, Dr. Muhammad. Hello?
Okay, sorry, yes. The ICTH.
Did you hear the question?
Yes, I hear the question. The ICTH, International Society on Thrombosis Hemostasis, they recommend extended VTE prophylaxis, up to 2 weeks, case-by-case basis. Like the case you mentioned, post ICU, admission, I usually recommend to give short course of thrombophlex up to 2 weeks. It's not wrong, but it's not recommended. Like if you don't give, you will be, mistaken for that. Also, there is another more hot topic to give thrombophlex post-COVID-19 vaccine for patients who are really at high risk, who have previous history of VTE, like provoked by transient risk factor that are off anticoagulation. Really, some expert, they recommend to give short course, probably a week to 2 weeks. And this is my practice. I give for these patients who have very significant past history of VT and currently off anticoagulation. If they are on anticoagulation, I don't stop. I continue to overcome the prothrombotic state of the vaccine. Yes, it is rare, but it is devastating.
Okay, thank you. And we'd like to apologize for those who typed their questions, but I'm sure the speaker can type the answers among the panelist group, and we'll move to the last speaker in this session. Dr. Noor?
Thank you. Thank you, Dr. Rabab. Let's move to our next speaker, Dr. Saeed Turki, a consultant He's the Chief Executive Director of Anwar Medical Laboratories, and he's a consultant of laboratory of the Hub Center, Ministry of Health, consultant molecular genetics in King Khalid University Hospital. Thanks a lot for joining us today, Dr. Saeed. You have 25 minutes, and please type the questions in the Q&A. The floor is yours. Thank you.
Thank you very much, Dr. Noor. Assalamu alaikum wa rahmatullah. Can you please confirm if you hear me?
Yes, and we see the
Perfect.
slides. Perfect.
Excellent. Thanks a lot. Good evening, ladies and gentlemen, and thanks very much for the organizing committee for their kind invitation. These are my disclosures. And we will shift gear a little bit to the molecular diagnosis of hematolymphoid malignancies. And, you know, in the last century, half century, since 1970s, we witnessed 5 major breakthroughs. The first one was in 1970s, when cytogenetics using microscope shed some lights in the chromosomal abnormalities. That was followed by genius method development by Sanger, the British scientist, who not only won 2 Nobel Prizes, one for sequencing the DNA and the other one for protein sequencing as well. And then we added some colors to the chromosomes using the amazing FISH, which added higher resolution for the chromosomal abnormalities. And in 1985, we met with the PCR, and this is the beating heart of the modern molecular biology as we know it today. And without it, we would not see major advances in our knowledge. And finally, in 2010, the new kid on the corner, the next generation sequencing, which brought a lot of lights into new mechanisms, novel mutations and fusions. And today we will see, you know, is it time to ditch what we know or what we used before, you know, the old methods, the cytogenetics, the FISH, in favor for the new kit, the NGS? And if yes, how confident are we, and how is that affecting our clinical practice, and are we ready for it or not? And during the 50 years, our knowledge in the classification has advanced as well for the acute myeloid leukemias, the chronic myeloids, the myeloproliferative disorders, and the lymphoid as well. So all this new classification that's coming to light every now and then is fueled by the molecular biomarkers. And I have listed here 5 major biomarkers. This is not everything, but the major ones. Single nucleic acid variants, the SNVs, insertion deletions called indels, copy number variants, fusion, and clonality. And if we link it with the history, we would see that the karyotype is able to detect 2 major groups, the copy number and the fusions. If we look at the FISH, it's actually detect the same groups, but with a higher resolution at the DNA level or the RNA level. Real-time PCR, on the other hand, has opened the floor for capturing other molecular lesions or biomarkers, from single nucleic acids to indels to fusion and even the clonality. And capillary sequencing is adding another layer, which enable us to not only detect the known mutation, but as well the variant, because we can read the DNA sequencing as well. And the arrays, although started probably 20 years ago, is still a fantastic tool for the copy number variants, but it is limited to only that group of biomarkers. This is recently published by the Saudi Society of Blood and Marrow Transplantation. This is the consensus in the treating the AML by Dr. Badr Al-Ahmari and the team. And you see here the classification or the steps of the workup for the AML patients, from the morphology to flow cytometry. And at every step, we are using one of the tools that I mentioned earlier, the karyotype or FISH. And as we move forward, we use PCR and sequencing. So multiple methods are being used to start or to finish the diagnostic workup for one patient. So it is really a jigsaw puzzle solving. The clinical team, hemato-oncologist or a hematopathologist together are trying to pick all these small biomarkers from different methods. Some are old, some are new, and stitching together the big picture to treat the patients, to give them a new treatment, to select the treatment, to do the diagnosis or prognostic classification. So with this in mind, let's think of the current standard of care where we use multiple methods as a big jigsaw, where we use morphology, flow cytometry, karyotype, FISH, PCR, fragment analysis, into trying to build up the picture regardless of what's the malignancy. What NGS is promising is decreasing this jigsaw puzzle by introducing, actually removing the need for just PCR fragment analysis. I highlighted them in gray now. And beside the basics, the morphology, karyotype, FISH, we just need a small panel to avoid using single gene testing. And this is what's have been happening in major institutes in the last 3 to 5 years. But also, so let's compare, what's the number of tests per approach. With the clinical standard of care, we are looking at least 8 different tests. The turnaround time between 3 to 5 weeks to have everything ready. And the cost is a little bit high, but it's now has been standardized. If we introduce the NGS, we are looking at 5 different tests on average. The turnaround time should decrease, hopefully to 2 to 3 weeks. The cost will slightly increase because NGS is an expensive technology. However, I think we are moving toward the whole genome sequencing, where we sequence everything. And this is going to be disruptive because it has the potential to remove the need for karyotyping and FISH to some extent, and enjoying what's the smaller panel is giving us. And today we will see how far are we from this, because there is a big promise here. The promise here is we will only need 3 tests, morphology, flow cytometry with the NGS. It will take 1 week or less, but it will cost a lot because whole genome sequencing by nature is very expensive. But the cost of sequencing is decreasing as we, year by year. So this is a big promise. It's disruptive. And in the next 10 minutes or 15 minutes, I will share with you the answer to some question. For example, how much we can trust this new technology compared to the standard of care. The second, what's the turnaround time and is it realistic or not? And then we'll share the good, the bad news for each of these technology and the promises and see where we're at. So the NGS is promising, is very exciting because it's promised to detect theoretically all of the major molecular biomarkers. And unlike the other methods, it can detect everything, but there is a big caveat here. We say this in theory because in practice, NGS is not one type. There is multiple types, multiple methods, multiple panel design. And I think this is the time where from now on, we should have an intimate understanding of actually the panel design, what's the caveat, because different technology will introduce different error models and different sensitivity and specificity as well. And we'll take some couple of examples. So the current standard for the NGS as we know today, the small panel, most labs will buy commercially available panels, and they will extract DNA and RNA from archived samples or peripheral blood. And we need the DNA for 2 things mostly, the point mutation, like JAK2, for example, mutation here, insertion deletion, like FLT3 tandem repeats. And in the RNA level, we are looking for translocations or the fusion. Here is an example of PML-BRARA. One of the most commonly used panels in the region, especially in Saudi Arabia, is called Oncomyloid Research Panel. And for one reason, it's the support from the company is good. It's relatively cheap. And you see at the DNA level, there is 23 hotspot genes. and 17 gene with a full sequencing. That's mean all the coding region is being covered, for example, in TP53. At the RNA level, there is 29 genes, the usual suspects, BCR-APL, NTRK3, and others. And there is an expression gene, 5 of them. One of them is MEK, and it's important for the expression. So what's the good news? There was a study on this panel to validate it compared to the standard of care at the University of Alberta in Canada. And they picked up more than 70 patients. Some of them have unique mutation that is of interest, like FLT3, NPM1, CBP alpha, and they have 45 also fusion positive. And these fusions include different translocation and inversions, like the T8 to 21 chromosome, 15 to 17, etc. So how did it perform? At the DNA level, the positive predictive value was really great, 97%, which is highlighted here in red. So we missed a little bit. So what did we miss at the DNA level? Well, one is we missed at the indel group, less than 5 base pairs. We missed, instead, it was 21 patients detected the mutation, but through this panel, we detected 18, so we missed 3. And in CBP alpha, which is notoriously difficult gene to sequence because of the high GC content, we missed 1 patient in this cohort. But when we look at the single nucleic variants, all of them are detected, as well as the large indels and the FLT3, all of them are detected. So this is really great performance at the DNA level. So let's go to the fusions, which is usually detected by karyotype or FISH. Here you see there is different kind of fusions, PMR-VARA, RUNX, BCR-APL, MYH11. And the great news is all of them were detected 100%. So that is a great performance at the RNA level, a little bit more better than the DNA. So now let's have a couple of, what's the bad news here? Other papers have compared the commercially available panels in GS panel for the myeloid, for example. Here we see 4 of them, 2 from Sophia Genetics, 1 from Oxford OGT, and the last one from Illumina. Different design, different content. And you would think, at least the known genes are all covered, but you will be actually surprised. This is the list of the gene in all of these 4 panels. The black dots, meaning is not covered in that panel. So each vertical is 1 panel. So you see there is a very different design. And when we look at the mutation called, all patients were sequenced using all these 4 panels. You will see in the middle, there is only 19 mutations shared by all the 4 genes. And some panels has their own specific mutation. If you look in more details into this, you will see the average number of mutation per panel is different. 2 of them called around 25 on average, the other 2 called 15, so they missed 15. And if you think, some of them are not of clinical interest, you are right. So let's look at the actionable that will change the diagnosis or change the therapy selection. And you will see here, the patients were color-coded. So the patient in yellow, for example, is missed from the 4th panel, while the one is in the red is missed from 2 panels. So there is a huge impact actually on the clinical reporting based on just buying the wrong, not the wrong, but let's say one of the commercially available panels, which tells us there is a lot need to be done when it comes to validation, careful selection of the gene, and absolutely intimate understanding of what's the content and what's of that panel and how it will affect the way we report the patients. And the other bad news here for usually these smaller panels is, yes, they are good for the point mutation, indels, and translocation, but they are horrible for copy number variants, as well as, so we still need karyotype and FISH for those, if we are dealing with large deletions. And we also need, for copy neutral loss of heterozygosity, we still need arrays of karyotyping. And for the immunoglobulin, the T cell receptor rearrangements, it needs BCR or special NGS. So it's not all bad. It's really great. It's removed the need for single gene testing. But in the same time, we still have major biomarkers that still need karyotype, FISH, and other methods to detect. So we are decreasing the puzzle, but not by a lot. It's way better than before, but that's still some work need to be done in this aspect. So this brings us to, if you say, let's, do the whole genome sequencing from end to end. And this basically means we need to sequence 3 billion base pairs, which represents 98% of the whole genome. And it's a huge amount of data. And this has been done a few months ago, published in this beautiful, beautiful paper from Washington University, where they tried to use this method of the whole genome sequencing as an alternative for the karyotyping and the FISH, the cytogenetics methods. And what they did is they had 263 patients in two groups. One is retrospective, 146. 100 of them was AML and 39 was NDS. And the other group was retrospective, 117 patients, divided also in AML and NDS group. And what they did is they took the samples from the patients, and within 8 hours, they extracted DNA and did the library, the NGL array. And it is very fast because we are not trying to amplify any specific region. We are trying to amplify the whole genome, sequence the whole genome. So this is less intensive in the lab, although it costs a lot, but it's less intensive, can be done within 8 hours. They do the sequencing within 26 hours. And the analysis and reporting, automated reporting within 3 hours. So that was the study design. And they compared it to the standard of care, the karyotype and the FISH. So what's the good news? The good news is this method was unbelievably great to detect almost all of the biomarker types. And you can see here copy number variants and the copy neutral loss of heterozygosity was covered. And using the standard of care, they detected all the 40 recurrent translocations and all the 91 copy number variants. Not only this, they actually detected the new findings in 25% of the patients. And in 16% of them, it was enough to change the diagnosis. So these new findings were missed by the standard of care, the karyotype, the FISH, and the standard. So with this new technology, they actually were able to change the risk category for 19 patients. And this is an example of a small deletion at chromosome 6 with only 13% abundance, which is show you how this method is actually sensitive enough, even with the small deletions at the genome, at the DNA level. But this is really impressive, is the turnaround time. It's 5 days on average, from receiving the sample to spitting out the protocol, the report. And this is amazing given all the amount of biomarkers that we can detect in one report. And in this slides, you see during the prospective study from April 2019 until February 2020, every patient is recorded how long it took. And initially the first 6 months, it took, probably 7 to 10 days. But as they improve and optimize the work in the lab, they reach to 5.1 days. And in some cases, they actually finish it in less than 3 days, faster than the FISH, which is the red dashed line at the bottom. Now, what's the bad news for this approach? One is it's really costly. Whole genome sequencing is still expensive. It's improving year after year, but still out of reach for every day and every patient. And the other problem is it's a lot of data. Each patient will spit out at least 100 gigabytes of data that need to be analyzed in big data centers, and to require specialized bioinformatics teams to do the automated analysis, which is out of reach for most hospitals, except for a few academia. So it's not really practical, and we don't expect to see this anytime soon in the clinic. Maybe it will take 3 to 4 years. The other disadvantage is, although we're happy that it's going to replace karyotype and FISH, it was not as sensitive as deep sequencing or small NGS panel. Here you see some example at the NPM1. We missed one patient. The blue color is detected by WGS. The red one is how many patients missed. CBB alpha, we missed 1. FLT3, we missed 3. Another one with the ACXL1, and 3 in the RUNX, etc. So, you know, there is some balance between how deep we can sequence. The whole genome sequencing could have been able to detect all of these mutations if we increase the sequencing. But the problem with that is we will increase the cost so much that it will become prohibited. So to balance this, we reduce the coverage, and we will suffer from the sensitivity a little bit. So smaller panel does not, you know, solve everything. Whole genome solves everything, but very costly and difficult.
5 minutes more, please.
Sure. So is there a middle ground today for another type of NGS? And the answer, luckily, is in the last couple of years, we start to see some advanced NGS panels that is well designed, well thought, and it has the best of both worlds, the smaller generic NGS panel and the whole genome. And I will give you one example. This year, actually a couple of months ago, a lymphoid next generation sequencing called LYNX panel was developed by a group in Czech Republic. And they picked up 70 genes for lymphomas. And not only they cover the coding region, for some of the genes, they went and sequenced also the intronic region, like the MYC for the rearrangement. For Notch1, they picked up the UTR region, untranslated region. So it's a very well thought based on the evidence that comes from the large scale studies. On top of that, they went and add some probes for the recurrent deletion. Here is the deletion 17p, 11q, and 13q. And with that, they have a backbone of probes spanning at 300 kb up to 1 megabases for these lymphoid specific recurrent deletions. For the trisomy as well, they did the same, but with a lower resolution. Instead of 300,000, they went for 6 million. So it's good enough to depict the large chromosomal trisomies or deletions. And they went also for the translocation, the BCL2, the BCL6, and the CCNB1. And if this is not enough, they also went for the IGH locus, the rearrangements at the T cells rearrangement as well for all of the genes, completely covered by a deep and tiling probes. So almost all the known biomarkers that we can think of in the lymphoid was covered in this panel. It's not whole genome, but it's not only commercial panel. So it's a custom designed. So what's the good news? The good news is they compared their panel with arrays, whole exome, BCR, Sanger sequencing, FISH, and Amplicon NGS. They did that in 84 samples from different resources, peripheral blood, bone marrow, fresh, frozen, and FFPE. And they picked it across different lymphomas, 30 CLL, 13 ALL, and other types. And for short mutation, the single mutation and the short insertion deletion, the detection was 100% for all the mutation above 5% allele frequency, which is amazing. And this is to be expected nowadays from NGS panels. And for the copy number variants, there was 109 copy number variants detected by the standard of care. They picked 88% of them. So 13 missed CMV. And the reason for those missed CMV is either the tumor cellularity was less than 20%, or the biomarker itself is smaller than the resolution they're designed. So this is to be expected, to be honest, with any panel. But you know, it just shows you that copy number variant is not as good as the whole genome sequencing, but definitely much better than the common commercial available NGS panel today. For the translocation,
would you please conclude, Dr. Turki?
Sure, just 2 slides.
Oh, sure.
There is 97% for the translocations. The cost is much better than the whole genome sequencing and similar to the current panels. And it doesn't suffer from big data. So the panel is still small enough for any medium-sized labs to do. The bad news is all the BCL6 were missed. 3 patients had it by FISH and it was missed. And this is a notorious gene as well. So this is one of the caveats for this panel is FISH is still required for the diffuse large B-cell lymphoma. To summarize, this is a much better than it's not as good as the whole genome sequencing, but very cost effective, and it's much better than the standard commercial available. So we still need FISH for the diffuse B-cell large lymphoma. Copy number variants may require karyotyping to support it, but eventually we are moving forward for advanced panels, which is the middle suite between whole genome sequencing and the general hotspot NGS panel. Thank you very much for listening.
Okay. Thank you very much, Doctor, for this very informative talk. And I have here 2 questions. One is about, do you profile proteins biomarker or protein isoforms?
With the NGS, the detection usually is done at the DNA and the RNA level. So when it comes to the protein, you need to use either immunohistochemistry through the morphology or the flow cytometry.
Okay, another questions here. PCR detection technique is based on gene structure. What in case of new mutation, as we are seeing now with COVID-19, will this technique still useful, and how to avoid false negative results in new mutation cases?
A great question. So this is the BCR, this one. So definitely it can detect non-copy number, point mutation and indels, but if it is novel, it will miss it completely. So this is why we need to do the sequencing, either capillary or the NGS. For the NGS, it's good enough to pick actually novel mutation. So there is no worry at this stage. And I think today, even with the commercial panel, for these 2 groups, the point mutation and indels, the performance is spectacular and very little false negative results can be obtained.
Okay, thank you very much, Dr. Turki. And by this, we conclude this sessions. May I ask all the speakers, particularly those who covered the COVID, because there are many really questions that could not be answered, just to type it. If it's possible, you can type it in the panelist list. And as we will break here now, and we'll be back at 6:15. I'd like to thank the organizing committee giving me the opportunity to share this session, and thank you all.
دكتور بسام.
السلام عليكم.
عليكم السلام، تفضل دكتور.
كيف حالك دكتور غالي؟
اهلا دكتور بسام، دكتور بيروت، حضرتك اخبارك؟
الحمد لله بخير.
سامعني؟
ايوه سامعك وزي القمر باين. طيب I think it's 6:15, 6:16 now. We will start the third session. It is a very interesting session in the hematopathology field, a field that is I respect a lot, and I wish I was a hematopathologist, but that's the career for everyone. We had an apology from one of the speakers, so the session will be shorter. However, we will proceed with the fourth session back-to-back with the chairmanship of Dr. Mohammed al-Mohammadi. So we will start with the first presentation by Dr. Ghalib al-Yamani. Dr. Ghalib is a consultant hematopathology and transfusion medicine, currently in the Prince Sultan Military Medical City in Saudi Arabia, in Riyadh. Dr. Ghalib is obtained his MD in 1993 from University of Cairo. Then he went in and he took his PhD in hematology and blood banking in 2005. Then he did hematopathology fellowship training in Toronto, Canada at SickKids from 2007 to 2009. So he's a FRCPC. Dr. Yamani is a reviewer in many medical journals, and he has published many articles, more than 95 publications in peer-reviewed journal. Dr. Ghalib, it's an honor to have you with us today and to see the high-grade lymphoma case presentation, and I'm sure you will have your hematological and hematopathological touches. So let's learn. The floor is yours, Dr. Ghalib.
Where is the screen?
We can see your screen, Dr. Ghalib. Put it into the presentation mode. Yes, we can see it.
Okay. First, thank you, Dr. Beiruti, for kind introduction, and thank you for scientific committee for inviting me to present the topic today, which is high-grade B-cell lymphoma diagnostic approach and the case scenario. So this is about the disclosure. This is my lecture outline. What is the high-grade B-cell lymphoma, and what is the patient presentation, and what is the happening in new WHA 2016 or for this category? What is genetic profile? And as we know, high-grade B-cell lymphoma is a little bit confusing. Some pathologists and also for clinician, if you tell the clinician your patient is high-grade B-cell lymphoma, he feel bad from the patient and he feel bad from himself, as he knows this patient will not responding to the standard chemotherapy, which are shop, and they need extensive chemotherapy, and they maybe relapse, and maybe need bone marrow transplant. And of course, so for pathology, he is confusing and also make a diagnostic challenge, because he depend on two issues, should be very close to each other, which is the morphology. But the morphology is subjective from pathology to pathology, from pathology experience. And on the same time, they depend on the cytogenetic or fish or karyotype, which always not on time. So it is how to report the case of high-grade B-cell lymphoma. It is high-grade B-cell lymphoma, or it is diffuse large B-cell lymphoma, it is gray B-cell lymphoma. There is overlapping between each other. So what is the high-grade B-cell lymphoma? High-grade B-cell lymphoma is recently introduced category on WHO as aggressive mature B-cell neoplasm with clinical and biological distinction from diffuse large B-cell lymphoma and the Burkitt lymphoma. Second. Okay. High-grade B-cell lymphoma, two categories. The first category, which is high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 gene rearrangement. It is called double hit or triple hit, or high-grade B-cell lymphoma NOS, which lack a genetic double or triple hit, but have morphological feature intermediate between diffuse large B-cell lymphoma and Burkitt lymphoma, or have plastoid morphology. This is the definition of high-grade B-cell lymphoma. So double hit lymphoma should make gene rearrangement with BCL2 or BCL6. It is aggressive again, have make gene rearrangement in addition to other known oncogene, which is BCL2 and BCL6. However, make gene can be rearranged and with other gene like CCND1, which is characteristic for mantle cell lymphoma, can be rearranged with BCL3 also in 2% of cases. But in WHO, is if MYC gene rearranged with CCND1, it is diagnosed as aggressive variant of mantle cell lymphoma. So if we have MYC gene rearrangement with CCND1, rearranged in the same time, it is double hit, but no, it is not considered double hit. It is a mantle cell lymphoma with aggressive variant. Similarly, BCL2, BCL6, BCL3, it is still not considered as double hit. So double hit, MYC gene rearrangement with BCL2 or BCL6 or triple hit. So double hit lymphoma have 4 morphological variants. As we see in this one, it maybe have diffuse large B-cell lymphoma morphology, which is the centroplastic variant. Maybe morphology between diffuse and the Burkitt with this one morphology. Maybe Burkitt-like morphology like the top one, and maybe lymphoblast like the blue and right one, this one. So we have 4 variants. Diffuse large B-cell variant, between diffuse and the Burkitt-like or lymphoblast. So it is difficult sometimes to differentiate exactly between morphology. And it is, as we mentioned, it is subjective from pathology to the other. Again, high-grade B-cell lymphoma, it is not new entity. It is a revised entity in the new blue book. Again, it is aggressive. The patient clinically presented by usually have advanced disease, stage 4, bone marrow usually involved, elevated LDH, usually have extranodal presentation, including CNS, high international prognostic index. So this is why clinician feel bad when you tell pathologist tell him your patient is high-grade B-cell lymphoma. Okay, now the category which was called B-cell lymphoma unclassifiable with feature between intermediate diffuse large B-cell lymphoma and Burkitt lymphoma no longer exists right away. It is now high-grade B-cell lymphoma. Okay, we'll start with a couple of cases how high-grade B-cell lymphoma is presented, how to diagnose, what is the diagnostic channel. The first case is 64 years old male patient presented by generalized fatigue, bony pain, night sweat, anorexia, and weight loss. Physical examination, the patient looks ill, cachectic, but no palpable adenopathy, no hepatosplenomegaly, or no skin lesion. CBC revealed anemia, thrombocytopenia, and mild leukocytosis. Peripheral blood film, no abnormal or atypical cell, only nucleated RBCs, 1%. So the patient did radiology, confirmed minimally enlarged mediastinal lymph node, mildly enlarged spleen and liver, as we said, 14.5 and 15.7 centimeter respectively. No abdominal lymphadenopathy. Okay. So the patient went to the bone marrow aspirate, unfortunately, is suboptimal, necrotic cells and a few intact were rare blast-looking cells. But the bone marrow biopsy was adequate, excellent, hypercellular, diffuse infiltration by malignant large mononuclear cell with blastoid morphology, looks like blasts, with a starry sky appearance. So this is the bone marrow biopsy. This is the bone marrow biopsy. This is the low power. If you look to the on the left side, this area is necrotic, but this area fortunately have intact cells. It is very clear starry sky appearance. And if you look to the high power, of course, any pathologist and some of clinicians also will appreciate this is large mononuclear cell. There is prominent nuclei, one or more, with relatively abundant cytoplasm. It is a blast-like morphology. So we expected leukemia based on, because we don't have flow, because it was, we expected based on the morphology, it is acute leukemia because there is no significant lymphadenopathy, no hepatosplenomegaly. So we did a flow cytometry, although the sample was suboptimal, but still we have some hematopoietic element. We gated on, if you look, we gated on the lymphocyte gate, which is the red one, and we detect small population of B cell, which is 19 positive. But if you look to the 19 and 23 is negative, the upper right quadrant. Okay, if you look to the bottom, there is also 19 and 5. There is no co-expression between 19 and 5. So 5 is negative. This population is B cell. Again, also 19 was 5. There is no co-expression. This separate population of B and T cells. If we look to the upper top, we will see a small population of the B cell is lambda restriction. It is monoclonal B cells. And express lambda, it means it is mature and also monoclonal, so it is not leukemia right away, because now we are dealing with mature B cell. Also, if you look to 23, again, it is negative. FMC7, if you look here, it is partially expressed. Also, again, CD3 with CD5 co-expressed with the normal. So CD10 also, again, negative. CD10 here is negative. So we can summarize what we have. We did immunostain. By flow now, we can summarize. We have B cell population, mature B cell population, lambda restriction, expressed CD19, and 20. FMCC is partially expressed. 5 is negative, 23 is negative. Also, we do immunostain to confirm this one, and we detect cyclin D1 is subset expressed. However, the other markers, BCL2, BCL6, CD23, all are negative. SOX11, which is one of the good marker for mantle cell lymphoma, it is not available as a sum. KX7 was more than 90%. Immunoglobulin PCR confirmed monoclonal. So what's your preliminary diagnosis in such a case? How to report this case? Now we have bone marrow involved by mature B cell neoplasm. Morphologically, we reported like that. It is morphologically consists with high-grade B cell lymphoma. But as we know, high-grade B cell lymphoma need to be subtype, and we need to confirm. We need cytogenetic, of course, for this type of lymphoma for proper classification and proper subtyping. So preliminary diagnosis, as we know, FISH and karyotype usually coming not on time. So we reported this case like high-grade differential diagnosis, high-grade B cell lymphoma with double hit, which is double hit, or NOS, maybe CD5 negative mantle cell lymphoma with blastoid variant, maybe Burkitt lymphoma also have high KI7, have blastoid, although it is not morphologically looks like. Maybe also CD10 negative follicular lymphoma grade 3B, which you can also confusing with high-grade B-cell lymphoma. The other issue may be diffuse large B-cell. Those all are differential diagnosis. So what we need now, cytogenetics. Cytogenetic is very important to categorize this case. So we did FISH. We detected c-MYC is rearranged. We detected IGH CCND translocation 1114. So what's your diagnosis? It is a high-grade B-cell lymphoma now, because we have MYC rearrangement, we have KIX7, we have SKY, which is called aggressive morphology, or now what we can. According to the WHO, it is mantle cell lymphoma blastoid variant, because we have CCND1 translocation with IGH 1114, which is the hallmark in mantle cell lymphoma. So these cases reported as blastoid variant of mantle cell lymphoma. It is not high-grade B-cell lymphoma, although it is confusing. So cytogenetic is very important for such cases. Okay, so the final diagnosis, mantle cell lymphoma blastoid variant. If CCND1 not positive, it will be diagnosed as high-grade B-cell lymphoma NOS, because we have only c-MYC gene rearrangement. We don't have other BCL2 or BCL6. So this is what so second case. So what learned from the first case? First case, you have high-grade B-cell lymphoma or blastoid mantle B-cell lymphoma can have the same morphological and immunophenotypic overlap. Second case is 57 years old woman without any significant past history who presented by flu-like symptom, and during routine workup, we discovered blast in the peripheral blood. See the blast in this. It is large, medium to large cell with prominent nucleus and mature. It has the morphology of the blast cells. Okay, we detected the WBC was 46. There is blast 72% in the peripheral blood. Based on that, we suggest acute leukemia for this patient as based on the morphological finding of peripheral blood. We did bone marrow again. So the bone marrow aspirate and the biopsy. If you look to the aspirate, again, there is infiltration by malignant cells, less condensed chromatin, scan cytoplasm, basophilic. It looks like, again, have a blast or blast-looking cells. The bone marrow biopsy is heavily infiltrated by malignant cells with blast-looking cells, again, small, medium to small, immature. So we did flow cytometry. Surprising flow cytometry giving us the positive for CD10, for CD19, for CD20, and the CD38 and 79A, and the surprising is CABA is expressed. CABA is expressed. So now, if CABA is expressed, we likely deal with lymphoma, not with leukemia. The other marker, which in the slide, almost all markers are negative. T cell marker is negative. Lambda, of course, it is negative. The immature marker, TDT, CD34, MBO, cytoplasmic CD3, all these markers are negative. So we deal with high-grade B-cell lymphoma or B-cell lymphoma with aggressive morphology. We sometimes say aggressive morphology. If clinician, the pathologist say clinician, I have B-cell lymphoma with aggressive morphology, it means we have frequent apoptotic pattern. We have star-sky appearance. We have KI67 is high. We have usually the size is medium or large size. It is called aggressive morphology. So we did immunohistochemistry also to confirm. We did CD10 is positive, CD20, BAX, BCL2, and MYC is partially expressed. If you look carefully, it is partially expressed. As we know, to interpret the MYC gene, expressed, we need at least more than 40%
of the cell should be expressed. It looks like 40% or little bit less, so it is equivocal, positive or negative. BCL6 is clearly negative. CD34 TDT is negative. So we are dealing again with mature B cell. Okay. So what is the next step to diagnose this case? We have to again, we do cytogenetic. We detected cytogenetic. We detect CMYC gene rearrangement. We detect IGH BCL2 rearrangement, and we detect second chromosomal abnormality when we in the karyotype. So now we have double hit CMYC with BCL2 rearranged. We have secondary chromosomal abnormality, which is a common finding in high-grade B-cell lymphoma. Now this case is diagnosed as high-grade B-cell lymphoma with rearrangement of MYC and BCL2. So again, we have to diagnose this case. Without cytogenetic, we can't diagnose high-grade B-cell lymphoma. It is depend on MYC gene rearrangement and BCL2 rearrangement as well. So this is also what we learn from this case. High-grade B-cell lymphoma can be presented as a leukemic phase. So this case is presented by peripheral blood blast or blast-looking cells. So one of the differential diagnosis when you see blast or blast-looking cells, the pathologist should all put in mind maybe high-grade B-cell lymphoma as a differential diagnosis. The other important issue, kappa and lambda by flow cytometry should be included in your acute leukemia panel. Okay, so case 3. Case 3 is 64 years old male without any significant past history, presented by severe back pain, fever, night sweat, fatigue, and weight loss. So the clinical presentation looks like likely lymphoma. His physical examination is unremarkable. No lymph node, CBC revealed mild anemia, white blood cell 21 with 40% blast again or blast-looking cells in the peripheral blood and thrombocytopenia. Provisional diagnosis based on this finding, it was like acute leukemia. So look to the peripheral blood in the left side. See, it is very clear. Any pathologist see it is blast, prominent nuclear, immature nuclear chromatin, basophilic cytoplasm. So it is a blast. No doubt it is a blast. It is or blast-looking cell, whatever. The bone marrow in the bone marrow biopsy, see, replaced by malignant cells with blastoid morphology. So we did flow cytometry. Again, surprising, we have lambda-restricted clonal B cell population expressing B cell marker without TDT, MBO, or CD34. So we deal with B cell lymphoma high grade with blastoid morphology. We did bone marrow some immune stain. BCL2 and BCL6 is expressed. With KI7, it was more than 90%, and also CD10 was positive. So what is the diagnosis? We have to do FISH. Again, in such a case, we have to do FISH. Now it is reported like, in such a case, we have to report it, in the next slide, how to report, because sometimes the FISH and the molecular study is not available on time to give a final diagnosis. We did FISH. We detected again MYC and BCL2 gene rearrangement, and also we detect secondary genetic abnormality, and the diagnosis finally is, this is the FISH, is IGH BCL2 rearrangement using double color fusion probe. We will see the fusion of this gene in these cells, and also MYC gene break apart. We'll see separate red and green signal indicating MYC gene rearrangement is rearranged. But as we know, break apart gene can detect MYC gene rearrangement, but he can't detect what is the partner, what is the other gene. Okay, so this usually, if we need to know what is the partner, we have to run the other probe. Okay, so what is the diagnosis? Again, diagnosis is high-grade B-cell lymphoma with MYC and BCL2 gene rearrangement. Again, he presented by leukemic phase, it looks like provisional diagnosis, it was acute leukemia. So we need, again, cytogenetics. So the last case is
You have
52
1
years
minute,
old.
Dr. Ghalib. 1 minute, my dear.
1
1 minute. دقيقة واحدة.
Okay. 50 years old, medically free, presented by abdominal pain, neck swelling, 2018. CBC with normal finding, no abnormal cells. Radiological workup detected lymphadenopathy. Core biopsy is done. This is look to the morphology in the H&E. It is looks like blast-like. It's blast-like, but we did CD20 and the KX7. CD20 is strongly positive. KX7 is high. We did other marker. We did immature marker. It is negative. We suspected lymphoblastic lymphoma, but CD20 strong positive. Immature marker is negative. So it is like we deal with high-grade B-cell lymphoma. We did FISH for McGear alignment. It is negative. So diagnosis, it was diagnosed high-grade B-cell lymphoma NOS. Okay, the patient received chemotherapy and did autologous stem cell transplant in 2019. Okay, 2021, two months ago only, the patient presented by renal impairment, hypercalcemia, and lytic lesion, CBC, pancytopenia, no abnormal cells, bone marrow extensive by infiltration by malignant cells. What's your preliminary diagnosis? Everyone will expect it is a relapse. It was 2018 high-grade B-cell lymphoma, and 2021 is presented by bone marrow infiltration by malignant cell. It is relapse. Okay, this is the bone marrow aspirate and the biopsy. I'm not going in details. We did immunostain. It looks like infiltration by malignant with malignant cells, medium to large size. We did immunostain, CD3, CD20 surprising negative. Oh my. So what can we do? CD20 and CD. We did a lot of immunostain, a lot of every immunostain we did. What is the important? What we discovered, we did these two immunostain, which is 138 and CD56. It was positive, strongly positive 138. It is positive 56. So what's your diagnosis? The diagnosis is we did immunostain again. All are negative. We did ALK is negative, KX7. So what is your differential diagnosis? Of course, if we have case like that presented by this presentation with positive for 138 and 56, we have to think about plasmablastic lymphoma, plasmablastic cell myeloma, ALK positive, large B-cell. This is a 3 differential diagnosis in such a case, but ALK is negative. So now we deal with plasmablastic lymphoma or plasma cell myeloma, which is, we know it is a challenging, but presentation and the 56 and the patient presentation looks like myeloma, and this is diagnosed plasmablastic myeloma. And if we look, we have plasmablastic lymphoma and the plasmablastic myeloma have the same immune profile, depend only maybe sometimes the only diagnosis been based on clinical presentation. It is if someone interested, we publish 8 cases of plasmablastic lymphoma and discuss this issue, how to differentiate from other cases. So it is just a few 1 minute, Dr. Bayroti.
Okay.
Again, what is the aggressive morphology? Again, if we see a aggressive morphology, star sky appearance, high apoptotic, KX7. If we have a case of atypical with atypical MEC or BCL2 or BCL6 abnormality, not considered double hit. Like if you have the report of cytogenetic extra copy of MEC or extra copy of BCL2, it is not considered double hit. It should be rearranged, not extra copy or other abnormality. As we know, there is difficult to classify every lymphoma based on the morphology, as we have see all type of lymphoma are overlapping. So how to can reach diagnosis? We mentioned this one, how the pathology report, pathology, how to report a case, because we know cytogenetic usually coming late, maybe second week or whatever. So we have in such a case, the pathology should write according to the morphology, it is diffuse large B-cell lymphoma genetic study are pending, or high-grade B-cell lymphoma genetic study are pending, and the final WHO diagnosis pending on genetic study. And you have to comment on the morphology. It is more diffuse or high-grade B-cell lymphoma. Immunohistochemistry, you have to mention the cell of origin, double expression of BCL2 or BCL6, KX7, any feature raising the possibility of double hit, of triple hit like aggressive morphology, pending cytogenetic should be in the preliminary report. And as Dr. Turki mentioned, molecular study in lymphoma and the clinical practice is coming soon. The next WHO will have implication of molecular study on the on patient outcome. The role is in therapeutic target and support the immune stain. So a lot of changes coming based on the next WHO based in the molecular. And this is how to approach a case of high-grade B-cell lymphoma. The last slide, what is the double expressive? We have to differentiate between double expressive lymphoma and double hit lymphoma. Double hit lymphoma BCL MEC with BCL2 or BCL6. Double expressive, it means based on immune stain, based in MEC gene rearrangement, MEC gene, MEC protein immune stain, and BCL2. The cutoff 40 and 50 for each one to be positive, and be in your mind, double expressive can be also in double diffuse large B-cell lymphoma 20 to 30%. What is the importance of double expressive? In some study, it has intermediate prognosis, and we have to differentiate between this one. And this is a differential diagnosis of high-grade B-cell lymphoma, and we overlapping, and we thank you عشان دكتور بيروتي خلاص.
شكرا دكتور غالب. I wish you don't stop, but all these are very interesting cases, very educational, wallahi. And it tells us how much the challenge you as hematopathologist you are going through to reach diagnosis. There are a couple of questions. The first one from Al-Junaid Ahmed. He's asking what makes some lymphoma double or triple expression with negative gene rearrangement test. I mean, hit. So
if you look back to my slide, maybe
you explained it
but again, double expressor, as we have a common word, double expressor, not always rearranged. Okay, so if MEC is expressed by immunity, it doesn't mean it is rearranged. Again, double expressor not always rearranged. It means MEC gene rearrangement. It is not a good surrogate for rearrangement. So we can express, but it is negative, and the vice versa. We can negative by MEC gene rearrangement, and it is positive by immunostain.
And as you alluded in your presentation, that the double expression, they are intermediate prognosis compared to double hit or triple hit, where they have worse prognosis. The last question, yeah.
Okay. Oh, this is why I showed in the pathology report. The pathology showed if we have large B-cell lymphoma, we have to mention it is BCL2 or BCL6, it is expressed or not, because they have clinical implication, as Dr. Bairotti said.
And the last question, Dr. Yamani, I have is what we are looking in lymphoma is the molecular signature. Like for hairy cell leukemia, we have the BRAF molecular signature. For plasma cell lymphoma, the MYD88 molecular signature. When are we going to have the molecular signature in order to alleviate this integration of the clinical immunohistochemistry and the FISH studies? When we are going to have molecular signature of every type of lymphoma, if we can?
It is difficult to answer, but as we mentioned, molecular study and genetic study will be very, very important. As we said, we can diagnose high-grade B-cell lymphoma with double hit or triple hit or OS or whatever without cytogenetic. If we go back to my cases, in the first it is large B-cell lymphoma, maybe. So we have, without, I think, as we said also, next blue book is coming with a lot of molecular marker with it is difficult. At least we have the basic one for every lab. This is what is the lesson from this lecture today. You have to prepare your molecular lab well, otherwise you will be outdated. Your patient not get the proper management or proper treatment. So as molecular marker is very important for diagnosis and for also outcome of the patient.
Okay.
Hopefully we have like national laboratory molecular with all. I think someone told me it is in processing or something like that. We need national. It is a big project. It is difficult to be in the private matter. Should be in the national way.
Okay. Inshallah, one day will happen, at least either in the regions or at countrywide. We have a molecular diagnostic lab for leukemia, lymphoma, myeloma. That's a dream.
By the way, Dr. Bayroti, before we say it is time consuming, usually molecular is coming late in the couple of weeks or once. Now, as Dr. Turki said in the previous lecture, it can coming within a few days. Now, with new technology, with new machine, we can get the molecular testing on time.
Okay. So thank you very much, Dr. Ghalib. Without further delay, we will move to the next presentation by Dr. Muna Al-Faraj, who will present to us a literature review about pure red cell aplasia, which is a very rare disease, but it's very nice to hear from Dr. Muna. Dr. Muna, currently she is the head of the hematology lab section and deputy director of medical laboratory department and blood bank in Al Qatif Healthcare Network, Ministry of Health in Saudi Arabia. Dr. Muna is a graduate of King Saud University Fellowship in Pathology, Hematology and Blood Transfusion. And she did her fellowship, finished her fellowship in 2013. And then she was, she's currently very active in research, participating in local, regional, and international scientific meeting in the field of the hematology and transfusion medicine. And she was head of many scientific and organizing committees for different symposia on anemia in Al Qatif Central Hospital region. Dr. Muna has also many publications. She's active members and in IRB Ethics Committee, and she is a pioneer in her field and in the field of hematopathology, transfusion medicine, and she's member of different society in the field of immunohematology, hematology, and the apheresis International Society and International Society of Laboratory Hematology. So Dr. Muna, the floor is yours, and we will learn from you also the literature review about pure red cell aplasia.
Hello, thank you, Dr. Bassem. Thank you, Dr. Bassem, for your nice introduction. Just I'd like to be sure first if I'm very well audible or not. So you can hear me very well.
We can see you and we can hear your voice clearly.
Okay. We will talk about pure red cell aplasia today. As Dr. Bassem Bayroti mentioned, pure red cell aplasia, it's not common disease, it's a rare disorder actually, but it's better to call it a disease of agreed diversity, and it's good to know about it because of its association and its underlying conditions.
دكتورة منى
أيوة.
البرزنتيشن مش ظاهر. share screen.
Share your screen. We don't see your screen yet, Doctora.
Just a minute.
Okay. The green button, share screen.
So what about now?
Not yet, Doctora. Until you opened your presentation, the PowerPoint.
Yes. Yes.
Open. So stop and share screen again. Stop sharing and share screen again. The green button.
Sorry. It's green with me.
Yes. Put
Can you
share
see it?
screen.
Yeah.
Not yet. We don't see your screen yet, Doctora. So press
What about
on.
now?
Now it's coming, I think.
Yes.
Okay, now we can see it. Beautiful. Okay. You can put it there. Yeah.
So Buretsel aplasia is a rare disorder, but actually we'd like to talk about it because it's a disease of a great diversity. What we mean by it's a disorder of a great diversity, there are many factors and many underlying association or disorders contribute to its presentation. It's better to classify it as a presentation rather than a disease of a separate entity. It can be congenital or acquired, and it can be primary or secondary. But the primary one is a disease of exclusion of all underlying secondaries. Additionally, the secondary underlying condition can be benign or malignant. And whether it's a primary or secondary, immune-mediated mechanism plays an important role in both the primary and secondary types. And this will affect the therapeutic modulating agents as many immunosuppressive agents used in the treatment of many types of acquired primary or secondary Buretsel aplasia. To know the causes of Buretsel aplasia, it's better to understand the normal development and maturation of red blood cells in the bone marrow till it reaches peripheral blood circulation. We can see here that the normal RBC passed through different maturational stages, starting from megakaryocyte erythroid progenitor and passing to pro-erythroblast till reaching late erythroblast stage in bone marrow environment. This maturational series take about 3 weeks in duration. And after that, it reach a level of nuclear extrusion in which the nuclear RBC in this stage enter peripheral blood circulation to become reticulocyte and finally mature red blood cell, which take a lifespan about 120 days in normal human. And this is in a brief. And knowing the factors affecting blood RBC maturation in many stages will help to understand the causes of Buretsel aplasia, as well as the other cause of reticulocytopenic anemia, which can be a differential diagnosis of differential diagnosis of a Buretsel aplasia. We know that erythropoietin produced from renal tissue under hypoxic effect, and thereafter it will act on maturation of erythropoiesis. Erythropoietin will act and express its effect in the colony-forming unit of erythroid, progenitor, pro-erythroblast, and also basophilic erythroblast. So any effect of erythropoietin will affect maturation of red blood cell and will cause reticulocytopenic anemia. And this slide shows some factors affect also maturation of red blood cells, like folate and B12 deficiency. It affects DNA synthesis in the early erythroid precursors, and also thyroid, androgen, and androgen hormones play important role in maturation of red blood cells in the late erythroid stages. And understanding the effect of androgen can give better understanding of the opposite effect of female hormones in erythropoiesis. Iron is very important also because it enters in incorporation. So any effect of iron metabolism by copper or pyridoxine deficiency will affect red blood cell maturation. So I gave now just a brief about red blood cell maturation in order to understand the causes of pure-red-cell aplasia. But what is pure-red-cell aplasia? Pure-red-cell aplasia simply is a type of hypoprotective anemia characterized by either normocytic or sometimes macrocytic anemia and low reticulocyte count, as reticulocyte count will be less than 10,000 per microliter or less than 1%. And since it's pure-red-cell aplasia, it's characterized by normal lineage of other blood cell lineage, both in the peripheral blood and also in bone marrow, unless another concurrent disorder is coexisting. So this is the simple diagnosis of a pure-red-cell aplasia. This is diagnosed from CBC, but bone marrow examination is important also to confirm hypoproduction of erythropoiesis or hypoerythropoiesis, because there are some types of pure-red-cell aplasia, some types of other hypoproductive anemia can give reticulocytopenic anemia. For example, folate and B12 deficiency with megaloblastic anemia or congenital dyserythropoietic anemia. And actually, bone marrow examination will be helpful in such cases, because in megaloblastic anemia and congenital dyserythropoietic anemia, the bone marrow will show hypererythropoiesis with dyserythropoietic features, while in pure-red-cell aplasia, it will show hypoerythropoiesis. Here in a case of bone marrow biopsy of a middle-aged lady presented with normocytic anemia and very low reticulocyte count, and bone marrow examination done for her as a part of anemia investigation, and we can see the bone marrow is normal to slightly hypercellular, and it show active trilineage hematopoiesis. With importantly, there is an increase of megakaryopoiesis, and the majority of those megakaryocytes are of monolobated and bilobated morphology. The finding of bone marrow biopsy raises possibility of myelodysplastic syndrome, particularly 5q deletion. And actually, it's confirmed by conventional karyotyping. And this is just an example to show how the bone marrow examination is important to differentiate pure-red-cell aplasia from other type of hypoproductive anemia. So the causes of pure-red-cell aplasia can be classified simply to congenital type or acquired type. The most common known congenital type of pure-red-cell aplasia is Diamond-Blackfan anemia. Pearson syndrome can be classified by some pathologists as a congenital cause of pure-red-cell aplasia, although some pathologists in favor to classify it as congenital dyserythropoiesis. We will talk about it in next slides. The acquired pure-red-cell aplasia can be primary or secondary, and actually the primary pure-red-cell aplasia is a disease of exclusion of all other secondaries that can be simply autoimmune or collagen vascular disorder, or due to infection like viral infection or TB, or can be due to whether hematological or non-hematological neoplasm, and also with some drugs or nutritional deficiency. We will talk about each of these causes in next slides. Let's start with the childhood Burette cell aplasia. Actually, the diversity of Burette cell aplasia, it's not limited only to its causes like primary versus secondary, benign versus malignant, but it's also to its duration. It can be simple, acute, or transit, or chronic. Best example for this type of diversity and also variability in its duration is the childhood Burette cell aplasia, because the very well-known one is congenital Diamond-Blackfan anemia is of a chronic course, while transit erythroblastopenia of a childhood is a type of Burette cell aplasia occurred in early childhood, most commonly from 3 months to 4 years, but with acute transit course. We will talk about the most common well-known congenital type, which is Diamond-Blackfan anemia. It's a congenital Burette cell aplasia characterized by early presentation in early infancy and associated with dysmorphic features like what's seen here in this slide, webbed neck, abnormalities in fingers and thumb, and sometimes strabismus with inverted nipples and renal anomalies. And all of these manifestations are due to ribosomal protein dysgenesis. This figure shows the example of ribosomal gene dysgenesis that occurs in a Burette cell aplasia. In the top picture, there is a normal ribosomal sufficiency in which MDM2 protein bind to RBL11, which is ribosomal large protein. And actually, when it binds in abnormal pattern, it will lead to activation of autosis of B53, which activate apoptosis and cell cycle arrest. And so this will affect the early erythroid progenitor and will lead to a Burette cell aplasia and Diamond-Blackfan anemia. The upper picture shown the normal sufficiency in which there is no binding and no interaction, while the lower show the ribosomal haploinsufficiency status. Although of the demonstration of this genetic abnormality in a Burette cell aplasia, which affect the purine synthesis, it is still under investigation to know more about its underlying pathogenesis. And actually, the anemia of Diamond-Blackfan syndrome is normocytic, but sometimes can be macrocytic. It's characterized also by an increase of erythropoietin level as a compensatory mechanism, with normal or slightly low leukocyte and platelet count, with also an increased expression of little I antigen on red blood cell surface, with an increase also of hemoglobin F as a sign of stressed marrow. Here we have a case of a 3-month-old exclusively breastfed male infant presented with history of progressive pallor and required frequent blood transfusion. He was born at term to second-degree consanguineous parentage by normal vaginal delivery with normal weight. There was a significant family history of death of 2 previous siblings involved both genders. With only one surviving healthy girl child. The 2 babies died on age less than 6 weeks following poor feeding and before even medical help could be sought. On examination, the patient was lethargic and had severe pallor with also soft hepatosplenomegaly. On urological examination, he had hypotonia with normal reflexes. His CBC show a very low hemoglobin level, as the level was 6.6 gram per deciliter, with low platelets but normal WBC count. Peripheral blood smear confirmed pancytopenia, and he has also reticulocytopenia. The inborn error of metabolism investigation done at that time to investigate such case, and it showed persistent hyperglycemia requiring insulin with absence of urine ketone bodies, elevated lactate level with normal plasma ammonia level. At that time, bone marrow examination done as a part of pancytopenia investigation, and actually the bone marrow aspirate was non-particulated but with cellular trail, and it can give some hint with such cellular trail. Here there is some finding shown in that patient, although this picture taken from this reference, but it was of the same finding of our patient. We can see cytoplasmic evacuation in both erythroid, a precursor that's demonstrated by black arrow, and myeloid, a precursor which is demonstrated by a blue arrow. And in iron stain, there was ring sideroblast, as it's shown here with a white arrow, as we can see very well ring sideroblast that encircling more than 1/3 of the nucleus of RBC. And with such finding of history of early death of his siblings, pancreatic insufficiency, pancytopenia, reticulocytopenia, abnormal vacuolization of both erythroid and myeloid precursors with sideroblastic anemia, the diagnosis was most likely Person's syndrome. Person's syndrome is a congenital mitochondrial disorder characterized by exocrine pancreatic insufficiency, dyserythropoiesis with congenital sideroblastic anemia, and can be also associated with hypoerythropoiesis. So whether Person's syndrome classified by pathologists as congenital dyserythropoiesis or congenital buried cell aplasia, it's characterized by reticulocytopenic anemia in infancy, which needs real investigation and confirmation because it's fatal, and the treatment is bone marrow stem cell transplantation. And for sure, the parents need further genetic counseling. It's important also to differentiate congenital buried cell aplasia from other type of congenital dyserythropoiesis. Actually, I compared between these types of anemia, and such comparison is published in a review article of buried cell aplasia in Journal of a Clinical Journal of Applied Hematology. The age of presentation is almost similar between congenital buried cell aplasia and congenital dyserythropoietic anemia, although it's more delayed in congenital dyserythropoietic anemia. There is no much difference in clinical features because both types of anemia can be presented with dysmorphic features. And also regarding MCV and reticulocyte count, it is difficult to depend on such parameters to differentiate between both, as congenital buried cell aplasia can give normocytic or microcytic anemia, and congenital dyserythropoietic anemia can give any type of anemia, whether normocytic, microcytic, or microcytic, depends on subtypes of congenital dyserythropoietic anemia. But the important differentiate finding is bone marrow examination. It's characterized by hypoerythropoiesis in a case of a buried cell aplasia, and hypererythropoiesis with dyserythropoiesis and congenital dyserythropoietic anemia, and this is confirmed with genetic abnormalities. Here are some pictures of dyserythropoiesis, like bionucleation in figure C, and multinucleation in E figure, internuclear bridge due to abnormality in cytokinesis. All of these pictures are finding in dyserythropoiesis, and particularly congenital dyserythropoietic anemia rather than congenital pure red cell aplasia. Now we will talk about the secondary causes of pure red cell aplasia. Pure red cell aplasia can be a presentation of autoimmune or collagen vascular disorder like systemic lupus erythematosus or rheumatoid arthritis. It can be a presentation of viral infection, most commonly known as parvovirus B19. HIV can be presented also with pure red cell aplasia. Epstein-Barr virus, whether due to the viral itself or due to progression to lymphoproliferative disorder, can cause pure red cell aplasia. Other viruses like cytomegalovirus or viral hepatitis, as well as other infection like TB, can cause pure red cell aplasia. And since we are in era of COVID-19, I tried to find any association between COVID-19 infection and pure red cell aplasia, but I didn't find any report or any case in the literature regarding such association. In this picture, we can see early pro-erythroblast seen in bone marrow examination of a young patient of sickle cell anemia presented with prolonged reticulocytopenic anemia following infection, and the case was confirmed with PCR as B19 parvovirus infection. And we have the characteristic finding of a pro-erythroblast with cytoplasmic pseudopedia, little vacuolation, and smudgy chromatin, which is seen in a case of B19 parvovirus infection. It's very well known that B19 parvovirus causes pure red cell aplasia in patients with sickle cell anemia or other chronic hemolytic anemia like hereditary pyrobipolycytosis through binding of B antigen. And in some immunocompromised patients, it can give also pancytopenia with extensive myelosuppression due to cytotoxic effect of the virus on the bone marrow microenvironment.
Ramona, you have 2 minutes. 2 minutes more.
Okay. Actually, 5 minutes already taken. Okay, I will complete. I will try to rush. We have a case of a 52-year-old woman presented to emergency room complaining of 1 month history of exertional dyspnea and fatigue, and she was admitted under hematology care. She denied history of a blood loss or jaundice, but she gave a history of significant weight loss. And on physical examination, she was severely pale, and she had enlarged lymphadenopathy, particularly at axillary and cervical lymph node. No hepatosplenomegaly was detected on time of examination. On investigation, she had severe anemia, particularly reticulocytopenic anemia with normal WBC and platelets count, normal C-reactive protein with lactate dehydrogenase, and also normal total bilirubin with ferritin. Direct comp test and indirect comp test was positive. But actually, autoimmune hemolytic anemia cannot explain her reticulocytopenic anemia as she has low reticulocyte count. Her peripheral blood smear showed rouleau formation with microspherocyte. At that time, we don't have the result of serum protein electrophoresis, but the sample sent to tertiary care hospital. All viral screening was negative except positive IgG for EBV or Epstein-Barr virus. With normal renal and liver function, normal vitamin B12 and folic acid. As a part of investigation, radiological imaging was conducted, and it demonstrated multiple lymphadenopathy. So by consultation, we decided to do lymph node biopsy, but the patient refused to obtain any lymph node biopsy from her. And just for a suggestion from a clinical hematologist, he suggested to do bone marrow examination, although I wasn't agree at that time, and there was a strong argument between such approach. But actually, bone marrow examination was done for her, but it's failed. No sufficient biopsy was taken, and it was markedly suboptimal. Then the patient referred to tertiary care hospital, and we received the report of lymph node biopsy examination as it's diagnosed with lymphoproliferative disorder, T lymphoproliferative disorder with positive CD3, CD2, and partial positivity to CD7, and there was population, follicular dendritic cell population stained with CD20, 21, sorry, and the diagnosis of T angioimmunolymphoblastic anemia was made. And this case presented just to show how the lymphoproliferative disorder can be presented as a case of a pure red cell aplasia. And actually, it is not only lymphoproliferative disorder, also other hematological neoplasm can be presented with pure red cell aplasia, like myelodysplastic syndrome. Also, presentation of myelodysplastic syndrome as pure red cell aplasia is not common, but reported existing cases of MDS, particularly with 5q syndrome, with pure red cell aplasia was reported. Other non-hematological neoplasm also can be presented as a case of a pure red cell aplasia. The most common or the most well-known is thymoma, as there is 50% association between pure red cell aplasia and thymoma. And actually 7% of thymoma are presented as pure red cell aplasia. Other solid organ neoplasm like breast cancer and renal cell carcinoma can present also with pure red cell aplasia. Important causes are major mismatch of ABO blood group, particularly in patients with hematopoietic stem cell transplantation. Drugs like recombinant erythropoietin, but development of subcutaneous ovopoietin and well-stored epoxy in 2020 reduced the incidence of pure red cell aplasia to less than 80%. Importantly, some medications like allopurinol and anticonvulsant can cause pure red cell aplasia. So the investigation of pure red cell aplasia is very wide, very broad. It includes simple CBC with wide differential leukocyte count, serological marker for like ANA, also nutritional assay like iron, folate, and B12 levels, bone marrow examination with immunophenotyping, whether in bone marrow examination or on some of abnormally seen cells in the peripheral blood circulation, like large granular lymphocyte, is important because many cases of large granular lymphocyte lymphoma present as a case of a pure red cell aplasia. Radiological imaging play an important role also to investigate pure red cell aplasia, and serum erythropoietin level can be assayed if it is available. And now I'm about to finish, just to talk briefly about the treatment of pure red cell aplasia. Actually, it is not my field, as I'm a hematopathologist, not clinical hematologist. But actually, reaching complete response of pure red cell aplasia is important to avoid further blood transfusion requirement and avoid further complication and risk of blood transfusion. And the aim of treatment of a pure red cell aplasia is to achieve normal hemoglobin level with reticulocyte count and eliminate need of a transfusion requirement after 8 weeks of a treatment. There are many therapeutic modalities to treat pure red cell aplasia. I mentioned in the beginning of my slides that immunosuppressing agents is very important in treatment in many kinds of primary and secondary pure red cell aplasia, including congenital type. there is good response with corticosteroid and the prednisolone, as the success rate of a prednisolone is about 40%, and it is in the first line of a treatment of buried cell aplasia. Cyclosporine can be used as a second line of buried cell aplasia with a success rate about 70%, but there is conservative opinion about its usage because of its nephrotoxicity side effect. Other cytotoxic agents like cyclophosphamide and rituximab also can be used in some types of buried cell aplasia. Rituximab, which is anti-CD20, can achieve good success rate in a treatment of buried cell aplasia associated with lymphoma. Anti-thymocyte globulin can be used. Plasmapheresis can be used as in a treatment of buried cell aplasia associated with ABO mismatch, and it's categorized as ASFA2 category in major mismatch and ASFA3 category in minor mismatch. Surgery, if it's needed, for splenectomy or thymoma, and for some cases as Person's syndrome or some types of malignancy like MDS, hematopoietic stem cell transplantation can be used. The assessment, as I mentioned, depends on the level of hemoglobin and reticulocyte count, as well as elimination of the transfusion. Finally, I think my time is already over. I'd like to say thank you for such a great opportunity. And if you need summarization of what we mentioned here about review of buried cell aplasia with their classification, conversion with congenital buried cell aplasia, and also about investigation and importance of each investigation in case of a buried cell aplasia and response of a treatment and the role of each therapeutic modalities, you can review the articles I have already published in Saudi Journal of Clinical Applied Hematology in collaboration with Dr. Hussein Saeed, who is a clinical hematologist in our hospital. That's it. Thank you.
Thank you very much, Dr. Muna. This is very excellent presentation. Honestly, I think hematopathology should be the one who will see these patients with anemia, because what clinical hematologists sometimes they do, not clinical hematologists, I have to be fair to my colleague, but what the clinician they will do, the time they will see anemia, they will give transfusion, that's it, without digging into more history, more detailed assessment. And it's very unfortunate when our colleague in medicine or surgery consult us to see a patient with anemia and we are looking at the blood film. It's frustrating when you see the transfused blood, you want to measure anything, and we don't do bone marrow always up front. We do it stepwise, but it's very important. And these cases, especially pediatric, I'm sure our pediatric colleagues, they are more careful as clinician than the adults. I have to admit, the pediatric always more careful. I checked the question and answer. I didn't see any question directed to you, Dr. Muna. But if you allow me, when do you think we should do bone marrow in a patient with low reticulocyte count anemia after ruling out nutritional deficiencies like iron deficiency, B12, and folate, which will cause low retic anemia? But if these things are normal or high, when we should do bone marrow?
Actually, unexplained cytopenia, whether it's unilineage cytopenia or multilineage, is a clear indication of bone marrow examination. So unexplained anemia is the clear indication of bone marrow examination. So if you eliminate all causes of nutritional deficiency and you don't have any hint on the examination, and also you eliminate all causes of viral infection, as well as connective tissue disorder, I think bone marrow examination is mandatory.
Yeah. Do you agree with my approach of giving a trial of therapeutic hematinics? Because honestly, I don't know how they do these labs. You see B12 normal or high, but the patient is symptomatic. So do you agree to give a trial of B12, folic acid, IV iron, and then sometimes you'll be surprised that you will get a response. And I don't have big faith in these levels, especially when the patient received transfusion from another institution, but they come to our institution as tertiary center. So I'll say, okay, well, let's not, especially usually most of the time patient, like the patient you presented, Dr. Amuna, she refused to do bone marrow. And it's painful, it is painful. So do you agree with this approach? Is there any danger, or you think we should do bone marrow before we give therapeutic trial? What do you think?
I will tell you something from my experience. Actually, not only iron or folate or B12 deficiency will cause reticulocytopenic anemia. There are some types of nutritional deficiency can cause reticulocytopenic anemia with lack of its investigation. Like, for example, riboflavin. Riboflavin deficiency is known to give butyl cell aplasia, even in experiments in humans. But actually, we don't have a way to assess riboflavin and also pyridoxine. And the medication taken in such situations contain multi-trace elements, including these elements, and including also copper. And copper can cause copper deficiency can cause butyl cell aplasia. And so the patient may get benefit from it because of underestimated or undiagnosed trace elements deficiency. The role of bone marrow examination here is confirmation or exclusion of other secondaries.
Yes. Yeah, especially when it is underlying myelodysplastic syndrome and you want to catch it early before it transforms into acute leukemia.
Yeah, actually, and in such case, I will take in consideration the age of the patient.
Okay.
If he is in the pediatric age group, I will go more toward a nutritional deficiency related to trace element deficiency. But if the patient, not only in elderly era, even in middle age, because the malignancy age in our population is actually, unfortunately, different from other population. The neoplasm presented in middle age and early age. So in such age, if the patient in middle age or elderly, I will not hesitate to examine the patient if unexplained anemia is present.
Okay, thank you very much, Dr. Muna, for this excellent presentation and discussion. And I will hand over the podium to my colleague, Dr. Muhammad Al-Muhammadi. Abu Badr, the floor is yours, my dear.
Thank you very much, Dr. Bassem. And I am so delighted and honored actually to moderate a session in this very important event, probably the only event that is concerned with hematopathology nationally. And this annual review for hematopathology with the distinguished speakers and distinguished moderators of the day. And it's always my pleasure. Today I have three speakers who are three close friends and colleagues that I learned from, too much. And I'm sure that the audience will benefit similarly. And my first speaker for the day is Dr. Ahmed Al-Bahrani. Dr. Ahmed has graduated from King Faisal University in Dammam, and then he did his hematopathology fellowship at King Saud University, followed by advanced training in University of McMaster in Hamilton, in Canada, in transfusion medicine and stem cell processing. Currently, he is the
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you very much, Dr. Muhammad, for the nice introduction. Also, I would like to thank the scientific committee, especially Dr. Ammar Al-Saghir and Dr. Ahmed Al-Askar for the nice invitation, and special thanks to Noor Kaya as well. My topic today is patient blood management. This is my hospital, King Fahd Specialist Hospital in Dammam. The definition of anemia, according to the World Health Organization, since 1968 is a hemoglobin level below 13 gram per deciliter for men and below 12 gram per deciliter for women. Anemia is a condition in which the number of the RBC, or their oxygen carrying capacity, is insufficient to meet the physiological need, and this is usually vary by age, by sex, male and female, by the altitude, as we know that people who are living on high altitude, usually they have polycythemia, by smoking, and also by pregnancy status. You can see here that the hemoglobin level to define anemia is variable, depend on the different age group. Also, you can see that here the non-pregnant woman, a hemoglobin below 12 is considered anemia, while a pregnant woman with a hemoglobin below 11 is considered as anemic. For men, of course, hemoglobin below 13. The three pillars of patient blood management, according to the 63rd World Health Assembly that is held in Geneva, Switzerland in 2010, the first pillar is to optimize the hematopoiesis. The second pillar is to minimize the blood loss and the bleeding. And the third pillar is the harness and optimize the physiological tolerance of anemia. And this is a multidisciplinary team approach between the hematopathologist, the blood banker, the surgeon, the internist, the hematologist. So it is a teamwork approach. So everybody is involved in the success of this program, the patient blood management. What is the prevalence of undiagnosed anemia? Anemia is so common that it is becoming accepted as normal. 20% of the world population are considered anemic, and up to 75% of elective surgical patients have anemia, and at least 1/3 of the patients who are undergoing elective surgical procedure have potentially anemia that can be treated. Anemia is epidemic, and it is a common complication of a common disease. It is common in inflammatory bowel disease, in patients with rheumatoid arthritis, in patients with chronic kidney disease, in patients with chronic heart failure, and up to 40% of diabetic patients have anemia. And all of these type of anemia are iron related to iron absorption and iron metabolism. You can see here the prevalence of preoperative anemia in patients scheduled for major surgery according to the most common frequent procedure. It is very common in gynecological surgical patient, and vascular surgical patient, colon surgery, cardiac surgery, and urological type of a procedure, and also an orthopedic surgery. It can reach to 50%. Anemia increases the perioperative morbidity and mortality. This study, large study from Toronto in Canada, it is a retrospective study of almost 8,000 non-cardiac surgical patients, found that the prevalence of preoperative anemia was almost 40%. And preoperative anemia was associated with 5-fold increase in the odds of post-operative mortality. Another study from Lebanon, it is a retrospective study of more than 200,000 patients were involved in that study, and preoperative anemia was found among 30% of the patients. Almost 69,000 patients have anemia preoperatively. And even mild preoperative anemia of hemoglobin level between 10 and 12 in women and between 10 and 13 in men is associated with 40% increased risk of mortality and 30% increase in morbidity in patients undergoing major non-cardiac procedure. It is very significant figures and also alarming figures. Perioperative transfusion is also associated with additional increased risk in the morbidity and mortality. Another study from Ottawa, it is a systematic review of 62 studies, showed that preoperative anemia is the most frequent predictor factor of perioperative transfusion. Other risk factors include advanced age, female gender, and small body size. Anemia is significant, now we agree, and it is a modifiable risk factor for increased perioperative morbidity and mortality. This is why it should be diagnosed and treated before any elective surgery. What are the causes of anemia? Iron deficiency anemia, of course, is the most common cause of anemia worldwide. Parasitic infection, hookworm, schistosomiasis, malaria also can cause anemia. Vitamin deficiency, folate and vitamin B12 deficiency can cause anemia. Anemia of chronic inflammation and chronic disease, especially chronic renal failure, obstetric and gynecological disorder, inherited disorder, of course, hemoglobinopathies, sickle cell and thalassemia, and other type of hemoglobinopathies also can cause anemia. Preoperative anemia diagnosis and treatment, the end result will improve the patient outcome. It improves the readiness of the patient for surgery. It reduces the transfusion risk in the perioperative period. It reduces the transfusion-associated morbidity and mortality. Also, it improves the patient outcome in chronic disease, such as chronic heart failures, chronic kidney disease, inflammatory bowel disease, and rheumatoid arthritis. Also, the diagnosis of preoperative anemia can identify some other comorbidity. For example, iron deficiency anemia can be suggesting an occult malignancy of the colon, for example. What laboratory tests are needed pre-surgically to diagnose and evaluate the anemia? Of course, we'll start with the CBC. We look at the hematocrit, at the MCV, MCH, and other parameters. Absolute reticulocyte count to differentiate between the bone marrow suppression and the peripheral utilization of the RBCs or destruction of the RBC. Vitamin B12 serum, vitamin B12 assay, and also folic acid. Iron study, of course, one of the top requested laboratory investigations. Transferrin saturation, ferritin, iron, and iron binding chemistry. Also, we need to do the renal function test as well. Other investigations are needed, the TSH, direct antiglobulin test, which is required to exclude the autoimmune hemolytic anemia, the C-reactive protein, especially for the inflammatory process, soluble transferrin receptor, serum protein electrophoresis, erythropoietin, and haptoglobin. The approach and the diagnosis of anemia, this diagram will show you our approach. If the hemoglobin level in men is below 13 gram per deciliter, then we'll do the iron study. If the ferritin is below 30 milligram, then it is a straightforward iron deficiency anemia diagnosis and should be corrected and treated. But if the ferritin is between 30 and 100 milligram, and the transferrin saturation is below 20, and the C-reactive protein is more than 5 milligram, then anemia of chronic inflammation with iron deficiency as well. And if the ferritin is high, more than 100 milligram, and the transferrin saturation is below 20, and the C-reactive protein is more than 5, then anemia of a chronic inflammation will be diagnosed. Other type of anemia as well, if the iron study are normal, megaloblastic anemia and other causes of anemia as well. So the golden rule is to delay the elective surgery if necessarily to optimize the surgical outcome and to reduce the transfusion risk. If absolute iron deficiency anemia is detected and the cause is unknown, also we do GI referral to rule out the malignancy as a source of a chronic blood loss. And also we need also the nephrologist consultation as well. A preoperative blood transfusion, the preoperative transfusion, as it is known that 30 to 35% of all allogenic blood units are used in the surgical setting, which is very high. And there is a common misconception that transfusion should be the default management strategy for anemia, which is wrong. It is thought that it is of low risk, high benefit, despite there are a lot of publication to the opposite of this conception. The use of a blood transfusion is frequently associated with poorer outcome post-surgically. From the systemic review of the literature, it is estimated that the cost of 1 unit of packed RBC in the Western Europe is €400. Also in our country, it's almost the same. It reached to 1,500 riyal. Despite the evidence of its clinical outcome, clinical and economic disadvantages, a blood transfusion continue to be the most frequently used treatment for acute intra-operative and post-operative anemia. It was found also that the intraoperative transfusion of a single unit of packed RBC will cause and increase the multivariant risk of mortality and morbidity. It can cause wound problems post-surgically. It can cause pulmonary complications and increase the pulmonary complications. Also, the post-operative renal dysfunction is increased, systemic sepsis, and the prolonged post-operative length of hospital stay as well. According to the AABB and the standard for the blood bank and transfusion services, and also a standard for the patient blood management program, RBC transfusion should not be used to treat anemia that can be corrected with a specific hematinic medication, such as oral or IV iron, or vitamin B12, or folic acid, or erythropoietin. It is contraindicated. Blood transfusion is contraindicated in those conditions. Also, RBC or whole blood transfusion should not be used solely for volume expansion or to increase the oncotic pressure of the circulating blood. This diagram will show you the outcome of the preoperative anemia and the outcome of the allogenic transfusion during surgery. It can increase the morbidity and mortality, and also increase the hospital stay. This is published in Blood Transfusion in 2015. The pre-surgical anemia treatment strategy, of course, first of all, we have to correct the nutritional deficiency, the iron therapy, the folic acid, and vitamin B12. Choice of therapy is based on the time scale before surgery. What is the time of the elective surgery? And also, what is the urgency of the surgery, of the surgical procedure itself? And what are the tolerance of oral iron, and also the iron status of the patient? Usually, we consider the oral iron when there is adequate time before surgery, 4 to 6 weeks, and there is no ongoing blood loss. Also, there is no inflammatory process or comorbidity, normal GFR, and the patient can tolerate the oral iron. We need to re-evaluate the anemia study 2 weeks before surgery to determine the effectiveness of the treatment. IV iron. It is the most common intervention used in the pre-surgical anemia. It is better tolerated than oral iron. Example, in the older age population and during pregnancy, the pregnant women already have GI symptom related to the pregnancy itself. This is why they will tolerate the IV iron better than the oral iron. And also individual with the existing GI disorders. Usually with IV iron, the response is much faster than the oral iron. And it is preferred to replete the iron stores in 1 or 2 visits rather than over the course of several months like the oral iron.
5 minutes, Dr. Bahram.
Okay.
5 minutes, please. Thank you.
Okay. Also, it is less expensive than the erythropoietin. Other indication for IV iron, when there is poor absorption of oral iron due to anatomic or physiological conditions, also during an inflammatory process, also when there is ongoing blood loss that exceeds the capacity of oral iron to meet the need. Also, in anemia, when there is anemia in the setting of reduced transferrin saturation below 20% and reduce the GFR below 60%, usually will respond to the IV iron. Also, when there is bypass gastric surgery or resection, this will reduce the gastric acid and may severely impair the intestinal absorption of oral iron. In this case, the IV iron is indicated. And also with malabsorption syndrome, celiac disease, Weber disease, and bacterial overgrowth. In the 2nd and 3rd trimester of pregnancy, also the IV iron is indicated. There are different formula available for the IV iron. We have high molecular weight iron dextran. We have the iron saccharose. We have the low molecular weight iron dextran. We have the ferric carboxymaltose, the iron isomaltoside, and also we have the furomoxetol. This study from Australia, the objective of the study is to determine whether giving the post-operative IV iron will improve the iron store and hemoglobin concentration and outcome following surgery. It is multi-center randomized controlled open label trials. 200 patients are involved in this study who are undergoing elective surgical procedure. The hemoglobin level was between 7 and 12 grams, and the ferritin level was below 100. A single dose of IV iron was given to the patient. The finding that fewer patients received transfusion in the IV iron group than in the standard care group, and the mean length of hospital stay was significantly reduced in patients receiving IV iron. Also, the IV iron treatment led to significantly improved the mean hemoglobin, the serum iron saturation, and serum ferritin level 4 weeks after surgery compared with the standard care group. The erythropoietin, it is a recombinant now available recombinant erythropoietin drug. It is indicated when there is a nutritional anemia has been ruled out and or corrected in patients with a chronic kidney disease or end-stage renal disease or cancer patient on chemotherapy. It is used conservatively with low dose and shortest administration time. And we should prescribe the iron throughout the course of the erythropoietin treatment as well to optimize the pre-surgical RBC production as well. This scheme will show you, or this diagram will show you that we should postpone surgery until patient no longer is anemic, especially in the elective surgical procedure, in the setting of elective surgical procedure in which the iron deficiency anemia is diagnosed and confirmed. And we have to correct the iron deficiency before proceeding with the elective surgical procedure. The expected hemoglobin optimization response to anemia treatment, most patients can expect to have a hemoglobin rise between 0.5 to 1 gram per week with the use of IV iron. Usually the response with iron, with oral iron is delayed. Of course, it is related to the GI intolerance or to the inflammatory diseases as well. That will reduce the iron intake. This is the recommendation from the 2018 Frankfurt Consensus Conference about the patient blood management, and this is published in JAMA. The first recommendation from the Frankfurt Consensus Conference that detection and management of preoperative anemia early enough before major elective surgery. And the second recommendation is the use of iron supplementation to reduce red blood cell transfusion rate in adult preoperative patient with iron deficiency anemia undergoing elective surgery. And also the third recommendation that don't use erythropoiesis stimulating agent routinely in general for adult preoperative patient with anemia undergoing elective surgery, and consider short-acting erythropoietin in addition to the iron supplement to reduce the transfusion rate in adult preoperative patient with hemoglobin concentration below 13 gram per deciliter undergoing elective major orthopedic surgery. In summary, depending on the cause and degree of anemia and the urgency of the procedure and the anticipated blood loss, surgery is postponed when feasible in order to determine the cause of anemia and to provide the appropriate treatment. Individuals with iron deficiency or iron deficiency anemia should be treated with iron, allowing adequate time for effect of a treatment before surgery, typically 2 to 4 weeks for correction. IV iron is an option if less than 4 to 6 weeks are available, and for patients with poor tolerance or an inadequate response to the oral iron. For individuals with anemia of a chronic disease or inflammation, we typically administer preoperative erythropoietin together with supplemental iron to avoid the functional iron deficiency in patients who are scheduled for surgical procedure with expected blood loss more than 500 ml if hemoglobin is below 12 gram, and also in patients undergoing cardiac surgery if the hemoglobin is below 13 gram per deciliter. Thank you very much for your attention.
Thank you very much, Dr. Bahrani. As usual, this is a very comprehensive and condensed lecture, straight to the point, and probably answered most of the questions that could come to mind, to the degree that we have no questions actually in the to address to you. Maybe later in the session. There is one question. Let me read it. In patients with multiple alloantibodies, especially with those with sickle cell anemia and difficulty to find optimal blood, we're using EPO with high dose, 150 to 300 units per kg. What do you think about that? This is a question from Dr. Al-Gadib. Sorry for the pronunciation in English.
For patients with sickle cell disease, already they have sickle cell production in their bone marrow. So giving erythropoietin and IV iron will increase the RBC of sickle RBC as well, mainly. So it can be used, but I don't think this is the ideal management of alloimmunization, the best is to find the compatible blood, normal RBCs. Usually they have sickle cell or hemolytic crisis or painful crisis related to the RBC that are sickled already. So giving erythropoietin and IV iron will not solve the pathological.
The question was about erythropoietin.
And sickle cell.
Yeah, yes, this was the only question. And I see that you are not in favor of this option. And there are also some concerns about thromboembolism in, in such, with such approach. There was some data about the use of this approach for, patients with malignancy as well, that it might carry harm sometimes. Well, with this question, with this answer, we will close this topic, and we may come back to you at the end. But for now, I would switch the microphone to my colleague, my great colleague from University of King Abdulaziz University, Dr. Maha Badawi. Dr. Maha has obtained her medical degree from King Abdulaziz University in Jeddah in Saudi Arabia. Then she completed all of her postgraduate training in internal medicine, followed by clinical hematology, followed by transfusion medicine at University of British Columbia in Canada, and she returned in 2014. Currently, she is holding the position of the Director of Blood Transfusion Services at King Abdulaziz University Hospital, and she has many research interests, including hemoglobinopathy, transfusion medicine, and donor recruitment, blood utilization. This session will be, some kind of testing the knowledge of transfusion medicine. So I'm assuming that it will be a semi-interactive session. So the floor is for Dr. Maha. Thank you.
Thank you, Dr. Mohammed. I'm really pleased to be among you today, and I'm very grateful to the organizing committee for inviting me to be part of this beautiful event. This talk is going to be completely interactive. I will need your help and interaction with me during this. So I will show you my first slide. It's basically, it's a group of questions. I need you to go to this website. Okay, I know some of you are watching from your phones, but if you can, go to this website. It's called menti.com. Menti.com. I am not sharing my screen yet. That's funny. 1 second. Okay. Okay, so I hope you can see my screen now. On top of the screen, you can find the name of the website. It's called menti.com, and then you will be guided to a screen where you have to type this code. So this is what the screen will look like. I hope you can see it. So this is the screen, and on the bottom you will find a space to type this code, and the code is 60256532. So the website is menti.com, MENTI.com, and the code is 60256532. And the code will be visible on every single slide. So I hope that that helps. So just to make sure that all of you are with me in this, this is my first question. Where are you right now? What city are you currently in? Excellent. So we're getting some answers. Your answer will immediately pop on the screen. So I'm looking for like 20, 30 answers before we move on. Excellent. So we have lots of friends from Riyadh, Al-Qasim, Jeddah, Hafuf, Al-Taif, Al-Ahsa, mashallah. So again, the website, it's called menti.com, and the code is 60256532. Excellent. Dawadmi, Qatif, mashallah. That's the beauty of online events. we can meet from all over the world with very little expenses. Okay, so we have a good number of people who were able to got in the website, and I hope you, all of you, even if you cannot get in right now, you can participate in later questions. So this was only my first question. It's definitely not related to transfusion medicine, but just to get you familiar with the program. So this is my first question. I'm starting with very, very simple questions. Not all of the questions are simple. So this is our first question. Now you should be able to see this question on your screen. What is the minimum acceptable hemoglobin for male blood donors? So the options are 12, 12.5, 13, and 13.5. Excellent. So, okay. So I'm gonna stop here. So the majority of you decided that is 13, and that's actually the correct answer. So this has been the answer for a while now, for a number of years, and it continues to be the correct answer. So the correct answer is 13. 13 is the minimum acceptable hemoglobin for male blood donors, which is corresponds to a hematocrit of 39%, while for females it's 12.5, and corresponding to a hematocrit of 38%. So that was the simple question. Okay, so here is another question. You get a blood donor with positive testing for anti-cardiolipin antibody. So that that donor had this test done as a patient. Now he's donating blood, and one of these tests on this list will be falsely positive. So is it going to be testing for HIV or syphilis or babesia or HTLV1 and 2? I love how this shows the results in real life. Okay, so we have a good number of answers, and the correct answer is, in fact, the syphilis non-treponemal test. So the trick here is the word non-treponemal. Syphilis has a number of different tests. Some of them are treponemal and specific, while some are not as specific, which are the non-treponemal tests. And among non-treponemal tests, the reagents contain the cardiolipin substance. So the reagents do contain this substance, and it might explain a false positive result on an non-treponemal syphilis testing. And definitely further testing is recommended to complete counseling of the donor and deciding if this infection is confirmed. So let's move on to another question. According to the most recent recommendations from the United States FDA and the ABB, what is the deferral period that is currently recommended after a donor gets a tattoo? Is it 3 months or 6 months or 12 months or 18 months? So now I'm referring to the most recent recommendations. Those are the recommendations that were put on by the FDA after COVID-19. So we have all sorts of answers. Okay, so the majority of you did not get this question correctly. The correct answer is, in fact, 3 months, which is shocking. If you still think that the correct answer is 12 months, which is the way it used to be. That's the way it used to be before COVID-19. After COVID-19, the FDA decided to revise all of its recommendations in regards to donor screening and acceptability criteria, and decided that 12 months was extremely precautionary and that 3 months were adequate in that regard. And the statement now reads, defer for 3 months from the most recent tattoo, ear, or body piercing, an individual who had a history of a tattoo, ear, or body piercing. However, they have another exit. You can actually accept them earlier with no deferral if they got the tattoo by a state-regulated entity with sterile needles and non-reused ink. Individuals who have undergone ear or body piercing within 3 months of donation are eligible to donate without deferral if the piercing was done using single-use equipment. So For us in Saudi Arabia, we have to wait for further recommendations from the Ministry of Health and regulatory bodies before we implement this change. However, it is coming. This is the QR code. If you want to read the whole recommendation, you can go to the website of the FDA and read the whole recommendations. This is a QR code to make it easier for you to get there. Okay, so I'm now going to ask you a question about post-freezing RBCs. So red cells can be frozen for those of you who are not exposed to frozen red cells, because that's not a routine practice. So red cells can be frozen if they were rare, and they can be frozen up to 10 years using glycerol with a concentration of 20 to 40% at temperatures that range between -65 to -120. After we thaw these red cells, glycerol has to be removed, okay? So glycerol has to be washed out of the red cell. And the question is why? Why do we need to remove the glycerol from frozen red cells after thawing? Is it because it causes anaphylaxis? Does it cause hemolysis, thrombocytopenia, or is it nephrotoxic? Okay, so the majority of the responses come as it's nephrotoxic. We're still going to get some more responses. I'll wait for a few more. Okay, so the correct answer is in fact hemolysis. So glycerol causes hemolysis because it has a different tonicity from blood. So it is not known that it is nephrotoxic, and it's not documented that it causes anaphylaxis or causes thrombocytopenia. The most important side effect is hemolysis, and that's why it has to be removed from frozen red cells. Okay, so this is an important question if you have pathogen inactivation technologies in your blood bank. It definitely adds a lot of safety to our processes, but it does not act on all pathogens. So which of the following pathogens cannot be inactivated using pathogen reduction technologies? And you have hepatitis C as an option, Trypanosoma cruzi, MERS-CoV, and bacterial spores. And I put this question here just to remind ourselves, the blood supply will never be 100% safe or free of infections. And that's why we have to use the patient blood management principles as described by Dr. Ahmed just before this lecture, because the risk will never be zero. Okay, so that's a very interesting distribution of answers. And there are a number of pathogens that cannot be inactivated using pathogen reduction technologies. On this list, the correct answer is, in fact, bacterial spores, which most of you picked at this point. MERS-CoV, we have good literature from Saudi Arabia by our teacher, Professor Salwa Hindawi, about inactivation of MERS-CoV using pathogen reduction technologies. And there is a good literature about hepatitis C and Trypanosoma cruzi inactivation. So there are a number of pathogens that are not, may not be completely eliminated or inactivated using pathogen reduction technologies. And these include hepatitis A, hepatitis E, parvovirus, prions, and bacterial spores. So keep those in mind whenever you are thinking about risks of infections, even from bacterial pathogen inactivated platelets, for example. Okay, so you have a number of blood components. Which of them need to be irradiated? Which of them should definitely be irradiated? Is it apheresis platelets, whole blood, granulocytes, or I think I had stem cells as the fourth option. So which one would you pick? Which one definitely needs to be irradiated? Okay, so we have a good number of responses here, and okay, We have a changing scene here. So the correct answer is in fact granulocytes. You definitely do not want to irradiate stem cells. They will lose their effectiveness. Whole blood itself, just because it's whole blood, is not a reason to for irradiation. However, for whole blood and for apheresis platelets, it really depends on the recipient. So let's take a closer look at this. So irradiation of blood component is indicated, has a single use, a single benefit. It's one of the few things in the blood bank where we say the benefit of this is only prevention of transfusion-associated graft versus host disease. And it has a number of indications. It's definitely indicated when the transfusion recipient is immunocompromised. So if you're giving whole blood or apheresis platelets to an immunocompromised patient, then yes, you need to irradiate those. But if the patient is immunocompetent, then there is really no need, just because it's apheresis platelets. It is indicated with HLA similar components. So if your patient is platelet refractory and you got those platelets from an HLA matched donor, then those platelets, yes, they need to be irradiated because the HLA is similar between the donor and the patient. And it is indicated with all granulocyte components. So just reminding you, this is a board review. So you might not see all of these in your real life, and that's okay, but they can come in questions. Okay, which of these is a reason for a permanent deferral of a donor? So if a donor comes in, they have West Nile virus or had Lyme disease or Babesia or CMV, what would be a reason to say, sorry, you can never donate in the future? Okay, how many minutes do we have, Dr. Mohammed?
We do have another 5 minutes.
Okay, but whenever time is up, we can just stop, because we are very flexible in that way. So the correct answer, we're getting answers all over the options, and the correct answer is in fact babesiosis. So if the donor had a history of babesiosis, they can never ever donate in the future. In regards to the other infections, and I understand these are not very common infections in our part of the world, but we need to know them. So for Lyme disease and for CMV, both donors can donate after they become asymptomatic. Babesiosis results in permanent deferral, and for West Nile virus, the recommendation is 120 days after diagnosis or 120 days after symptom onset, whichever later. Okay, TRIM. This question is about TRIM, transfusion-related immune modulation. Transfusion-related immune modulation is a complication of transfusion which was described over the past number of years, and it is thought to explain one of these statements is correct. So I just need you to pick up the correct statement. Does it result in does transfusion cause reduction in graft rejection after kidney transplant, or does it result in a reduction in the rates of post-operative infections, or are transfusions associated with an increase in spontaneous miscarriages or cancer? Does it result in a reduction in tumor recurrence? And most of you picked the right answer. So yes, it was noted in patients post-kidney transplant. Those who were transfused more had lower rates of rejection, suggesting that transfusion might be associated with an immune suppression effect. So basically, let's just talk about TRIM for a second. So TRIM, or transfusion-related immune modulation, basically we think that transfusion is a liquid allogeneic transplant causing changes to the immunological profile of the recipient. And such changes could be pro-inflammatory or immunosuppressive, and the immunosuppressive effect is clearly visible in the effect in kidney transplant recipients. transfusion is associated with an increase in tumor recurrence and is associated with an increase in risk of infections during hospitalization. It is associated with a reduction in the risk of spontaneous miscarriages. So let's take one question before we stop. Okay, so in 2019, new definitions were published for TRALI, describing TRALI type 1 and TRALI type 2. And my question here is about the main differences. What are the differences between TRALI type 1 and TRALI type 2 according to the 2019 published definitions? Is it the time of onset after transfusion, or is it the presence of ARDS risk factors, or is it the degree of hypoxemia, or is it, I can't see all the options, but you can see them. Your findings. So let me talk about TRALI for a second. So we had the Canadian Consensus Conference definitions from 2004 for TRALI, and we were following these for a very long time. And then the critical care community changed their acute lung injury definitions. There is no longer in critical care literature, there is nothing called acute lung injury. Now it's mild ARDS, okay? And based on that, based on all the literature that was published on TRALI, a new paper was published in 2019 attempting to redefine TRALI or improve the definition that was already there. So previously we had TRALI and we had possible TRALI. Now we don't have anything called possible TRALI. We have TRALI and we have TRALI type 1 and TRALI type 2. And you picked, well, we have a tie. The difference between TRALI type 1 and type 2 is the presence or absence of ARDS risk factors. So I'm going to just show you the new definitions. So TRALI, basically, it has to be of acute onset. There has to be evidence of hypoxemia, bilateral pulmonary edema on imaging, no evidence of left atrial hypertension or volume overload. And it has to occur during the transfusion or within 6 hours of the transfusion. For type 1, patients must have no risk factors for ARDS, and there has to be no temporal relationship to an alternative risk factor for ARDS. While type 2 are patients who have risk factors for ARDS or had mild ARDS but deteriorated in relation to the transfusion. And in order to confirm that they were, this is temporarily associated with the transfusion, they needed to have a stable respiratory status in the 12 hours before the transfusion. So it's interesting to see how these new definitions will help us during our clinical work as we see these cases reported in order to be able to define which is which. Shall we take another question, Dr. Muhammad, or is time up?
Well, actually, the time is up.
Time's up, okay.
But because you don't have questions after your talk, your talk is actually questions, you may take another 2 minutes.
Okay,
so
we'll just take one question. So this is my last question. So thank you for the generosity. This is my last question. So as you know, in patients undergoing therapeutic plasma exchange, we have the option of choosing the replacement fluid. So we either use albumin or plasma or normal saline. The question is, in which of these 4 diagnoses would you prescribe FFP as the replacement fluid of choice? And I know I did not put TTP on there because TTP would be the very obvious answer. There is another diagnosis on this list where FFP is the replacement fluid of choice according to the ASFA guidelines of 2019. So yes, most of you picked the right answer, and the correct answer is in fact catastrophic antiphospholipid antibody syndrome. And this was one of the major changes, for me at least, in 2019 version of the ASFA guidelines. They recognized that in addition to removal of the antibodies in catastrophic antiphospholipid antibody syndrome, you really have to replace the natural anticoagulants, protein C and protein S and others. And that's why FFP now is the replacement fluid of choice for patients undergoing therapeutic plasma exchange. And that concludes my slides. And I'm really grateful for being interactive. And thank you so much.
Okay, thank you for this great interactive session, Dr. Maha. And I think we all shared the fun of having the questions and answering them. And such sessions usually people don't get enough of them because they're the interactive ones that really keep you thrilled all the way. And now our great colleague, Dr. Ammar Sghair, I want to switch the floor to him for his final talk of the day. Dr. Ammar, as many of you know, is a distinguished hematopathologist and transfusion medicine consultant who graduated from medical school at King Saud University, and then he finished his fellowship in hematology from the same institution. Then he completed a fellowship in transfusion medicine and bone marrow transplant in the University of Ottawa in Canada. And currently he's a consultant in transfusion medicine and hematopathology, as well as chairperson of Transfusion Medicine Service, Department of Pathology and Clinical Laboratory Medicine at King Fahd Medical City in Riyadh. Without any further delay, I would hand him the microphone, and the floor is his.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank Dr. Mohammed Mohammadi for his nice introduction, and we wish him a very speedy recovery from his illness. And we thank you, Dr. Mohammed, for taking the efforts of chairing this session despite your medical issue. Thank you very, very, very much. We all appreciate that. And I would like to present the plasma utilization and plasma derivatives. Plasma is very important product in our practice, and it is in the developed countries very precious component where we derive derive all the plasma derivative. I mean the albumin, the IVIG, the fibrinogens. Many plasma-derived products are manufactured from this plasma. But it is very precious product, and the time will come soon where we will be, very meticulously managing this plasma to direct all our plasma to fractionation, and we hope this day come very soon. During my how to move the I'm pressing enter بس ما just bear in mind دقيقة. Thank you. This is my facility, King Fahd Medical City, very big, one of the largest facilities in the kingdom, almost 1,200 bed capacity. very busy practice. In my presentation, I will talk about the plasma products and the different types of plasma and the dose and volume and the utilization and the effect of coagulation test. And very importantly, we will talk about the inappropriate utilization of a plasma. And all these, we talked about the plasma as a coagulation replacement. But at the end, we also will talk about plasma as immune replacement therapy. Plasma we get, you all know that we get plasma from either, it is a frozen, and we get it in this component from donors, either apheresis or whole blood. But from this plasma also we can get different components that help the coagulation replacement. For example, prothrombin complex concentrate, we'll talk about it briefly. And so cryoprecipitate and fibrinogen concentrate also are derived from plasma, whether cryo or fibrinogen concentrate, lyophilized product. The plasma product we get in our practice in the hospital setting, it either come from apheresis, which is typically collect almost 500 to 600 collection in one time, or whole blood derived, and we can get 250 ml. And also we can expose as pathogen-reduced plasma. This is getting into the market and into the practice gradually. Many centers, they utilize the solvent detergent plasma, and many companies provide that. For example, the Octopus is one example. The plasma, we get it either from one single donor, whether apheresis or whole blood. And this is compared to pooled plasma, which we'll talk about in the second slide. It is one unit, we get it from one donor, and it is available group specific, blood groups available. AB is the universal donor. The advantage of having this plasma, which we all manufacture in all the blood centers in the worldwide and the country, it is easy accessible and available, the local plasma. We can get whatever we have from the donors, and standard technology from safety point of view, it is only applies the testing and donor selection. The disadvantage compared to the other plasma, like the Octopus or the pooled or solvent detergent plasma, the quality varies according to the center, and the availability depends on the donation process, and the supply depends on whether you have campaigns or not. Pathogen safety only guaranteed by testing or quarantine. There is no pathogen elimination. Compared to the pooled plasma, which we get from hundreds and thousands of donors, and we pool the plasma from those donors in one pot, and this pooled plasma, same thing, which issued and manufactured group specific, same like AB is universal. It goes into under pharmaceutical manufacturing process. This process, plus having a reduced risk of pathogen transmission by having the pathogen removal process at large scale in pharmaceutical basis. It also passes through regulatory approval and complex technology, but it is somehow more expensive. The pathogen-reduced plasma is getting into the centers also, many centers now in the kingdom and in many countries like in Europe and in Canada, they are implementing nationwide pathogen reduction technology. There are available companies or technologies that expose these plasma that we manufacture locally into a pathogen-reduced technology at the hospital level. The SD plasma is manufactured outside the hospital at a very large industrial basis. But the BRT, we are exposing the plasma that we collect locally into pathogen-reduced technology. The available technologies now, they use the amoxicillin or riboflavin, these are the major two companies available in the market. Beside adding the amoxicillin or riboflavin, then this what it will do, it will interact with the DNA and RNA of the cellular components in the blood product, especially plasma or platelets. Then after exposing this product into UV light, This will damage any residual pathogen or white cells. This is the differences between the two companies, the major companies available. For example, the volume is very similar. The loss, there will be some loss of coagulation factors during the process. There is some differences in the processing time, some longer than the other. But overall, some of them is FDA approved, the others are not. The solvent detergent plasma compared to also the solvent detergent plasma, which is done at very large industrial bases, done in few countries in the world. Not every country have it. For example, the Octaplus compared to methylene blue plasma product. Similar principle where you add material to the plasma, so it will inactivate and eliminate any residual lipid enveloped viruses or protozoa or bacteria. For example, it's the Octaplus, which is widely available in the country. The Vonwell brand, there will be some reduction in the coagulation factors with minor differences between the two technologies. Prothrombin complex concentrate is stored and issued in the pharmacy, not in the blood bank. It is derived from the plasma at industrial, it will go through fractionation process. It contains a balanced coagulation factors, for example, factor 2, 7, 9, and 10 with 1:1 ratio. It has very good therapeutic levels of protein C and protein S, some amounts of antithrombin. With very small amount of factor 7A. It is used mainly now, it is used for to replace plasma for the reversal of warfarin overdose, especially in patients with bleeding. This is the main license indication for this product. The difference between this and the plasma, the BCC, it is pooled and virally inactivated, bromine reduced, lyophilized product, and it is the volume 40 to 80 ml. It is infused over at a 40 ml per 5 minutes. The plasma that we have at the hospital, which is not pathogen reduced or is not solvent detergent, it is not virally inactivated. It requires blood group compatibility. Volume is, the adult dose is almost 1,000 ml to raise the coagulation factors. It has infectious transmission risk compared to the BCC. Cost is very similar if you utilize one adult dose. But safety issue is a drawback in the plasma. These are the common therapeutic indications for plasma transfusion. To summarize, there are complex deficiencies of coagulation factors, multiple deficiencies of coagulation factors where one single replacement therapy is not available. Substitution therapy in single coagulation is not available. Rapid reversal of oral anticoagulant, and the use of a plasma in therapeutic plasma exchange, for example, in TTP or other diseases. The blood compatibility, blood group selection, we don't worry or we don't bother about the RH, but very important blood group compatibility. AB is the universal donor, O is the universal acceptor for these types of plasma. The plasma transfusion, there are many transfusion guidelines available, but there is little evidence to guide the current use. Many large number of transfusions are considered inappropriate by these guidelines, and we'll talk about the inappropriate use. And also the transfusion guidelines and practice variable between centers and between physicians. But many studies have looked at the transfusions of plasma in many countries like Canada, UK, Finland, and they found that the inappropriate use of plasma transfusion constitute percentage for up to 66%, 2/3 of transfusion of plasma are considered inappropriate. These unnecessary transfusion has also the plasma, it is not without side effects. Side effect can be trali, can be infectious transmission. So we have to be very careful on these plasma transfusions. The complication range from mild allergic reaction, pose some discomfort to the patient, and they consume a lot of nurses' time to infectious transmission to fatal issues like trali. So it is not without side effects. These are summary of the side effects we can get from plasma and animal transfusion reaction: allergy, viral transmission, anaphylaxis, volume overload, citrate toxicity in massive transfusion. Many guidelines are published over the past many years. These guidelines are non-evidence-based or lack sufficient detail to guide the practice. Typical recommendations such as those by the Canadian groups or Finnish or the Australian and the British also, we'll talk about them. These guidelines, they are common. For example, the Canadian recommendation regarding plasma transfusion, they advocate the use of plasma uniformly in the clinical, if you read the clinical setting, uniformly when there is a clinical active bleeding. It is not advocated as a prophylactic therapy to prevent any bleeding. And associated with this active bleeding, you have also with or without significantly prolonged coagulation parameters, BT or BTT. The same thing for the British standards, which is published recently also. All of them, they are advocate the use of plasma for bleeding with prolongation of BT and BTT. For example, during massive transfusion, the urgent reversal of warfarin to stop bleeding pre-operatively, acquired coagulation factors, plasma for TTP and others. TTP is, when it comes, it consumes a lot of your plasma at the inventory. The treatment can take up to 30 units for 10 days to 30 days sometimes. TTP is a rare disorder. There is Adamas 13 deficiency. It can be deficiency or antibody. So this one case in particular consumes a lot of your inventory, which is, it is considered by ASFA guidelines a category 1. The level of evidence for using plasma in this type of patients is very strong. Also, one of the indications nowadays for the use of plasma is during massive transfusion. And many studies from the American combat and from American soldiers, they to try to include the plasma and plasma products in any massive transfusion protocol to have a ratio of 1:1:1. And they found that they have those who have high, like the curve in the top, these have high platelet and FFP component. And you see that very associated with very good survival. So what will happen? What do the INR, the BT and INR have an effect on the coagulation factors, and what the plasma will do? Once the BT and BTT begins to prolong out of normal range, the coagulation factors start to, they already reach 30 to 50% of normal. So the prolongation of BT and BTT up to 1.5 times the midpoint of normal range, this corresponds to coagulation factor level of 20 to 30. So it is not usually associated with spontaneous hemorrhage in these types of patients. And the risk of bleeding is only greater if there is associated risk factor like low platelet or low fibrinogen as well. So what will what these have an effect on the coagulation factors? As you see, the BT begins to lengthen when the factors go to 25% low. EBT-TT, it is also going to be prolonged when factor 5 goes below 45%, and 2 or 11 will go below 40%. Similarly, the other coagulation factors will go to less than 25% normal. Plasma is, one of the commonly prescribed medications worldwide. The goal of this type of plasma is to raise the coagulation factors, and this will, what you wanted to have the coagulation factors around 30%. And with a dose of 10 to 15 ml of FFB per kilogram, this will bring the coagulation factors to a very good hemostatic levels. The adult dose is almost 1,000 plus or minus 200. And now we'll talk about the appropriate utilization. The most frequent reason for this inappropriate is to correct a mildly prolongation of INR and BTT. The many studies, that looked at in this study in particular, the use of FFB in critically ill patients, 1/3 were consistent with the guidelines, 20% were inconsistent but appropriate, almost half were inappropriate according to their guidelines. For example, this is the similar, to this summary of these numbers. They review these types of almost 1,225 FFB orders, and they found they divided according to the INR more than 1.5, so it was considered with or without bleeding, INR less than 1.5, with or without bleeding, and those who have no active bleeding, consider 26% of those with INR less than 1.5. So it is not really indicated to give. And among that, there is no planned or there is no invasive procedure. So this is the summary. And so this is the effect of plasma transfusion on INR. And you see that in this curve, most of the transfusions are located at an INR less than 2. And in the axis, there is a decrease in INR. Those who would have INR of less than 2 or less, the amount of INR correction after plasma transfusion is very minimal, not very significant. Some have no change. For example, when you have this 0, it means that after plasma transfusion, there is no change in the INR. So, and you see, most of the transfusions are centered around INR of less than 2. Similarly, this is a graph of the previous slide. So this is another study that looked at the effect of FFB transfusion on prothrombin and bleeding in patients with mild coagulation factors. They look at all patients transfused with FFB, and they looked at they checked the pre-transfusion prothrombin time and INR, and they follow up these patients 8 hours after. Of the almost 1,100 units of FFB transfused, they follow up, they get the data for 324 units, almost 120 patients. So what they found that they normalized the BT INR in only 0.8% of patients, i.e. 99% of the cases, they didn't correct the INR on BT. The decrease in BT INR halfway in 15%. Median decrease in BT was 0.2 seconds only in all these cases. So 99% didn't correct and didn't have an effect. The British, also the British advocate, the British standard, the British Society of Hematology, they advocate not to transfuse plasma to correct mildly prolonged INR or less than 1.8. This is another study, very large. This is complication following percutaneous liver biopsy. A very large study looked at almost 70,000 percutaneous biopsies published some time ago, and they found that bleeding only occurred in 1 out of 1,600 patients. This is the INR of these patients. So this British Society of Hematology, they endorse the Liver Society recommendation that prophylactic transfusion of FFB and cryopyrin is not given at low risk, globally the risk procedures such as paracentesis. And there is no good evidence to support a role for prophylactic FFB to reduce the risk of bleeding from percutaneous liver biopsy. The asymptomatic high INRs, some recommendations, INR, the therapeutic indication, Australia and New Zealand, INR more than 10, they still advocate the use of non-plasma products, vitamin K, for example. American College of Chest Surgeons also vitamin K oral, not IV. British Committee, same, vitamin K without bleeding. Now we'll shift gears to plasma as an immune replacement therapy. We did cover many slides about plasma to correct coagulation deficiencies, to stop bleeding, and so on and so on. Some time ago, before, since the MERS, COVID, the use of plasma, and many before, the use of plasma to boost the immune response against certain diseases. During this COVID pandemic, the use of convalescent plasma arise strongly, and the FDA early that time, they issued emergency use authorization for convalescent plasma as a potential treatment for COVID-19. Our country participated also in very large nationwide study for the use of plasma in this disease, and many centers have been participating. Many of you did participate heavily in this study. But this is a summary of the use of convalescent plasma that came, after the pandemic, after many collected evidence occur and collected to how whether the use of convalescent plasma was effective against COVID-19 or not. And in summary, all of these studies, they said that the use of convalescent plasma may have little or no effect on mortality. But the evidence so far is not certain. Most of the studies share the same recommendation. Another large study that looked at very systemic review and meta-analysis of the use of convalescent plasma treatment in COVID-19, and they found their conclusion that convalescent plasma compared to placebo was not significantly associated with decreased all-cause mortality or with any benefit for other clinical outcomes. And this is the summary of our study also. But this is a detail, but it shows how the product was promising at that time. We developed some experience. We reached to the conclusion similar to other centers, but technology may occur that improve the collection, the indication. Like we have IVIG, maybe you will have specific immunoglobulin against certain disease. This is my last slide, and appreciate all your listening. Thank you.
Thank you, Dr. Ammar, for this great presentation. And it was a great closing for this really prestigious and well-prepared event today. And looking at the questions, I can see only deep thanks for your great efforts. And that's probably the only thing that is in the question box. Most likely due to the very comprehensive, very clear talk that you have just given. So now for the closing remarks, I will hand the microphone to you.
Thank you, Dr. Mohammed. And I would like to thank, on behalf of the SSBMT President, Dr. Ahmed Al-Askar, and all the SSBMT board members, I would like to thank all the attendees, the almost 900 plus attendees, and the Zoom and the physical attendees in the podium, in the floor here. I would like to thank the moderators and speakers for their efforts to bring this program. It is very honored. I'm very honored that we all participated in this event, and we advise you to follow our accounts, the SSBMT Twitter and all media accounts, to follow the next activities, which will be very busy in 2022. And we all looking forward to see you in person in in 2022, inshallah. And with that, I would like to thank everybody again and thank the secretarial support from Noor and her team who brought this hybrid event, which is very difficult to coordinate, and was brought very nicely and professionally, really, to everybody without any issues. And thank you again very, very much. With that, assalamu alaikum.